Hello, good morning. I think we should start now. Almost 100 delegates have joined online. Good morning and a warm welcome to all the delegates uh, attending physically, as well as all the delegates that are those who are attending online. I welcome today's faculties, Dr. Suhas Hardas sir, Dr. Manoj Bhise sir. I also welcome cardiologist Dr. Sachin Lakde sir. Friends, today we have this CME in two sessions. In the morning session, we will be covering recent advances in cardiology, and in the afternoon session, we have advances in endocrinology. For the whole day, we have renowned uh, speakers from Sahyadri Hospital, Pune. Today in the afternoon, we have the most prestigious installation ceremony of our incoming president, dynamic lady president, Dr. Meenakshi Deshpande, madam. This ceremony will start at 11 o'clock, and Padma Vibhushan, Dr. K. Sancheti sir would be the chief guest, and Mr. Vikram Kumar, the Commissioner of PMC, will be the guest of honor for this function. So before starting the first session, I would request our President, Dr. B.L. Deshmukh, to give his opening remarks.
Good morning, everyone. I welcome you all for this CME on advances in cardiology and endocrinology by the Sahyadri Group of Hospital. We have eminent speaker from Sahyadri Hospital Group. We have long association with the Sahyadri Group of Hospital. He is our academic partner. I hope and trust this association will remain in future years together. Thank you.
Thank you, Deshmukh sir. Now I request Mr. Hemant Bapat from Sahyadri Hospital to tell us about the Sahyadri Group of Hospitals.
Thank you, sir. Good morning, sirs. A very good morning to all. First of all, for Sahyadri Hospital's installation of IMA CME is like a tradition. For so many years, we have been associated with it. And so I really, from my bottom of my heart, would thank to IMA Pune team for considering us as a permanent partner for this IMA installation CME every year. I would not take much time. It's a long day today, but then I would like to highlight something about Sahyadri Hospitals. The Sahyadri Hospitals with 8 hospitals, more than 2,000 clinicians, 2,600 staff, and more than 80 lakhs lives touched. Today, Sahyadri Hospital is Maharashtra's largest chain of hospitals. It's based on philosophy of medical care made quality care made available, accessible, and accountable. And the journey started way back in 1994 with the establishment of Pune Institute of Neurology, which was the then only neurological institute, which was basically catering to tertiary care neurological treatments. And then it was transformed in 2004 into the very Sahyadri Super Specialty Hospital, Deccan Gymkhana, which is our flagship hospital. And then the journey continued. In 2006, we established our first community hospital at Kothurud. Then the second community hospital came up in Bibewadi. And in same 2009, our first super specialty hospital out of Pune, that's in Kara, Karad, which is one of its kind tertiary care facility in the entire southern Maharashtra, came up in 2009. In 2013, we started a Surya Sayadri Hospital. It was a community hospital, secondary care, and now it is transformed into a tertiary care hospital soon. A radiation unit is coming up in Surya Sayadri. And talking about Surya Sayadri Hospital, it was the first hospital, first private hospital to be dedicated 100% for the underprivileged under Ayushman Bharat scheme. Also, in the same 2013, our Nagar Road, which is the second super specialty hospital of the group, started, which is a center of excellence in IVF neonatology. In 2018, our third super specialty of hospital in Hadapsar started. We were there in Hadapsar in the form of secondary care hospital. It was transformed into a super specialty tertiary care hospital. Now it is a center of excellence in oncology. In last 2 years, because of pandemic, it was very challenging. But then today, in last 2 years, we have transformed the Deccan Super Specialty Hospital. We completely renovated building with additional 100 beds is up and running. And next year is very challenging for us, where we are actually going to add more than 250 beds in our existing hospitals. These are our hospitals. So key milestone I would definitely like to highlight, we are the pioneers and leaders in neurosciences in the state of Maharashtra. Center of Excellence in Neurosciences, Hematology, Cardiac Sciences, Organ Transplants, Oncology, and Endocrinology. It is India's one of most leading bone marrow transplants program, and we have done more than 800 bone marrow transplants. Also, we are the fastest growing liver transplant center in the entire Western India, and we have recently completed more than 250 liver transplants. Also, with this, we have 5 liver transplant centers across our group: Deccan, Nagar Road, Hadapsar, in Pune, as well as Nashik and Karad. And one thing about Karad is, in Karad, it is the first liver transplant center in a taluka level in the country to have a liver transplant center. Talking about cardiac care, the main agenda for this session, the Center for Advanced Care at Sayadri Hospital is a center of excellence in advanced cardiology, cardiac surgery, pediatric cardiology, and pediatric cardiac surgery, as well as heart transplants. It's a leading referral center for complex cardiac conditions, performing advanced procedures like rotablator, IVUS, and post-MI-BSD. Also, it has a dedicated heart revival clinic for advanced diagnostics for heart failure, as well as varied treatment options covering advanced medical management, including ECMO, device therapies, and heart transplants. Of course, I would like to share some acknowledgements. We were awarded Guinness World Record for maximum organ donation pledges in 8 hours, which was a collaboration with Rotary, Pune. Also, we were listed in Economic Times as Best Asian Healthcare Brands in 2017 as well as 2021. Also, we were awarded the Best Hospital in Organ Donation by NOTO, which is National Organ and Tissue Transportation Organization. Also, Best Hospital in Organ Transplant by Navbharat Excellence in 2018. Recent updates, so we are basically migrated to single number 5 times 8, 5 times 2. So if a patient wants to get connected to Sayadri for any hospitals, they just have to dial one single number, that is 5 times 8, 5 times 2. Recently, we have basically launched our robotic orthopedic joint replacement facility, where it's a portable robotic facility, where it is available at Deccan, Nagar Road, as well as Hadapsar unit. And soon we are going to launch a dedicated mother and child care center at. This is up from me. Thank you so much. I'll hand it over the proceedings to IMA.
Thank you, Mr. Hemant Bapat. Now we'll straightway go to our first session of advances in cardiology. This session will be moderated by renowned cardiologist Dr. Suhas Hardas sir. Dr. Suhas Hardas sir is the Director of Cardiology at Sayadri Hospitals. He is a renowned senior cardiologist in the city of Pune. His outstanding skills in complex angioplasties, device implants, and various forms of cardiac therapies are well known to the entire world. He is a gold medalist at various levels. He heads the Department of Cardiology at Sayadri Group of Hospitals. He is a national and international faculty. Under the aegis of Hardas Heart Foundation, as a corporate social responsibility, he and his team is involved in training general public about healthy heart lifestyle, cardiopulmonary resuscitation, screening and treatment of special children for congenital heart diseases in projects like Vardhan and Adhikar. With this short introduction, I request Dr. Suhas Sardas sir to give his first talk, which is on approach to the patient of chest pain and what's new in cardiology. To chair this session, I request another renowned cardiologist in the city, Dr. Sachin Lakde, to chair the session. Lakde, sir, please. Sound is not clear as a message, please. Sachin Lakde, sir, you can come on dais and chair the session.
Green color, sir. Good morning, ladies and gentlemen. It's a pleasure being here after a century. I used to be a frequent flyer in this area once upon a time when I began my practice approximately 21 years back in the city of Pune, having come back from Australia. And I think I conducted close to 14 lectures back to back about how to read ECGs for family physicians and general practitioners. And after that, I was an infrequent flyer here. I came here for a few lectures and there has been a big gap, possibly also because there was a pandemic during this last period of couple of years. The audience here is a mixed bag of clinical practitioners, and I know that we have to be addressing a talk and the contents must be appropriate and must cater to everybody. I thank Sahyadri Hospitals for having given me this opportunity to take the Department of Cardiology a little ahead of what it is today. And I have been Director of Cardiology of the entire group of hospitals for the last 8 months. The best part of this hospital since the time I've been here is that they have a great outreach to every area of the city. And earlier it was going to be a spoke and hub kind of a model. And the peripheral hospitals were going to be smaller hospitals, predominantly pickup points for the patients to be brought to a tertiary hospital. But this concept soon changed to making sure that the tertiary hospitals are present not only on Karve Road, but also in Hadapsar, Nagar Road, etc. And now they are fully equipped, full-fledged, fully staffed with good consultants manning these hospitals. I'm very happy to also announce that Dr. Manoj Bhise, who is one of the ace echocardiologists, and by choice, he has opted to be a non-invasive cardiologist. I think out of a breed of 100 cardiologists who come out of training, now I don't even see a single cardiologist who wants to be a non-invasive cardiologist. It takes a lot of courage. It takes a lot of effort to become a non-invasive cardiologist for obvious reasons that I need not cite them here. But I think he is heading our department of non-invasive cardiology, and his knowledge of echocardiography has transformed the reporting that we give to patients of cardiology who have echocardiographies in our institute. You will soon find out from him when he talks to you about how to read. For the practitioners, when you get an echo report, त्याच्यात काय बघायचं, त्याच्यात काय बघायचं नाही, काय रेलेव्हंट आहे, काय इरेलेव्हंट आहे, हे कसं जाणून घ्यायचं ह्याच्याबद्दल मला वाटतं डॉक्टर मनोज भिसे तुम्हाला सांगतील. आय एम ऑल्सो very happy that Sachin is moderating my session. Sachin used to be a student when I used to visit Bharti Hospital. I have taught him cardiology, and I think the infusion of interest in cardiology was first from my side to him. And today he's a very successful cardiologist, and I want all of you to put your hands together for Sachin as well. Instead of going into the details of the jargon of what advances we have made in cardiology, I'm going to come to a very, very simple topic today. And that is probably relevant to a lot of you, because you cater to these patients as a first information report. The FIR of a patient is lodged with you. He comes to you with the first symptom. And then it is your job as a family physician, as a general practitioner, to send that patient to the appropriate facility, to the appropriate consultant. And I personally feel that our jobs as cardiologists is much simpler. We deal with ischemic heart disease when they have been diagnosed by somebody like you, and thereon it is much simpler. But for you to filter out exactly what is cardiac, what is musculoskeletal, what is respiratory, what is gastrointestinal for a simple symptom like chest pain, which can have varied etiologies, varied reasons, is a huge task. So salute to all of you once again. Coming to the topic, how do I go on the presentation mode here? If somebody can help me. So it's on the presentation mode. So that's fine. Yeah, here it is not. That's fine. My job as a first lecture is to bring to you how, when a patient of chest pain comes to you, how do you triage it? How do you sort it out? How do you group that into gastrointestinal, respiratory, cardiac, or something else? When you look at the various causes of chest pain, you have multiple causes. In fact, you'll be surprised that these are only 1/3 of the causes that I have listed here. There are many, many, many more causes which I can fill here and make the entire list extremely crowded. But my job was to pinpoint the reasons of chest pain, which can be very sinister, which can be very lethal, which can be dangerous in your clinic. Dangerous from the point of view of life of the patient. And these are highlighted in the red color. Acute myocardial infarction, dissection of aorta are the cardiac or the cardiovascular causes of chest pain, which can kill a patient just as you are examining, or just after you have finished examining, or just when you are about to send that patient to a bigger facility. So your job is to find out whether there is an acute myocardial infarction or there is a dissection of aorta. Other causes of cardiovascular chest pain are, I wouldn't say rudimentary, but are not as important from the patient outcome. And you can take your time. You can call the patient once again for a follow-up visit. You can get few more investigations done, whether it may be an X-ray, CT scan, MRI, and then come to a diagnosis of chest pain or the etiology of the chest pain. The second important group which can cause chest pain is the pleuropulmonary. In pleuropulmonary causes, two sinister and the most lethal causes that are there are the pulmonary thromboembolism and pneumothorax. Other causes like pleural effusion, intrathoracic tumor, they are absolutely very, very important. They must be diagnosed appropriately, but they are not going to kill the patient in your clinic. The third group is the musculoskeletal group. In this, it's a mixed bag. Once again, we have variety of reasons to have chest pain. And the last important one is the acid peptic disorder or the gastrointestinal causes of chest pain. Now, there is only one condition in the gastrointestinal causes which can be lethal. And in my entire career of last 32 years of cardiology, I have come across only one such patient who has had esophageal rupture following a transesophageal echocardiography, because the patient already had an underlying problem. But otherwise, this is very rare. Coming to the first group, that is the cardiovascular causes of chest pain. The most important group is the ischemic heart disease. How one would present? One would present with a squeezing discomfort in the center of the chest. typically, and since I've taken this figure from an atlas where it was an Englishman, this is not a typical situation in our country, that person walking out of the pub or walking out of the restaurant on a cold, windy night. No, these things don't happen here. But yes, if somebody reports to you a typical retrosternal discomfort, which is compressive in nature, pressure-like, vice-like, radiating on the inner side of the arm along the ulnar border to the tip of your fingers, one can suspect this. Now, acute myocardial infarction, as I said, the symptoms are very, very typical. It's a constricting, choking, pressure-like discomfort. It is not a pain which is pinpoint. It is not a pain which is very focal. It is not a pain which is localized. It is more diffuse. It is more retrosternal. If you ask the patient, "Kuthe dukta hai?" the person is confused. The person is not able to tell you, "Ithe dukta hai, ithe dukta hai." He will probably keep the entire palm of his hand on your chest. It is associated with dizzy sensation and sweating. Why do you get sweating in patients with acute myocardial infarction? That is because there is an adrenergic drive associated with acute myocardial infarction. Now, what is adrenergic drive? There is an increase in the adrenaline levels. And why do you get sweating in adrenergic drives? Because the postsynaptic fibers also go to the sweat glands. So hyperadrenergic drive of any sort is associated with sweating. I'm sure a lot of you would have come across patients who report to you nocturnal sweating. Now, nocturnal sweating is a very, very common symptom. But if somebody reports to you with a lot of sincerity in his symptoms, then you have to find out if there are other causes for hyperadrenergic drive, which need not necessarily be acute myocardial infarction. There are various causes of hyperadrenergic drives. Disease spells occur because there is a drop in blood pressure with certain types of acute myocardial infarction. There can be conduction problems with certain types of infarct, and you can get dizzy sensation. What is important is the onset of discomfort. The onset of discomfort is not sudden. It is never sudden. It is over minutes. So it is acute in onset, but not super sudden. And it gradually builds up and reaches the plateau. That is very typical of acute myocardial infarction. Now, when you do the initial evaluation, please always ask about certain risk factors which make you prone for having acute myocardial infarction. And these are, I need not stress, everybody knows the 5 important risk factors. History of smoking, tobacco consumption, family history, hypertension, diabetes, and any history of dyslipidemias. Record the pulse, blood pressure, and ECG. And please be very, very truthful while recording a pulse and blood pressure of a patient who is complaining of chest pain, because this is going to give you a very vital information to decide whether you need to triage this patient immediately to a higher facility, or you can afford to treat this patient in your clinic and call him for a second visit. I'm not going to go once again into the details of these diagrams and figures which indicate the type of infarct and the arteries involved. Now, chest pain due to ischemic heart disease, it's a big continuum. It's a big spectrum. At one end of the spectrum, we have already seen there is acute myocardial infarction. At the other end of the spectrum is a chronic stable angina, where the person reports to you that whenever he walks uphill, whenever he walks stairs, or whenever he's walking even on flat ground, sometimes people report that after having had good meal, if they start to walk, they get discomfort. Unfortunately, a lot of our biases don't allow us to quickly diagnose a possibility of ischemic heart disease. Now, these biases are, we are very food-centric culture. We tend to blame a lot of things around gastrointestinal tract, gas, reflux, etc., etc. I think these reasons may exist or may coexist, but they are not as important as diagnosing a case of ischemic heart disease. Therefore, have a high degree of suspicion if somebody reports to you these symptoms and they are exertional symptoms. If you have exertional symptoms and if you are still in doubt and if you want to diagnose, then get an exercise stress test done. This is nothing new. All of you know this. There are situations when even with a typical history of angina on exertion, I would not get an exercise stress test done, and a straight coronary evaluation may be mandated in this particular situation. In between these two spectrum, in between these two ends, there is what is called as unstable angina, where the person presents with a longer anginal episode. Angina after having had meals can be unstable angina and requires medical attention as soon as possible. Now, this is a good slide which quickly tells you, and if you would like to take a quick picture of this, it's a good time to take a quick picture. Chest pain may be anginal if 1, 2, 3, 4, 5, and chest pain is generally unlikely to be angina if it is 1, 2, 3, 4. And this 1, 2, 3, 4, 5 in the first group, if it is angina, pain is poorly localized, as I said to you before. Pain is squeezing, pressing, or burning types. Pain lasts not more than 10 minutes. This is very important. As against, if the pain lasts only for 30 seconds, if the pain lasts for more than 30 minutes, it is highly unlikely to be angina. The pain is generally of moderate intensity. This is once again a very, very important factor. If somebody comes and tells you, Mala ajibat bear karta hai, unbearable pain mala hota. If the person reports to you an unbearable intensity of pain, once again, it is unlikely to be ischemic heart disease. Ischemic heart disease pain is bearable. The patient becomes very cautious. The patient suddenly slows down. The patient is with you, but still not with you, is somewhere else, he's thinking. That type of a discomfort is typically ischemic heart disease. Pain is retrosternal, but may be felt at other sites. I have had some patients with a funny symptom of having had an occipital pain due to angina. But of course, these are rare. And if you have occipital pain, ischemic heart disease should not be the first kind of a thought in your mind. But if you have a retrosternal discomfort, radiating to the left arm, left shoulder, funny feeling in the elbows, you must suspect ischemic heart disease. One more thing which will take away the diagnosis of angina is it is consistently severe in intensity. It is very repetitive, associated with inspiration or associated with posture. Once again, highly unlikely to be ischemic heart disease. I deliberately kept this slide for a longer time, so you could probably take a picture of this. Coming to other cardiovascular causes of chest pain, and unfortunately not diagnosed as many times as it should be, is pericardial disease, constrictive pericarditis, pericardial effusions, minor pericarditis because of various etiologies. Predominantly in our country, still it is viral and then followed by tubercular. It is overstressed that tubercular pericarditis is the most common cause. No, it is not. Viral pericarditis is still the most common cause of pericardial pain, and that can present with the typical chest pain, which increases with the pressure over the precordium. It changes with posture. The ischemic heart disease pain does not change with posture, and there is a variation with respiration, a very distinctive feature of pericardial pathology. If you dig out the history, the person will tell you, the patient will report to you that yes, there was some viral prodrome a few days back. And if you get a few investigations done which are relevant, like ESR, which may be raised, there may be leukocytosis. Cardiac enzymes are by and large normal. In myopericarditis, however, there can be little increase in the cardiac enzymes as well. The ECG is non-progressive. This is a very, very important thing. If you have a facility of getting an ECG in your clinic, and unfortunately, I still come across a lot of family physicians who feel that doing an ECG is not their domain. I feel that if taking a blood pressure is your domain, if taking a pulse is your domain, then please, taking an ECG is your domain, and you must learn very, very few basic things of an abdominal ECG. And it does not require a rocket science or a rocket knowledge to diagnose certain conditions. Now, once again, pericarditis. I've seen a lot of patients who present with these kinds of X-rays. They are not investigated further. They are not treated in time appropriately. And then a few months later or a few years later, they present with an X-ray which is like this. Now, this X-ray is nothing but a eggshell full calcification of the pericardium. Can you see this calcific ring? The entire pericardium is calcified in a few months after the person has had pericarditis, after the person has had fibrinous pericarditis, exudative pericarditis with lot of adhesions, and then goes on to progress to a calcific pericarditis where you have to write off the patient. You can't do much when the pericardium is calcified this much. The point that I want to stress here is that if somebody comes to you with chest pain, give little more time in diagnosing even pericarditis. Echo will definitely help. Aneurysm of the aorta. Aneurysm of the aorta is another cause of cardiovascular pain, chest pain. Is a diffuse saccular dilatation of the part of thoracic aorta. It is usually seen in the elderly people who are atherosclerotic and hypertensive, and the pain can be because of pressure over the adjacent structures. This is how the aneurysm looks like. This is an MRI scan of an aneurysm. Typically, the aneurysms are seen after the left subclavian artery. The aneurysms can dissect, causing acute and severe pains. Aortic dissection is another cardiovascular cause of chest pain. And we all know what is dissection of aorta. There are three layers of an artery, the intima, media, and the adventitia. When the intima separates from the media, in similar fashion, when the intima separates from media, that is called as aortic dissection. Now, aortic dissection is a very catastrophic event. And you require a very high degree of suspicion to be able to diagnose this. And if you diagnose, you would definitely save the patient. And if you do not, you would have definitely lost the patient. How do you diagnose? Sometimes these patients can present with transient ischemic attacks, a neurological deficit which recovers. And that is because whenever there is a dissection of the ascending aorta, the intimal flap goes across and sits at the origin of the brachiocephalic arteries supplying blood to the brain and to the arm. There will be inequality of blood pressure in the left arm, right arm, indicating that the intimal flap has closed one of the arterial origins. There may be loss of consciousness. And that is once again because of sudden drop in cerebral perfusion. Now, it's important to know that there are more symptoms in this particular condition than signs, because by the time person comes to you, the pulses also may have equaled. But if the person has lost consciousness, has reported hemiparesis for a transient time, has had a very severe, very sudden, mind you, this is a very sudden catastrophic event. So in the timeline, we have seen that ischemic heart disease, slow increasing over minutes of acute myocardial infarction associated pain. Pain associated with dissection of aorta, bang, it's like this, sudden, within seconds. Coming to pleuropulmonary causes, one of the most important reasons is, of course, pulmonary thromboembolism. Once again, this is, one has to have a very high degree of suspicion to diagnose this. You have to look for certain backgrounds for acute pulmonary thromboembolism. And these are presence of DVT, bedridden patients, long bone fractures, pregnancy, postpartum, patients with congestive cardiac failures, rheumatic heart disease with atrial fibrillations, etc. So look for these things in a patient who presents to you with more breathlessness and less of chest pain. Causes of chest pain, once again, pleuropulmonary, pneumothorax. Person is acutely breathless and hypotensive because of reduced venous return. There may be pulsus paradoxus. I won't go into the details of what is pulsus paradoxus. The neck veins are very prominent and JVP is raised. There may be tracheal deviation and there may be a hyper-resonant note on percussion if you still believe as clinician in percussion. Now, these are the miscellaneous musculoskeletal causes. I'm coming to the end of my talk. I'm quickly going to summarize after this. Treat syndrome, commonly seen in women. It is due to the inflammation of the sternochondral junctions of the ribs. And there is significant tenderness over the anterior aspect of the chest. You can have raised ESR, cervical radiculopathy due to variety of reasons. It may be infiltrative, it may be malignant, it may be tumors, it may be fractures, it may be various reasons which can cause cervical radiculopathy. Thoracic outlet syndromes, yes. Once again, have a high degree of suspicion. I've had few patients diagnosed and treated well in time after having had thrombosis of the subclavian artery and significant radiculopathy. Degenerative spinal conditions. Now, in India, this is very, very important because of various reasons. Number one, because of our posture. Number two, because of tuberculosis. Number three, because of the degenerative spinal conditions that we often have in the elderly population. I have an example to show you here. The scans are normal. Everything is normal. Scan here is absolutely normal, clearly shows that there is an indentation of the spinal cord. These MRI scans were done at 4 weeks apart. But when the person had a normal MRI scan, and he came back to me and I found nothing on cardiovascular system and I felt that there was a tenderness on the spine, on the spinal process. I asked for a MRI scan once again. The patient's reaction was very interesting. He almost wanted to tell me that there is a nexus between doctors and diagnostic centers. Probably because of my seniority, probably because I'm brought up that way in the medical school. I said, you get it done or you do not follow up with me. You need it. And only 1 month later, we could find that there was a significant degeneration of the vertebral body with compression on the spinal cord. So what is important is, if the person is consistently reporting to you a symptom, and if there is a sincerity in his symptoms, if there is coherence, if there is something which makes you believe that it is important to get one more test done, no matter if it is done once, twice, please do it. Because in the timeline, you are placed in a better position to diagnose a particular problem. This is once again that we diagnosed cold abscess. Not very uncommon in our country. Other causes of chest pain, acid peptic diseases, reflux, esophagitis, and you will be surprised that sublingual nitrate also relieves the esophageal spasm. So the chest discomfort due to esophageal spasm due to reflux esophagitis can also be cured, but you have to look at other relevant factors also, which are very important. Anxiety disorders of various types can cause chest pain. Mitral valve prolapse. There was an epidemic of mitral valve prolapse when we had echocardiography introduced in the diagnostic tool. Unfortunately, mitral valve prolapse is diagnosed more often than it should be. Unfortunately, we make patients out of normal people, and whereas our job is to do exactly opposite. Herpes zoster, I still remember a very interesting story about this. My teacher, Dr. D.B. Kadam, all of you know him. He's a very senior physician of the town, very well respected in the medical fraternity. I was a houseman in Sassoon Hospital. This is a story of 1986-87. A person, after having seen by me, was walking out, and I prescribed him. That was Silin for commonly lies of it. Silin is vitamin C. Sassoon Hospital में सगळ्यात काही कोणाचं सिम्पटम कळलं नाही तर एक मिक्स बॅग मध्ये त्यांना टाकून त्यांना एक सिलिन देऊन टाकायचं आणि त्यावेळेस कंपोस्ट सुद्धा फार इझिली प्रिस्क्राइबेबल होतं. आता तेवढं नाही आहे. So Dr. Kadam called this patient and he said, we need to see this patient properly. all that he did was he exposed the patient properly, asked him to remove the shirt, and looked at the back. There was herpes. And patient had come to me for the second time in the weekly OPD that we used to have. So this is also sometimes important that we do a good clinical examination and expose the patients properly. I think what is most important is to remember, how does the patient look? How sick is the patient? Is the patient extremely sick, critical and about to die? Steady pulse, heart rate much higher than you expect, blood pressure lower than 100 systolic, diaphoretic, not interested in what you are saying, generally listless, breathless, are the patients who need an immediate transfer to the other hospital or a tertiary care hospital. How to do a tertiary care transfer? That is also very, very important. I'm going to just about to tell you one story. Is the patient uncomfortable but sick? Once again, can have a ECG in your clinic, and well enough that you can do a few tests like hemogram, X-ray chest, or an echo, or a ECG from some other facility. If you do not have that facility, call for a follow-up, etc., etc. And this is called as a triage of the patient. I often used to get called in good old days until the time I almost went on a crusade to bring about the awareness amongst referring doctors that if you are referring a patient, don't send patient to the casualty of a particular hospital. की मी चिठ्ठी दिली आहे, तुम्ही अमुक हॉस्पिटलला जाऊन दाखवून द्या. This is 2 a.m. in the morning. The person comes to you from some distance, say 1 hour, 1.5 hours. You have lost a very, very crucial period. The person is once again examined by casualty medical officer. Then he calls a cardiology resident. The cardiology resident is sleeping. So he comes there, sees the patient and does a ECG and realizes, oh my God, this is an extensive anterior wall infarct. And the person's blood pressure by this time is 80 systolic. So he calls the cardiologist at 2:30 a.m. in the morning. And the cardiologist says, okay, we have to open the lab. We must take this patient in the cath lab and open the culprit vessel, put in an intra-aortic balloon pump, call the anesthesiologist, probably need an elective ventilation. So the cath lab is initiated. Everybody comes at 3 o'clock. Patient is in the lab at 3:15. We accomplish the procedure. But by the time the procedure starts, the patient's blood pressure is 70 systolic, requiring a lot of adrenaline, dopamine, supports, intra-aortic balloon pump. And we do all this in a big hurry and don't think too much about sterility, etc. So introduce some infection somewhere at the time, which manifests 2 days later with septicemia. Patients have renal shutdown on second day, third day, and the patient succumbs. And think of a scenario where the referring doctor at 12:30, when he came across the patient, at night says that, okay, you probably have an infarct and I'm going to inform the doctor. So the doctor is informed at 12:30 that I am probably sending you an acute myocardial infarction. Patient is not looking good, very diaphoretic, and I have done the ECG or I have not done the ECG, whatever. I am ready with entire arsenal. My entire team is there, they're ready to take over as soon as the patient comes at 2 a.m. That 1.5 hour that we got extra made a world of difference. Do you agree with me, Sachin?
Sure.
So referring to a tertiary care hospital is an art where you make a patient, where you make a doctor responsible for the immediate care that may be given or imparted to the patient when he arrives in the casualty. I think what is potentially fatal, we have seen, just to summarize, it is a myocardial infarction, pulmonary embolism, pneumothorax, and dissection of aorta. And what are the reasons why these people die? They die because of these things associated in acute myocardial infarction. In pneumothorax, there is hypoxia and shock due to decreased venous return. In pulmonary embolism. So your treatment must be directed towards these things. do a quick examination, get into the habit of doing a very rapid examination, peripheral pulses, forelimb pulses, blood pressure recording, etc., ECG. And nowadays, I have started to write that it is a must above the age of 25 years. I have given this lecture 20 years back also, and that time I used to write 35 years. But what I've seen in the last few years, I've changed this figure from 35 to more than 25 years. I see a lot of young infarcts. If you suspect potentially fatal condition, send to the hospital stat after primary care, which may include pain relief, antiplatelets, sublingual nitrates. Please do not use sublingual nitrates very randomly and without any rationale. If the blood pressure is good, you may use it. Oral beta blockers if you are suspecting anterior wall infarction, if you have diagnosed anterior wall infarction, if you are suspecting dissection of aorta, etc. 24 hours observation if you have the observation facility in your clinic, etc. Thank you very much. And I think I did not want to, I will take those claps. I did not want to go into the details of what is new in cardiology and what are the recent advances, because I think I have already consumed a lot of time talking about the basic topic, which I thought was very relevant to the mixed bag here. Cardiology has made an immense progress on various fronts. And to mention a few, we are able to do a lot of complex angioplasties, which once upon a time we thought that they were only meant for bypass surgeons. We are able to replace cardiac valves through the catheters, and something which seemed only feasible after having cut the sternum and after having put the patient on cardiopulmonary bypass is now possible through a catheter. So I think with that, I'll hand over the reins to Sachin. Thank you.
Thank you, Hardas sir, for giving excellent lecture on the chest pain management for the family physician. He has given what are the potential lethal causes for the chest pain and which should be evaluated as early as possible. As sir has given many case examples and very good input about the management of chest pain. Thank you, sir.
I request Suhas Sardar sir to join Sachin Lakde sir to moderate the next session.
The sequence of talks is going to change a little bit, but of course that will not make much difference. I now call Dr. Jagjit Deshmukh, who is problem. Absolutely. The patient is in casualty already? Huh? Okay. Now you wonder if you could do these things with Corindus. That is another advance in cardiology. You can do angioplasty from a remote place. So if Jagjit had that particular robo here, he would have done an angioplasty of a patient who is having infarct in Sahyadri Hadassar. Jagjit is a cardiologist with a good experience of more than a decade in cardiology, having got a lot of experience from BJ Medical College, Ahmedabad. He did his DM cardiology there, which is a very high volume center. And head of the department of that particular facility used to be one of my very, very good friend, Samir Dani.
Yes, sir.
Yeah. So over to you now, Jagjit, for your talk on differential diagnosis of heart failure, how to refer, and whom to refer?
Thank you, Hardas sir, and thank you. I'm Dr. Jagjit Deshmukh. I'll be talking about the role of cardiologist in management of an heart failure, specifically in relation to the general practitioners and physicians' perspective. We know that a heart failure is basically not a single disease entirety, but it's constellation syndromes, which includes symptoms like breathlessness, ankle swelling, fatigue, and signs like elevated JVP. So it's just term which has been used to refer, that is inability of the heart to pump the blood effectively to maintain enough blood for the body's need. There are a lot many reasons for heart failure, but most common reason in our scenario looks to be the coronary artery disease, which is seen in nearly 60 to 70% of the times. Uncommonly, in 30% of the times, in 10% of times, we may not find the reason for that. Other less common causes of heart failure includes peripartum cardiomyopathy, thyrotoxicosis, anemia, and rheumatic heart diseases. When we used to categorize the patients of heart failure, European Society of Cardiology categorizes these patients of heart failure into three forms. In the first one, when the patient is having ejection fraction of less than 40% echo-wise, plus signs and symptoms of heart failure, they are labeled as heart failure with reduced ejection fraction. Patients who are having ejection fraction in the range of 40 to 50 with symptoms are labeled as patients with heart failure in mid-range EF, while patients who are having documented EF of more than 50, but objective evidence of structural abnormalities on echo, that is presence of LV diastolic dysfunction or a raised LV filling pressure with elevated natriuretic peptides, are labeled as patients with preserved ejection fraction. Although in day-to-day practice, we used to see most of the patients of reduced ejection fraction nearly 60-70% times. Heart failure with preserved ejection fraction is common, is most of the times undiagnosed entirety, and used to see in patients like in subsets of the patients who are old, female, diabetic, and having other comorbidities like hypertension or CKD. When functional class of the patients are considered, patients in beginning phase, that is an initial phase of heart failure, are likely to enjoy the good functional class. There is no limitation of physical activity. They can do ordinary physical activity without any limitations. But as the disease progresses, patients are more likely to have restriction doing all daily activities. And in stage 4, they are not even able to carry out the activities without any discomfort, and they become symptomatic even at rest. So as the disease progresses, as the cardiac function decreases over the period of time, the rates of hospitalization for heart failure increases. With each hospitalization, there is a rapid drop in the clinical state of the patient, which may not fully recover. And as the disease progresses, there is chronic decline in the cardiac function and increase in the mortality rates of heart failure patients. So it's very critical from the primary care physician perspective to refer these kind of patients in the beginning phase only, because in earlier phase we can see the patient is having onset of heart failure and having good functional class, tolerating the guideline directed medical therapy without any hospitalization, and no evidence of end organ dysfunction like elevated creatinine levels. Such patients can be managed at their own level. But once the patient starts to deteriorate, like he enters the class 3 symptoms or class 4 symptoms, when the routine medical therapy is not able to control his symptoms, when the rates of hospitalization increases, and when the chances of arrhythmias, or when patient who had ICD increase in shock rate, this patient, it becomes a golden time for such patients to see faculty who is expertise in management of heart failure patients. Because once the patient goes into the multi-organ failure, and it becomes very late, because pump failure and subsequent sudden cardiac death restricts in management of such patients. So when we see the signs and symptoms of the heart failure, we know that the most commonest presenting symptoms of heart failure is breathlessness or dyspnea on exertion. Few patients may complain that they have dyspnea only in the night times, that is paroxysmal nocturnal dyspnea. Less common symptoms includes nocturnal cough, wheeze, or some patients may simply complain about the loss of appetite or bloating sensations. What we used to find in such patients, or what are the specific signs we used to get in such patients are elevated JVP, that is distended neck pains, positive hepatojugular reflex, presence of third heart sound, and displaced apical impulse. These are the specific signs of the heart failure. Other uncommon signs and symptoms like increase in weight gain over a period of 2 weeks, or simply presence of tachycardia, irregular pulse, or decreased air entry on both lungs can be a sign of decompensated heart failure. So what are the recommendations, or what are the routine tests which should be offered in patients of chronic heart failure? Simply doing an ECG or X-ray can diagnose heart failure in OPD basis. Like commonest ECG rhythm in heart failure patient would be sinus tachycardia, while X-ray in patients with decompensated heart failure will show presence of congestion, that is curly B lines, or we may get to use cardiomegaly, or even presence of pleural effusion on both sides can indicate that the patient may have heart failure. So the diagnostic, when the patient of an heart failure is comes to an OPD, and when the diagnosis is there uncertain, apart from a physical examination, there are array of tests we should offer to the patients. Simply basic ECG, X-ray, and echocardiogram. Plus, there are certain blood tests which should be done in patients of heart failure, like complete blood count, and should be done in all patients of heart failure, because nearly 1/3 of the patients, that is 37% of the patients, may have anemia, and we know that anemia itself can increases the chances for mortality in heart failure patients. It decreases functional capacity and increases the heart failure related morbidity, and prolongs the prolong the course of hospitalization in such patients. Other important tests like INR, patients who are on anticoagulation should go for the testing of an INR. Serum tests like urea, creatinine, and electrolyte should be done in such patients, because nearly 20% of the patient may have hyponatremia, specifically in acute heart failure. Then patients who are receiving the diuretics may have change in the potassium level, which may again causes arrhythmia. Other enzymes like BNP, troponin should be done in such patients. So once the patient comes to a OPD or in hospital and is suspected to have acute heart failure, apart from the physical examination and assessment of signs and symptoms, as I told, the basic tests like ECG, X-ray should be done quickly. And if there is suspicion or the tests are abnormal, then cardiac evaluation by echocardiography, person doing echocardiography or cardiologist should be offered, because echocardiography will categorize this patient in low ejection fraction, mid or high ejection fraction patients, preserved ejection fraction heart failure patients, and will help to categorize and manage such patient. And in selected patient, we may offer further testing, which include the angiography and hemodynamic monitoring. So ECG is the basic test which we should do in all patients of heart failure. As I already mentioned, the commonest rhythm abnormality in heart failure patient would be sinus tachycardia. Sometimes underlying abnormality, like in patients who are having infiltrative disease, we may get low voltage complex. Even they can be seen in patients with pericardial effusion. Other signs of right ventricular or left ventricular strain, or enlargement of an atria, that is L enlargement, or R enlargement, that is tall P waves in second lead, or simply the presence of ventricular desynchrony, that is white QRS complex, may indicate such patient need further evaluation for the device therapy. Echo is probably the most crucial test for the evaluation of the functional and structural changes in patients with acute heart failure. It checks the cardiac chambers and valves. By doing echocardiography, by assessing the patient's ejection fraction by Simpson's method or by conventional method, we can diagnose his ejection fraction and categorize, and helps to influence to manage such patients according to the guideline directed medical therapy. So when it comes to the blood test, BNP, a role of BNP as a biomarker is important. It not only helps diagnose the heart failure, but it also helps to manage and helps to assess the prognosis of the patients in long term. We know that the BNP as a biomarker is released from the myocardial left ventricle wall because of myocardial stretch or by neurohormonal stimuli. Once it is released into circulation, it is inactivated by the neprilysin enzymes in inactive forms. Elevated BNP values are not only helpful for managing or differentiating patients for heart failure, but also helps to rule out the other causes of patients of acute shortness of breath presenting in ER or in ICU. So this is a slide which is taken from the PRIDE study, which shows that a BNP value of more than 500 picogram indicates that the heart failure is likely in 90% of the times. And when BNP values are less than 100, the heart failure is essentially ruled out, and such patients should be assessed on the other lines. These are certain potential biomarkers which are not commonly used in management on heart failure, like inflammatory markers, interleukin 6, CRP. Other markers of myocardial injury like troponin, CPK can be used. On the contrary, elevated troponin level in patients with acute heart failure itself can indicate the patients may have a worse outcome. So when the diagnosis for heart failure is concerned, it's basically a stage process. Initial workup of the patient with symptomatic heart failure includes thorough clinical examination, assessment with the basic test, which ECG, echo, stress test, and cardiac enzymes. Detailed workup involves doing a stress echo or offering him cardiac catheterization to rule out the coronary disease. And when the underlying pathophysiology and etiology needs to be found out in a in rare cases, we may need to go for endomyocardial biopsy or cardiac MRI. So the patient of suspected heart failure may have cardiac causes apart from heart failure, like he may have hypertrophic cardiomyopathy, or simply he may have acute coronary syndrome with pulmonary edema. Other causes of endocardic shunts or arrhythmia can mimic the heart failure. Other less common respiratory causes like primary pulmonary hypertension or simply COPD with exacerbation, interstitial lung disease, chronic thromboembolic PH, or sleep apnea or obesity hypertension syndrome can mimic the acute heart failure. Systemic causes for heart failure includes the anemia. Heart failure includes anemia, AV fistula, thyrotoxicosis, or a certain liver disorder or chronic kidney disease can even misdiagnosed as an heart failure. So once the diagnosis of a heart failure is done, so what are the treatment options, or what are the current standard of treatment in such patients? So therapeutic algorithm of the patients with heart failure includes these five pillars of the heart failure, which includes ACE inhibitors, beta blockers, mineralocorticoid receptor antagonist, and new molecules, that is SGLT inhibitors, dapagliflozin and empagliflozin. We have the robust data for the management of such patients, like ACE inhibitors and ARBs are concerned. We do have recently in 2016 paradigm HF trials, which has shown that a significant improvement in the outcome of patient with heart failure, that is 60 to 17% absolute risk reduction with use of ARNI, that is apart from that, other agents like beta blockers, we have robust data for the beta blockers. We have Merit HF trial, which has been published in 2001. Then we have other Copernicus trials, which justifies the use of carvedilol in such patients. Newer molecules like dapagliflozin and empagliflozin have also shown to be useful not only in diabetic heart failure but also in non-diabetic heart failure patients. So once these 4 or 5 drugs been started, the patients can be assessed on other aspects, like if he is having wide QRS complex, if he is having ventricular desynchrony, if the QRS duration is wide more than 130 milliseconds, such patients may need to go for the device therapy, which include the cardiac resynchronization. Because in 2001, US FDA has approved the use of CRT in patients with sinus rhythm broad QRS complex and LBBB, and it is in class 1 indication for such patients. Patients who are having narrow QRS complexes, like when the QRS complex is less than 130, but having low ejection fraction, such patients may be offered as primary prevention for certain days. That is, intracardiac fluid should be offered in such patients. Patients who are having EF more than 35% or device therapy is not indicated or not appropriate. And if such patients remains symptomatic, then other class 2 agents like digoxin or ivermectin can be considered. So why the guideline therapy matters? Because we have seen that the patients who have been offered with the conventional therapy like ACE inhibitors, ARB, when compared with the new compression therapy, including ERNI, beta blocker, MRI, and AGL2 inhibitors, they do well. That is significant improvement with the compressive therapy is observed, and overall event-free survival is more in patients who are offered to have a comprehensive therapy. Simply a 55-year-old male man, compressive therapy would improve his event-free survival by 8.3 as compared to the conventional therapy. So these guideline-directed medical therapy options, which include the newer agents like ERNI and AGL2 inhibitors, should be added unless it's been contraindicated by some hemodynamics. So how best to prescribe these medications? Once the patient has been diagnosed as a case of a heart failure with low ejection fraction and EF less than 40% and is symptomatic, this patient should be subjected with the ERNI if possible, beta blockers, MRI, and AGL2 inhibitors. The dose needs to be start from the lowest possible dose. Other parameters like hemodynamics, blood pressure, and serum electrolytes should be checked at regular intervals. When the patient is assessed at 2 or 4 weeks in OPD, and if he tends to have abnormalities, like if the heart rate tends to have high in sinus more than 70, such patient, despite of using the beta blockers, if heart rate remains high, then can be offered with the ivabradine, that is 5 milligram or 7.5 milligram twice a day. If the patient is in atrial fibrillation, in such patients, digoxin can be considered. In our setup, like patients who are not able to tolerate ACE inhibitors, in such patients, combination of atrazine or nitrate can be considered. These therapies should be started and slowly titrated over a period of 3 to 6 months, so that the maximum possible tolerable dose should be given in all the patients. And such patients should be regularly assessed at the 3 to 6 months on OPD follow-up. And their clinical parameters, including their symptoms, including their signs and clinical risk to be assessed. If there is improvement in the clinical signs and symptoms, such patient continue to have should be offered to have same medical therapy. Should not be stopped because symptoms will improve or improvement in ejection fraction, because it may relapse and causes again problem to the patient. When the patient is having low ejection fraction but symptoms have been controlled, such patient should be referred to the device therapy to electrophysiologist or a person who is doing it on a regular basis, like ICT or cardiac resurgence therapy, CRT. In patients who is not doing well, continue to deteriorate and enter into functional class 3 or 4 or having advanced heart failure signs and symptoms, such patient should be referred to the team which is managing such patients, like we do have in Sahyadri, where we are doing mechanical circulatory support like LVADs, left ventricular assisted devices, or a team which is managing the cardiac transplant. Thank you.
I think there was a overall quick discussion about a topic which is otherwise very difficult to understand, very difficult to comprehend even by cardiologists. Contrary to our belief that heart failure is reduced ejection fraction, that is not always the case, as he has pointed out. You can have heart failure because of variety of other conditions where the ejection fraction is very well maintained. And how to differentiate a respiratory cause of apparently looking heart failure from the heart-related heart failure causes, by way of doing all those tests that he has just suggested. Is there a question? We can take a quick 1 or 2 questions. Yes, please. Jagji, is there a
Diastolic dysfunction can lead to patients can lead to heart failure. because this is the variety which is less commonly diagnosed. The patients may have ejection fraction echo wise more than 50%, but if somebody expert does echo and is found to have restrictive filling or diastolic dysfunction, such patients can have the symptoms or can be labeled as patients with preserved ejection fraction heart failure. And these patients may get benefit from offering the routine diuretics, plus they may have other comorbidities, like they may have hypertension, which is the commonest cause in diastolic heart failure. They may have diabetes or may have anemia. So controlling the comorbidities plus offering the diuretics will help in such scenario. Yeah, already pointed out is heart failure with preserved ejection fraction, where systolic function is preserved, systolic function is more than 50, but they have signs and symptoms. They have echocardiographic evidence of heart failure, that is restrictive filling pattern, or they may have elevated BNP levels. Yeah, in such cases.
I don't think we will have those leading questions. Otherwise, it is not going to give him a chance to ask his question. So,
the CT angio and cardiac MRI. So, which one is better as a screening test for ischemia?
Obviously, CT angio is for ruling out the obstructive coronary disease in patients who are having less risk of less likely to have a CAD. When this is a kind of test which rules out as a good specificity, and cardiac MRI is for different purposes. Like it may have for infiltrative diseases, like we may suspect a patient, patient may have amyloidosis, or patient may have some other diseases which can cause myocardial involvement. In such scenario, cardiac MRI, or in patients for assessment of valve function, we can offer MRI. But CT angio is for different purpose. CT angio is probably for ruling out the obstructive CAD.
But MRI does show ischemia.
Yeah, MRI can show this.
Thank you, Jagjit, for giving good insights about the heart failure management. He has specially highlighted about the early referral to the appropriate specialist cardiologist for having the increased survival rate of heart failure patients, as well as advances in therapies like ICDs, CRTs, and heart transplant. Thank you, Jagjit.
I now invite Dr. Priya Palimkar, who is a cardiologist predominantly practicing interventional cardiology and is head of the unit and head of the department at Sahyadri Hospital, Shastri Nagar. Priya is a very well experienced cardiologist. Yes. Okay. Okay. All right. So you will do that. Deshmukh sir, I request you to please come on the stage. Yes, yes. We want to thank you for your lecture and having given this time when you have a heart attack pending in the casualty. Thank you very much, Dr. Jagjit. Thank you. So I was telling about Dr. Priya Palimkar, who is very well experienced. She has more than 1,000 procedures to her credit, various types of interventions, including angiographies, angioplasties, pacemaker implantations, balloon mitral valvuloplasties, etc. She has a dual prestige of having been conferred upon with a fellowship from the European Society of Cardiology, as well as fellow from the American College of Cardiology recently in Orlando. So I think she is going to be talking to us about a very, very interesting case that she always likes to do, which is the image-guided complex coronary intervention. So with that, over to you, Dr. Priya Palimkar.
A very good morning to all of you at IMA, and I think this is my first talk after the lockdown, and I would like to thank IMA as well as Sahyadri Group of Hospitals for arranging this talk. So, very often when you advise angioplasty to a patient, they have a lot of doubts in their minds, like which stent is good, Will my angioplasty last forever? What will happen after some years? Will the stent get blocked again? These are day-to-day questions that keep coming up. And as an interventional cardiologist, it is our endeavor, the endeavor of the entire fraternity, to give better and better technical results. So this is what is the new thing about optimization of angioplasty, so that we have ever long lasting results. And with newer stents, I think we can give better results than bypass surgery also. So, when we want to optimize angioplasty, we have three modalities. One is FFR, which is called as fractional flow reserve. And what is this? Basically, it is the maximum achievable blood flow in stenotic coronary artery divided by the maximum blood flow in the same artery without the stenosis. So if you can see over here, this is the stenotic segment, and this is the flow at the normal site. So the maximum hyperemia, at maximum hyperemia, the ratio of flow at the site of stenosis to the site where there is no stenosis is what gives us the FFR. So I don't know whether these images are very clear to you, but if you can see, there are two images here of an angiogram, and you can see over here, can we have this light off, please? So we can see over here that this is a right coronary artery, and in the middle section, you can see a stenosis over here. This is a 58-year-old gentleman with a positive family history of coronary artery disease. And this looks quite significant if you see. Whereas over here, this is a moderate sized coronary block in the LAD artery. And here in both these cases, when you do an FFR, in the mid RCA, you find that the FFR is not significant. And in the moderate looking LAD stenosis, you find that the FFR is significant and is 0.68. So which is the artery that you should be stenting? This really gives us a clear picture as to which artery, which is the block that deserves to be stented and which is the one which we could manage on medications. This is another example where you can see the LAD artery. This is the stenotic segment over here. The same segment in another angulation. It looks like a moderate stenosis. Look at the circumflex point over here. This looks a little more critical. This is a block in the RCA which looks like a moderate stenosis here. And here lower down in the PLV, you can see a very tight looking block over here. So if you decide to do FFR, which is a wire measurement, you find that it is not significant in the LAD. And here, RCA also, the proximal part is not significant. And if you look at the distal part, it is very much significant. So this patient will land up with just one stent. So that is how you can optimize the stent placement, especially in very elderly people where you would not like to overdo stenting. You would probably like to do a stenting only at the really deserved site of stenosis. Now, what are the unique features of FFR? The normal value is 1 for every patient in every artery. FFR is not influenced by changing hemodynamics like heart rate, blood pressure, and contractility. It specifically relates to the myocardial perfusion area. That means, previously you used to see a moderate block in one artery and a tight block in another artery, and you'll wonder whether both should be stented. So you could do a stress thallium and see. So you would know in this particular circumflex area, it seems that the myocardial perfusion is really suffering on stress thallium. But now we can see it on FFR itself. So you can make out that this artery, which is the more tighter artery, which is actually causing reduced myocardial perfusion, and stent accordingly. Besides, FFR also accounts for collaterals. So some arteries which are totally blocked, but there are good collateral flows, maybe we can skip those for stenting. The circumscript threshold value of 0.8 is there. That is the cutoff to indicate ischemia. So below that is significant, and above that we can defer angioplasty. It is also easy to measure with a success rate of 99%, and it is extremely reproducible. So there is nothing like eyeballing or guesstimate on this. This is an actual measurement which can be reproduced. Now, besides FFR, you also have RFR, that is resting full cycle ratio. And in this, it is a novel resting index that scans the entire cardiac cycle to find the minimal PD by PA ratio. So in FFR, we challenge the artery. We have to see at maximum hyperemia. So we give intravenous adenosine. But in RFR, you don't have to give adenosine. So supposing your patient is having a low blood pressure and you don't want to take the chance or is already bradycardic, then in that case, you can just see RFR, which will give us the lowest value of PD by PA ratio. So what are the cutoffs? FFR, the cutoff is 0.8 and RFR, the cutoff is 0.89. So depending on this, we can judge and estimate which is the tighter disease artery, and we can stent accordingly. This is what the pressure wire looks like. There is there's a transducer, and there is the wire which is connected to the screen, and that gives the FFR measurements. Now, the next modality here is optical coherence tomography, or OCT. So it's time for high resolution imaging. Now, you all know that better than stress test has a sensitivity of 75%. If you want to do better than that, you go for a CT angio. But the picture is still fuzzy because this calcium does not show exactly what is the extent in the wall. Is it circumferential in the outer wall? How much is it protruding into the diameter? So there are some mistakes that happen in the calculation of calcific vessels on CT angio. Angiography, which we do, catheter angiography, of course, gives a better picture, but it is a luminogram. Ultimately, it is showing us the lumen of the vessel. Then looking at IVUS, it gives us a more clearer resolution up to 100 micron meters. And OCT, it boasts of a resolution of 10 micron meters. So if you want to see a clearer picture of Mona Lisa, probably you need to go for OCT. So what is intravascular OCT? OCT is an optical imaging modality that uses near infrared light for high resolution imaging of the vessel anatomy, tissue microstructure, and stents. So this uses infrared light, whereas the other modality, which I'll be talking of later, uses sound waves. This does not use X-ray. It has a fast image acquisition. The acquired images are sharp, obviously, because the resolution is very high. And it gives the lumen of the artery very clearly. Like here, you can see these dots here. Can you see this? These are the stent struts which are opposed to the wall of the vessel. So image resolution of OCT is 10 times better than IVUS and 20 times better than that of an angiogram. OCT helps in pre-PCI for decision making, during PCI for profiles, and post-PCI for removing any event like a malopposition, etc. Image acquisition with OCT is fast, interpretation is easy, and you also get a 3D fly-through image of the entire artery. Now, a few basics. I know it is a little technical, but we'll just go through it in short. Now, when you see OCT, this is the cross-section of the artery. So you can see this dot is the image catheter, which is inside the artery lumen. And then you see these three layers, which is, if you see here, the intima, the media, and the adventitia. So it shows you the three layers. This is a normal, healthy vessel. It also shows external elastic lamina. And for the type of the plaque, it tells you what type of plaque may be there. So over here, you can see a fibrous plaque which is there. This is a calcified image. Can you see more white intensity? And over here, this is an IVUS image. This is an OCT image. And over here, you can see the sharp borders which are there, and it is less echogenic. This is the calcified image, whereas this high echogenic part is the fibrous plaque. The lipid plaque is more, low tissue penetration. It has diffuse shadowy edges, high backscatter, and is seen like this. Now looking at this was to see what type of the block it is, whether it is lipid layer or it's fibrosis or calcium. So depending on that, you can decide which kind of balloon you would like to use to open up that artery. And this is after deploying the stent. You can see strut malposition. Like you can see the struts, they are closely attached to the vessel wall at some points, and at some points there is a big gap over here. So at these points, you can see that the stent is not well apposed to the arterial lumen. And that is why such patients are likely to have stent thrombosis, which you would not be able to appreciate on an angiogram. Whereas if the stent is undersized, sometimes if you have used a smaller diameter stent, 275 for example, and the stent of the diameter of the artery is 30, and in that case, you will see circumferentially the stent struts and the lumen, the internal lumen of the artery, there is a gap all across. This means that your stent is undersized. Obviously, this tells us that we need to post-dilate the stent better, have a better stent apposition. Also, if the patient has come after some years with an in-stent restenosis, this will show us that there is neointimal hyperplasia inside the stent, and thus we know that we have to use a cutting balloon or something, do more aggressive pre-dilatation in such patients. Now, this is what a thrombus would look like in an OCT image. Can you see these flame-like or fluffy kind of shadows inside the lumen of the artery? So there have been instances where patients saw where the doctors could visualize only a clot or only a thrombus inside the arterial lumen, and the underlying endothelium was absolutely clear and there was no tear or no ruptured plaque. And in that case, the patient could just be treated with GP2B, 3A inhibitors and so on. Also, edge dissection can be found out. So supposing you have deployed a stent and sometimes there is a micro edge dissection at the edges of the stent, which may or may not be seen very clearly sometimes on an angiogram. The OCT would definitely tell you that there is a clear edge dissection. And in such cases, you need to tack up the dissection by using another overlapping stent. So in summary, for optimization of PCI, OCT is a very important and handy tool. Stent size selection and landing zone, it can be planned. The position, the expansion, the apposition of the stent can be maximized. The intimal tear, dissection, or false lumen can be tackled with another stent if required. Sometimes there is tissue prolapse. The stent has been deployed, but between the stent struts, there is a prolapse of the tissue over there, which can be again post-dilated. And if there is a lot of calcification, you know that you have to use different modalities than just a simple balloon to cut open the calcium, and so that you have a better result for the angioplasty. And for follow-up, strut coverage, you can see very clearly. Neointimal growth, you can see. And restenosis, or is there a thrombus, all these things you can get a much better idea on OCT. So coming to the third modality now, that is IVUS guided PCI. So this is an artery, and like I said, these are the sound waves which are used by the catheter of the IVUS, and it gives you a grayscale image of the cross-sectional area of the artery. So this is the IVUS transducer catheter over there. This is the vessel lumen. You can see the intima over here. So you see the lumen first, then the intima, then the media, and then the adventitial border. So from inside to outside, it is called as lemma. Now the interpretation of IVUS is a grayscale image. So the fibrofatty plaques will look lighter, the fibrous will look a little more echogenic, and the calcific plaques will look more echodense. So this is a soft plaque, fibrofatty plaque, refers to the low echogenicity, generally due to high lipid content. Then this is a fibrotic, which is definitely more echogenic than the fatty plaque. This is the calcific plaque, where you can see that it is circumferential calcium is there, but more on this medial side. And here you know that this would require at least a cutting balloon, or maybe a rota or an IVL to open up, depending on how much is the arc size of calcium, etc. So calcium is quantified by measuring the arc that it encompasses. The calcium is classified by its location within the plaque. The superficial calcium is closer to the lumen than the adventitia. So if it's only superficial calcium, then in that case, you can use a cutting balloon. If the calcium is deeper in the tunica media, you need to go for an IVL, or depending on the other parameters, also a rota. So in summary, there are very important reasons to use an IVUS. Firstly, of course, the diagnosis of the type of plaque, the significance of the lesion. You can assess angiographically more, the indeterminate zone where you have a moderate kind of a stenosis. You can assess it much better to see the lumen area, whether it is significantly narrow and requires stenting. It guides you regarding what kind of plaque modification tools, that means what kind of balloon or IVL or rota that you need to use. It guides you for the stenting because it tells you the exact diameter of the artery, the length of the stenosis, what should be your landing zone. You can plan the size of the stent. And also for complex lesions, it gives you a better idea. Sometimes your artery is flush occluded, ostially occluded, and you have a branch at the side. So you can put the catheter through the side branch and then come back and probably get some idea regarding from where the totally occluded artery originates. You can check for dissections, tears, etc. And you can also use something which is coming up now called as low contrast or zero contrast PCI. So in patients who are CKD and have multivessel disease or coronary artery disease, you know that they are mostly calcific vessels. They are mostly patients who are very vulnerable and will go into, if they are not already on hemodialysis, they could go on to hemodialysis with all the contrast that we're going to use. So you would like to use the minimum or the least amount of contrast. And in that, the low contrast PCI with IVUS is a very new and coming up kind of a procedure where this modality can be used very well. Also, there are landmarks which you can see in IVUS because you can see the entering of the different branches, the side branches like septals, diagonals. So if you put wires in these, you can make out the landmark zone where you would like to land your stent in case you want to do a zero or low contrast PCI. Also, there are other things that you would be able to see in IVUS. You could see the plaque burden better. The stenosis area, of course, you can see in both. The positive remodeling is seen better with IVUS. The plaque tissue type is seen equally well in both. The lesion length is seen in both IVUS and OCT. Dissection, thrombosis, stent apposition, strut coverage, so on. Everything is seen well enough in both, but IVUS is better recommended for left mains, especially the ostial left main disease, which can be seen with IVUS and not well so with the OCT catheter. And also you can see different branches entering and exiting better with the IVUS catheters. You can see CTO, like I told you, and flush ostial occlusion of vessel. You can use IVUS catheter for trying to see where it is coming from. Muscle bridges are seen better with the IVUS catheter. So you would like not to stent in the muscle bridge because that is the place where the artery is going to go on getting contracted and there are chances of dissection are higher. These are the cutoff values in left main where you can see if you have achieved this area of the left main bifurcation diameters, then you know that your stenting is well done. Regarding the calcification, depending on how much it is, the depth of the calcium, whether it's nodular calcium, whether the calcium is behind the stent, you can use the different modalities for procedure. This is just an example where an operator has done a very good, there are 4 branches coming from left main and all of them have been stented so beautifully and it looks fairly okay. But when you see the OCT run over here, when it is coming into the left main here, So you can see that there is a dissection over here, which you may miss on an angiogram. And now if you have seen this kind of a dissection, obviously you will not leave the patient. You will need to put in another stent there and tack it up. This is a 34-year-old gentleman, diabetic, tobacco chewer. Last year had a PAMI to LAD with EF of 40%. And he came with a restenosis, but the restenosis is starting just at the distal edge of the previous stent, and he was having significant angina and a positive treadmill test. So this is the IVUS images of this particular patient, where we could see a very fibrotic kind of a lesion over here, more close to the origin of the diagonal vessel. And so we stented it across the diagonal, keeping a wire in the branch for provisional stenting. But you can see that after the stent, there is a pinching of the diagonal branch, and the branch was rewired and a kissing balloon was done. And now you can see the branch is also very well preserved, and so is the vessel. A post procedural run of IVUS showed good apposition of the stent. And so we are now more confident that nothing more is going to happen. This is a 57-year-old patient who presented with acute coronary syndrome, TROP-I positive, ejection fraction of 35%, and he had a distal left main bifurcation disease. He was offered bypass surgery as a first option. He was non-diabetic though, but the patient refused to go for a bypass bypass surgery, and so we decided to do a PTC of left main to LAD and CERC using Culotte technique. So this is the first image. Can you see it looks really tight? The distal left vein into the bifurcation of the two arteries is very tight. We had to wire both, predilate both. And then we took an IVUS run of both the vessels. This is the circumflex, which showed a hard fibrotic kind of a plaque more towards the origin of the CERC, as is usually the case. And then we took a run on the LAD artery as well. This was what the block was looking at. There was a distal CERC lesion which was tackled first. Then the left main to circumflex was stented. After that, you can see that the LAD ostium is still quite narrow. The wires were exchanged. Pot was done. Then another stent from left main to LAD. Then again exchange via second pot. Then we again saw the IVUS run, and we could see that there was the left main to LAD stent was looking well apposed. So at the end of it, we had a decent result and the patient is doing very well. So if we want to give our best results to the patient, technically best results, using these tools are really essential, and it helps us not only to avoid unnecessary stenting, but also to give the best results of stenting and leave no margin for any technical failures for a later date. So on that note, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Priya. That was a wonderful talk, because you not only kind of, talked about just the imaging, but you spoke about FFR, which is a very, very important tool to be able to decide whether we need to stent or whether we need to intervene an intermediate looking lesion or not. And I think that has made a world of difference. And some of you may be wondering as to why that cutoff value of 0.8. It is from the data that was analyzed. And it was realized that if you stented or dealt with a lesion which was more than, if the FFR was more than 0.85, you were probably able to save only one person at the end of 1 year out of 100 who went for a real intervention on an acute basis. Whereas if you intervened, if the FFR was between 0.8 and 0.85, then you probably did good in 3 individuals. But below 0.8, this number catastrophically increased to 15. And therefore, it was unanimously decided by experts that let us take the cutoff value as 0.8. In fact, the first trial of FFR, the deferred trial, had taken into account the FFR value of 0.75 as the cutoff value. Because below 0.75 or equal to 0.75, the event rates were as high as 22%. So there has to be a balance between the stent disease that you give versus the natural events that occur. So I think that was a wonderful presentation, Dr. Priya, because you have discussed some of the interesting cases also. There is a question. Wonderful. Please go ahead. Yeah.
Thank you so much for that excellent presentation. Probably I might not have understood exactly FFR because if FFR is that important, you said initially it is being taken into account the vessel actually. That's all. It doesn't go by the hemodynamic. It doesn't go by the blood pressure. It doesn't go by the other variables which would normally we would expect in any flow which we are in a living person. Because we are not only talking about the vessel as a dead tissue. We're talking about a living person who would have his own cardiac output, his own collaterals also for that matter. Yeah. But at the end line, there was a disclaimer saying that none of them are, it's slightly difficult from a scientific point of view, non-medical point of view here, at least for that particular question.
No, I think your point is very valid.
Yeah.
It's just, very valid.
Thank you so much, sir.
And in fact, I was going to bring it up.
Yeah.
But Dr. Priya will address to that.
Just
Please
to complete that FFR, because we are seeing patients in our setup, point of contact with a medical institution. It is not a frequent point of contact. That is going to be a one-time contact in probably a few years. Patient may lose to follow-up. And the kind of patient that they see in a trial setting or in the evaluation are more frequent, more followed up. If our patient has that numbers, should we follow blindly or we should have our own guidelines? Just a second final question is, OCT is remarkable. You actually, first time we are getting so much information about OCT also compared to IVUS. So most of your follow-up actually slides had IVUS rather than OCT. Should it be mandatory for every stent manufacturer that before a patient leaves the hospital, that you give the OCT data with the stent apposition and the flow, whatever? Because what happens, we have some people may be getting more technical than a clinical cardiologist. We need both. After the procedure, what happens to the patient? Patient may just crash after 15 days. He just goes into flash pulmonary edema. And then somebody may realize later that the stenting had some issue or the procedure was not. Your thoughts? Thank you so much.
That's a wonderful question. I want to put my...
I'll address the second question first. So actually, yes, some imaging is mandatory post-procedure at least, because we need to know whether the stent is very optimally placed, apposed, and there is no strut injury, no edge dissection, and so on. But, we live in the real world. There is always a difference between the ideal world and the real world. If you tell the patient that your procedure is going to cost 1 lakh rupees more, then the patient starts thinking. And even insurance companies, unfortunately, all of them do not pay for these imaging modalities. So, yes, if it is also a completely insurance-backed medical service, then definitely one of these would be mandatory. But I think Dr. Hardas can also correct me, but in most of the centers across the world, all procedures are still not done with image guidance, even in the best of countries. So what are the challenges that they face? I also do not know. Maybe it is a little more time consuming because you're going to do this run again and again. And if you have a busy cath lab with many people, then you have to think of all those issues as well. So if I were the next NPPA coordinator, I would say, yes, every angioplasty should have at least a post run of an imaging modality done. Then the second thing about the FFR, what you're saying, we are going to check FFR at maximum hyperemia. So we do give a vasodilator which dilates the artery, and then at that time, the heart rate or the blood pressure doesn't really affect the principles of the ratio at that point in time. And that is why the ratio will still hold true. And this is important. FFR is important, especially, like I said, maybe I'm telling you 7 years back when I did an angiography of an elderly, I think 80-year-old lady. And she had moderate kind of stenosis in LAD circ. and RCA ostium. But RCA ostium also had a lot of calcification over there. And I was going to stent all three. But then, I consulted with another very senior cardiologist. Actually, their relative was Dr. Dev Pehlajani in Bombay, and he was very kind enough to call me up and discuss with me the case. And then he said that, why don't you do this? Why don't you do an FFR to all the lesions, see the exact ratio, and then stent? And it turned out that LED LCX had normal FFRs, and I stented only the RCA ostium. And he was so appreciative of the case, and the patient did very well after that. On the remaining arteries, of course, the medical management continued. So I just want to say that everyone can do an angioplasty. Every cardiologist can do an angioplasty, but you need a very thinking kind of a person to do all these technicalities, and giving the best results, not just unnecessarily stenting, but also trying to give the better results, should be the way forward. Thank you. Thank you, madam.
Yes, there's one more question.
So there is a wait. On behalf of IMA, I will request our President-elect Dr. Raju Aryani sir to come on the dais to felicitate Palimkar madam. Sir,
Excellent.
I think, Priya, there's somebody wanting to ask a question to you.
Yes.
So
Yes, sir. It's already Dr.
we are running late?
Yes, sir.
All right, okay, that's
So
fine.
we have to finish before 11 actually.
But Priya, wonderful presentation,
Yeah, it was a
absolutely. I
very
think what is
nice
important is
presentation.
you have brought it up so very well that angioplasty is angioplasty, but angioplasty with imaging is something else. And we must fall into the era of angioplasty with imaging because I think it has long been proven. Unfortunately, it is not talked as much. And the first paper I think I wrote about imaging was way back in 1996 about intermediate left main lesions and IVUS assessments. So we must embark upon a new era of angioplasty, which is along with intracoronary imaging. Thank you very much for bringing it up. Now I request Dr. Manoj Bhise. I think I have said a few words about Manoj. Manoj has passed out of BG Medical College with gold medal. Subsequent to that, he was in Grant Medical College, JJ Hospital, passed his DM from there. And as I said, he took a bold decision of practicing only the non-invasive cardiology. And today, he really specializes in various modalities of echocardiography, the transesophageal echo. His reporting is very, very exhaustive, gives a complete information that is not probably needed by everybody, but by cardiologists for sure. So I think over to you, Dr. Manoj, for your talk on how to interpret the echocardiography report.
Yeah, good morning, everybody. And thank you, IMA. Thank you, Sayadri, for giving me this opportunity. I think we have been flying very high with IVUS and FFR and OCT and something which an average person really cannot afford in India, and the insurance is coming into play. So we will come back to some very basic investigation like echocardiography. Why is echocardiography important? It is because it is cheap, it is easily available. I think 50 odd centers may be offering it in private practice also. And it is effective, and it can diagnose up to, I think, really 95% of the cardiac illnesses or cardiac problems. So about the interpretation of an echo report, I think I will have some very few basic slides, and I have seen to it that it is not very busy, that what does the physician look for in an echo report. And I have put some few basic things. out of which I'm going to remove valves because it is a very, very important, but a very, very intricate topic. So the holy grail of echo is left ventricular systolic function. Everybody just keeps asking, any doctor accompanying their relatives to me for an echo. The moment the echo finishes, he'll ask me just one question: what is the ejection fraction? So is it so important that everybody should have a mathematical figure? And even though we are in medical sciences, I think all of us are enamored by mathematics and numbers. So we want a number which is allotted to something which we can say that his left ventricular contractility is normal. They are not satisfied with that. They want the number. Okay. Since the recent heart failure classification, I think Dr. Jagjit also took it, that left ventricular failure is now divided into HFrEF and HFpEF. PEF is preserved, REF is reduced. And the preserved ejection fraction is in some way dependent upon the left ventricular diastolic function. And I think somebody here also questioned that we very many times read a report of diastolic dysfunction in the echo report. Should we presume that this patient has left ventricular preserved or HFpEF? The third is valves, which I'm going to omit. And the fourth is surprisingly the pulmonary pressures. Everybody wants to know what is the pulmonary pressure, even of a normal man who is walking, talking, he has no respiratory symptoms, nothing. But there is a requisition that we want to know the pulmonary pressures of this individual. So why is left ventricular systolic function important? It plays a pivotal role in cardiac diagnosis, risk stratification, obviously, and it helps us in therapeutic guidance. What is the normal ejection fraction? And this question is even difficult to answer by the students who come to learn post-MD, the echocardiography. And the recent American Society of Echocardiography, I don't know whether those values are very clear or not. They have differentiated the male from the female. We know this, that males are different from females, but even the normal ejection fraction is different for females and males. So the normal range in a male is at 52 to 72%. Does it surprise people? Yes. That 52% would be called a normal ejection fraction, and 72. So 72 and above would again be abnormal. Then we have this basic classification of mildly abnormal, moderately abnormal, and severely abnormal, and the severely abnormal less than 30%. We have been playing around with the classification with heart failure and the treatment and the trials, and now reduced ejection fraction is less than 40%. But for time immemorial, we always believed that the severely depressed ejection fraction is less than 30%. Probably will say that clinically, these are the patients that deserve your attention much more than between 30 and 40%, because that would be a moderately affected LV ejection fraction, and he would not be so symptomatic. The females are at 54 and 74%, so they fare better than the males, and at 54%, it would be a normal ejection fraction for a female. The next line here is the left atrial volume index adjusted to the body surface area. What does that mean? That means that if we are to evaluate somebody's diastolic function very carefully, we would need to have his height and weight entered into our echo machines so that they give us this value of left atrial volume index. Otherwise, you would have a 5'2" person and you would calculate the volume, and you have a 6'2" person, you would calculate the same volume. It would not be the same. So you have to adjust it to the body surface area. And here the normal value is 34 ml per meter square body surface area. And if it is more than this, it is abnormal, because we are also looking at left atrium as its function, the strain, and the left atrial dilatation is one of the first finding that you would get in a diastolic dysfunction, which is significant. So left atrial volumes important. You try to read them if the echocardiographer has mentioned it, and it is important for further classifications. What are the methods for calculating the left ventricular ejection fraction? It makes for very simple reading the M mode Tecoix method, which has been outdated. Nobody now tells us that you calculate the left ventricular ejection fraction by the M mode method. The next is the biplane Simpson's, which is now recommended. So it should be the baseline, and the ejection fraction should be mentioned what method this has been derived at. So if you read that somebody has written biplane Simpson's, I think it has been done fairly well, and you can believe in this ejection fraction. The third is what all of us do because of lack of time, and that is known as a visual eyeballing method. We have become good at this. So we see a few visuals, angles, the left ventricle, and we can really assess what the ejection fraction is. And here we tend to report it at multiples of 5 so that the person in front may understand it more easily. So multiples of 5, it would be 45, 40, 50, 55, 60, 65, because it is basically done by the eyeballing method. Is this the only way to look at LV contractility? And we have calculated the ejection fraction, that's it. No, there are a lot of other methods also to look at LV contractility. We do that in specific clinical circumstances where there is a surgery happening specifically of the valve, and we want to know what is the correct or a good LV contractility. And the methods, I'll just enlist them because it should not bother any of you, but it is EPSS, which is the mitral septal distance. Then there is MAPSE, which is the systolic excursion of the mitral annulus. Then there is fractional shortening. Then you can have a look at the stroke volume and cardiac output. Then the visual assessment, then myocardial performance index, then the mitral DP by DT, the tissue Doppler index, and newer technologies like 2D strain and the myocardial contrast, which can tell you much more about the LV contractility than only the calculation of ejection fraction. Now, there is a variability in the left ventricular ejection fraction calculations in individual patients. And you may have a person who comes on a Monday and he comes on Saturday, and we may give ejection fraction as 62 and then 66%. And he will ask you, how has it changed? Is my heart got better over 1 week's time? And there is something known as a physiologic variability, that the ejection fraction depends upon loading conditions, heart rate, volume status, image acquisition, how do you acquire the image, the endocardial definition, the image orientation, and the measurement variability in tracing the endocardial borders. So many factors can come into play. So you may not have the same ejection fraction of the same person even a few hours later. So after we do the systolic function, we'll talk a little bit about diastolic dysfunction. As clinicians, have we been ignoring diastolic dysfunction of left ventricle? The answer is yes. We have been ignoring the left ventricular diastolic function all throughout. We probably believed that the ejection fraction numbers is everything that we need to look at. And since a lot of clinical trials have come up for the medical treatment of heart failure and medical treatment in preserved heart failure also, here we have been trying to look at the left ventricular diastolic function in a much more detailed way. We know the cardiac cycle, we know it's divided in 2 parts, systole and diastole. We know that the diastole is longer than systole, it has 4 parts, the systole has only 2 parts. And the recent classification of heart failure dividing into REF and PEF has put focus on diastolic function of the left ventricle. So the diagnosis of HFpEF is basically clinical. And I will reiterate this fact that basically the diagnosis of HFpEF is clinical. It is supported by cardiac biomarkers. So you have to do a BNP, pro-BNP, and show that it is elevated. Even if you have a normal ejection fraction on echo, we have to look at comorbidities like old age, female gender, hypertension, cardiomyopathy, coronary artery disease, diabetes, sleep apnea, renal dysfunction, metabolic syndrome. And the echo part, we have to look at left ventricular filling pressures. And this information is very difficult to see in the echo reports that come our way in most of the places. That are we reporting that the left ventricular filling pressures, the end diastolic pressure and the PCWP, is it normal or not? Here we have a diagram. I think due to brevity of time, I think I'm going to run through these slides, that we have a diagram of normal diastolic function, the left ventricle and left atrial pressure traces, what we see in the mitral flow, what we see in the tissue Doppler and the ECG, and then you have a normal left atrial pressure or normal left ventricular end diastolic pressure and high left ventricular end diastolic pressure. Those waveforms will change, the patterns of the tissue Doppler will change, and thus we can always comment in the report that he has diastolic function with increased left ventricular filling pressures. And that comment will come only if it is abnormal. I think Dr. Mantri was asking this, that comment if it is a type 1 or a lesser severity of diastolic function, we would not comment on the left ventricular filling pressures. So if we comment that the left ventricular filling pressures are high, that means that this patient has higher chance of having a HFpEF. So there are grades of diastolic dysfunction. It is not just the diastolic dysfunction. You must look at whether the diastolic dysfunction has been graded as 1, 2, 3, 4. There are various patterns, various modalities, including the pulmonary venous flow, the IVRT, and the tissue Doppler. We incorporate all these patterns. They are fitted into our brains, and then we can easily interpret this as 1, 2, 3, and 4. Now, all grade 3 diastolic dysfunction will have high left ventricular filling pressures. 50% of the patients with grade 2, that is the pseudonormal pattern, will have high left ventricular filling pressures. But by and large, the grade 1, that is impaired LV relaxation, will have normal left ventricular filling pressures. So here the diagnosis of HFpEF should not be entertained. How should we report diastolic dysfunction? Presence and absence, severity and grading, evidence of elevated filling pressures, and the concurrent factors that may affect the diagnosis, that in elderly age group with a very high heart rate, with atrial fibrillation and presence of mitral valve disease, it may not be easy even for us to grade the diastolic dysfunction or to tell about the left ventricular filling pressures. So in the recent guidelines, they have changed that. They have said that when we talk about diastolic dysfunction of the left ventricle, we must mention 4 parameters in our report. The number 1 is the average E by E dash ratio. Normal is less than 14. The septal E dash velocity and lateral E dash velocity on tissue Doppler less than 7 centimeters, less than 10. The TR velocity more than 2.8. That means there is presence of pulmonary hypertension or not. And the LA volume index more than 34 ml per meter square surface area. So these 4 parameters are a must now for indicating or telling about the diastolic function. If you have a person who has no comorbidities, no clinical thoughts about him having any cardiac pathologies, 3 out of these 4 should be positive for you to say that he has diastolic dysfunction. If you have a person with comorbidities, he has severe hypertension, CRF, CKD, cardiomyopathy, ischemic heart disease, whatever, even if you get 2 of these 4, you could still say that he has diastolic dysfunction with left ventricular filling, high left ventricular filling pressures. And this is the flow chart. It's a very busy slide. And this is that the same thing, that everything is mathematical now. You can have a ratio of the E by A ratio of E by E dash, and a lot of jargon. But basically, the grade 3 will have raised LVEDP. The type 1 will have normal. And the type 2, you go in details for you to decipher that this is raised LVEDP or raised high filling pressures or not. We'll come to the third point, and that is pulmonary hypertension. Why are we so keen on pulmonary hypertension? I will make a very basic statement here that all the pulmonary hypertension and pressures that we measure by echocardiography are just mere approximations. And the number that we give of the pulmonary artery is a finding. It is not a diagnosis. It's not a diagnosis. It's just a finding that his pulmonary pressures by our echocardiographic means is so and so mm of Hg. So by definition, pulmonary hypertension is defined as mean pulmonary artery pressure. There is a difference. The definition is by mean. We give basically the systolic pressure. So the mean is equal to or about 25 mm Hg as measured by cardiac catheterization at rest. So by definition, it is the cardiac catheterization. Nowhere echo has been mentioned. So the pulmonary hypertension is pre-capillary and post-capillary. Here we have to measure the pulmonary capillary wedge pressure. This is easy for us to measure. It comes by various modalities like E wave, E dash wave, and there is a formula which is devised by a cardiologist named Nage. So if you incorporate these findings, we can calculate the pulmonary capillary wedge pressure by echo. So you have high pulmonary pressures, a normal pulmonary capillary wedge pressure, it is pre-capillary. Post-capillary, you have high PCWP. So pre-capillary is pulmonary arterial hypertension due to lung diseases, chronic thromboembolism, and post-capillary is pulmonary hypertension due to left heart disease. And left heart disease means cardiomyopathies, myocardial infarction, everything that affects the left ventricle or the valves of the left side of the heart. So normal pressures inside cardiac chambers, and this is a chart, and this is what is known as hemodynamic monitoring of echocardiography. So we can measure all these cardiac pressures non-invasively, not putting a CVP line, not putting a Swan-Ganz catheter or going inside the heart. Just by echo, we could measure the pressures in the left ventricle, left atrium, right atrium, and everything. And these are the normal values which have been displayed. Now, there is something known as echo features of pulmonary hypertension, which we concentrate on, and that is RARV dilatation, main pulmonary artery dilatation, paradoxical motion of IVS, evidence of right ventricular systolic dysfunction, IVC dilatation with reduced collapse. So all these put together, we call them echo features of PH. So how do we say pulmonary hypertension is pulmonary hypertension unlikely? So if the systolic pressure is less than 35 and no echo features, there is nothing to worry about. Everything is normal. Pulmonary hypertension possible, and possible is systolic pressure more than 35, echo features of PH. So between 35 and 50, and there are echo features of PH, we would call this pulmonary hypertension. And PH very likely is pulmonary artery more than 50, even without echo features of pulmonary hypertension. So here I will just talk for another 5 minutes, I think, on just a new modality called strain imaging and speckle tracking. And here, this is another way of looking at regional wall motion abnormality and overall a global LV systolic function scenario. Here we image the heart in 3 particular views, that is known as a 4-chamber, 3-chamber, and 2-chamber. And with this, we can assess the global longitudinal strain, and that means how much is the myocardium getting deformed, or what are the changes in the length of the myocardial fiber in diastole and systole. And the strain imaging can be quantitative. It has magnitude and it has direction. And this is the deformation that you have seen myocardial fibers. It can lengthen in diastole and then it can shorten in systole. So the strain is the L0 is the basic length. L1 is after it has shortened. So L1 minus L0 upon LO into 100. And here the strain is a plus 60. Or you can have a negative strain. That is also the global longitudinal strain, and here the strain is minus 25. And this is the myocardial strain, depicted down the normal, how it goes down and how much it contracts and what is the systolic shortening. And this is the abnormal GLS, which is less. And we pick up the speckles on the 2D echo imaging, and they see the variation of the distance traveled by the 2 speckles, and then the machine makes all these calculations. You can have a longitudinal, radial, or a circumferential strain, and it is displayed in a quad format. On the left is the color encoded region of interest. On the right is the segmental analysis of the strain curves. Then you have the anatomical M mode, and then you have the peak segmental strain map. And then you have the global longitudinal strain in a bull's eye plot, that the red is good and the blue is that it is not shortening or it is not good. So the depiction of the various segments of the myocardium are on this bullseye map. On the top is the anteroseptal, then you have the septal, then you have the inferior, the posterior, lateral, and anterior. And obviously you require a machine which is capable of this, and crisp, good 2D images and then interpretation of the strain images and obviously experience. So the clinical applications are pattern recognition of bullseye, subclinical dysfunction, and regional variations. So these patterns can do a lot. On the left, the all red is the normal, and below is the apical hypertrophic cardiomyopathy, and then you have the cardiac amyloidosis with the cherry on top, and then the septal MI. And if you have a more than 15% reduction in the GLS in a patient of oncology who's taking chemotherapy, it is a reason to believe that his left ventricular systolic function is going to go down with the therapy, and that so you have to reduce the dose or stop the therapy totally. And this is an example where the GLS has fallen by more than 15%, and then mechanical dispersion on the left. All the strain graphs are peaking together, and there is dispersion on the right side. So this patient would benefit by CRTD. So in summary, the strain measures myocardial deformation. The most common application is the global longitudinal strain. Normally in India, it will be between -16 to -18%, though the Westerners, they say that they may have a strain of upwards of -20. And we have to be very fastidious, attention to detail, and it has got a learning curve. So pattern recognition, subclinical LV dysfunction, regional variation is now what we can see. It is now utilized in left ventricular hypertrophy, heart failure, cardiotoxicity, aortic stenosis, and IHD. And in future, we would do this or use this for the RV strain, the LV strain, the regional wall motion abnormality, and obviously we'll have better studies for the diastolic function. Some images, I don't know whether they will play, but some images of the real time, how we do the strain imaging. So you can see the region of interest, which is moving, and the global longitudinal strain. This is a normal patient, is calculated as -18.2. Now, this is the bullseye, which also shows a normal -16.7 strain or GLS. Now, this is a patient with a mild apical hypertrophy. So you can see the bullseye pattern, and this bullseye pattern in the center shows some pink or light. So that means that the apical area is hypokinetic. The rest of all the segments are contracting well. And this is the part of the hypokinesia where it has picked up a lower strain. And now this could help even after therapy and after angioplasty. Is the GLS in that particular area improving after angioplasty or not? The next thing, this is how we see three different, this is a case of ischemic cardiomyopathy who's had a anteroseptal MI in the past. So you see a large area of anteroseptal hypokinesic, only the basal and the lateral portion of the myocardium are contracting. So we did a global longitudinal strain on this, and we have a lot of blues here, which say that this entire part of the myocardium is completely damaged. Even the light pink is problematic, the darker pink is problematic. Only the inferior and the lateral part, some part of a normally contracting ventricle. So the global longitudinal strain is only 5.4%. I think this is the same, and I go to the next. So this bullseye pattern of ischemic cardiomyopathy, these are the strain patterns, and you can see very, very low strains all throughout. And this is the peak systolic dispersion or time to peak dispersion. So if you see this thing and this thing, there will be a gap of 216 seconds to 586 seconds. And this map we use for knowing about the myocardial dysynchrony. Here we calculate the ejection fraction by tracing the left ventricle in diastole and systole. So I think usefulness of GLS is cardiotoxic chemotherapy, subclinical rejection in cardiac transplant, cardiac dysynchrony, TTP strains across many strains, and useful in hypertension, diabetes, CRF, hypertrophic cardiomyopathy, IHD, and regional wall. So a very, very long list where you could utilize this newer modality. And some few pictures of what does 3D echo look like, and this is what we would see a normal atrial septal defect in a 4-chamber view. And I've just put a 2-clip crop, and this is what the ASD would look like. This is just a simple plain transthoracic 3D echo. And here we have a tricuspid and a mitral valve. How does it look on 3D echo? This is the tricuspid valve, and this is the opening of the mitral valve. And here you have how we cut across the mitral valve to show you the opening of the mitral valve on 3D echo, the same thing. And a very nice image of what a routine 4-chamber would look on a good 3D echo machine. I think I had to run through these slides for want of time, but I've completed the lecture, and thank you for the attention. Thank you.
That was a very, very exhaustive lecture, Manoj. I think it's very, very important that we do a very exhaustive echo to be able to come to some kind of a conclusion about management, various aspects of management of the patient. And as you rightly said in the beginning of your lecture, that some of these are relevant to general practitioners and most of these are probably relevant to people like interventional cardiologists who take important decisions of sending the patient for surgery or not. And you have come across so many patients, and I'm sure Dr. Sanchiti sir is already here. In post-surgical period, when the patient begins to go downhill for non-surgical reasons, like accumulation of fluid in the pulmonary circuit, pulmonary edema, they go back and look at the echo report and say, oh, LV function is okay. LVEF was 60%. Why did he land up with pulmonary edema? But now we know, Dr. Manoj, why that happens, because an exhaustive, proper echocardiogram, looking at the GLS, looking at ST, looking at the DPS, all those things that you just mentioned, were not properly done. So thank you very much for at least making us aware. One quick question we can take, if he allows, one last question, and then I will have this mic handed over to Sachin for his comments. Any question, please? No? Okay, Sachin.
Thank you, BC sir, for that good examples giving about the how to interpret the echo report and the newer advanced modalities like the 3D echo as well as the tissue Doppler and strain pattern. Thank you, sir.
I thank Sahyadri Hospital Cardiology Unit for this fantastic morning session on cardiology. And I request our President B.L. Deshmukh sir to felicitate Manoj Bhise sir and moderators Dr. Suhas Hardas sir and Dr. Lakde sir. Dr. Hardas, Suhas Hardas sir. Dr. Sachin Lakde. Thank you, sir. Thank you very much. I request all the faculties to join the most important ceremony that is going to be held now. That is the installation ceremony of our incoming president and her team for next year. Just give us 2 minutes for the stage arrangements. Till the stage arrangements are over, I request Dr. Apurva Deshpande Madam to present Ganesh Vandana. Apurva Deshpande Madam.
नमस्कार. आजच्या या कार्यक्रमाची सुरुवात आपण गणेश वंदनेपासून करतो आहोत. सुरुवात करू का सर? सुरुवात करू. कनेक्ट नाही झाले. प्रथम तुला वंदितो कृपाळा, प्रथम तुला वंदितो कृपाळा, गजानना गणराया, प्रथम तुला वंदितो कृपाळा, प्रथम तुला वंदितो कृपाळा, गजानना गणराया, प्रथम तुला वंदितो कृपाळा, प्रथम तुला वंदितो. विघ्न विनाशक गुणीजन पालक, विघ्न विनाशक गुणीजन पालक, दुरित तिमिरहारक, दुरित तिमिरहारक, सुखकारक तू दुःख विदारक, सुखकारक तू दुःख विदारक, तूच तुझ्या सारखा, वक्रतुंड ब्रह्मांड नायका, वक्रतुंड ब्रह्मांड नायका, विनायका प्रभुराया, प्रथम तुला वंदितो कृपाळा, प्रथम तुला वंदितो कृपाळा, गजानना गणराया, प्रथम तुला वंदितो कृपाळा, प्रथम तुला वंदितो. थँक्यू.
Thank you, madam. I welcome our chief guest, Padma Vibhushan, Dr. K.H. Sancheti, sir. We are fortunate to have you here in IMA building for the installation ceremony of our incoming president and her team. I also welcome all the delegates attending online as well as physically. I request our president, Dr. B.L. Deshmukh, sir, to escort our chief guest, Dr. Padma Vibhushan, Dr. K.H. Sancheti, sir, on dais. Thank you for coming, sir. Our guest of honor is on the way. Honorary Commissioner of Pune Municipal Corporation, Dr. Mr. Vikram Kumarji is our guest of honor and he's on the way. Now I request our incoming President, Dr. Meenakshi Deshpande Madam to come on dais. I also request Chairman Trust Board, Dr. Avinash Bhutkar to come on dais. And Executive Trustee, IMA Pune, Dr. Sanjay Patil and Dr. Jayant Naurange sir to come on dais, please. I also request IPP, Dr. Aarti Nimkar Madam to come on dais. I also request our Joint Secretary, Dr. Gitanjali Sharma Madam, our Secretary, Dr. Alka Shirsagar Madam, and Joint Treasurer, Dr. Kedar Patil sir come on dais. And I also request Raju Varyani sir and Dr. Sancheti sir to come on dais, please. Neeta Nimkar Madam. I request all the dignitaries to join for lamp lighting. I request the dignitaries to be seated. Now I request all of you to stand up for IMA prayer. I will be reading the prayer. You have to follow me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every creed and cure. Thank you. Now I request Dr. Alka Shirsagar Madam for flag salutation. You need not repeat.
We, the members of the Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you.
Thank you, ma'am. Now I request President Dr. B.L. Deshmukh sir to do a floor welcome and felicitation of our chief guest, Padma Vibhushan, Dr. K.H. Sancheti sir. Now I request Secretary Dr. Gitanjali Sharma Madam and Dr. Kedar Patil sir to do a floral welcome of dignitaries of the dais. Dr. Dilip Sarda sir, member Maharashtra Medical Council. Dr. Anand Deshpande. Dr. Padma Iyer, madam. Dr. Arti Shahade, madam. Dr. Arun Halve, sir. Arun Halve, sir. Dr. Suresh Gokhale, sir. Dr. Suhas Nene, sir. Dr. Damle. Dr. Parag Biniwale, President POGS. Dr. Amrish Shahade, sir, past President IMA Pune. I thank you all for coming here to witness this ceremony of installation of new office bearers and the incoming president.
I request our secretary, Dr. Sunil Ingle, to present his secretary report.
Today's chief guest, Padma Vibhushan, Dr. K. Sancheti sir, dignitaries on the dais and off the dais. Friends, last year, 1st of April, I took the charge of Secretary IMA Pune. I was little doubtful about giving justice to this post, but Dr. Sanjay Patil boosted me and he said, we all are there to support you. And so I took the post and I started working as the secretary last year. I was very fortunate to have the most loving president, Dr. B.L. Deshmukh sir, as my president, who gave me a full free hand to work during my tenure. Friends, last year, we tried to work according to the aims and objectives of our association. The association works for members, for the society, and we all work for the association. Like every year, we continued the teaching programs at IMA Pune for our members. Due to COVID pandemic, we were not able to do physical CMEs, but I had an experience of working with IPP Dr. Aarti Nimkar madam, who had taught us how to change to the situation, and we shifted on to the webinars. Friends, to upgrade the knowledge of our members, we did about 26 webinars of multiple specialties like cardiology, rheumatology, pediatrics, dermatology, neurology, proctology, IVF, orthopedics, vascular, and medical legal. We also did 4 webinars to update the changing trends of corona and the changing trends in the treatment of corona during this pandemic. Experts like the task force in charge, Dr. D.B. Kadam, Dr. Amit Dravid, and Dr. Bharat Purandare were always there to guide us during this pandemic. Our annual conference was held on 20th and 21st of November at Dr. K. Sancheti Hall, Neetu Manke House in a hybrid form. Till the time we reached to the conference, we were able to do a hybrid programs just like we are doing today. About 800 delegates attended the multi-speciality conference, in which we had reputed national and international speakers enlightening the delegates on 29 different topics. I should thank the scientific committee chairman, Dr. Padma Iyer madam, and Dr. Sanjay Patil, who finalized the topics and the speakers just in 3 days. Friends, in this conference, we had 3 important orations. Dr. Neetu Manke IMA annual oration was given by renowned cardiologist from Mumbai, Dr. Eric Borges, on palliative care in cardiac patients. Dr. Mohan Joshi IMA Bhushan Puraskar was given to renowned ophthalmologist from Shankar Netralaya of Bengaluru, Dr. Rohit Shetty. He delivered his oration on accidental scientist. IMA Pune annual NIO oration was given by renowned urologist Dr. Sanjay Kulkarni. He delivered his oration on my journey through urethra. All these talks were fantastic and all the members enjoyed it. Friends, last year, due to COVID, our IPP, Dr. Aarti Nimkar madam, was not able to give the prestigious IMA awards during her tenure due to COVID. So these awards were given in this conference during this multi-con. The prestigious IMA Pune Lifetime Achievement Award was conferred upon our mentor, our guru, Dr. Jayant Naurange sir, for his extraordinary work in the field of medicine as well as in IMA. IMA Pune Community and Social Award was conferred upon renowned oncosurgeon Dr. Sanjay Deshmukh for his excellent work in oncosurgery for poor and needy patients in Indrayani Hospital. IMA Young Achiever Award was given to Dr. Pooja Loda for her extraordinary research work in field of fetal medicine. Late Professor M.G. Shahade Award for Academic Excellence was conferred upon the senior most pediatrician, Dr. Anand Pandit sir. This conference was inaugurated by Chief Guest, Director General CSIR New Delhi, Dr. Shekhar Mande, and guest of honor for this program was our MMC President, Dr. Shivkumar Utture sir. In last year, we also did a state conference, that is MLCon. Friends, it was very necessary to learn how to practice medico-legally correct. And picking up this, our medical legal committee chairman, Dr. Jayant Naurange sir, meticulously planned a conference on this, and our incoming president, Dr. Meenakshi Deshpande, helped him a lot. We had excellent national speakers for this conference. It was very important conference to learn practicing medico-legally correct. It was very well supported by the state president and secretary. These academic programs not only help the members to keep themselves updated, but also fetch them MMC points, which are mandatory for the renewal of registration. And Dr. Dilip Sarada sir, MMC member, was a great help for us for collecting these points. Our medical legal committee, comprising of medical legal expert Dr. Naurange sir and Meenakshi madam and Dr. Zappe, conducted regular medical legal meetings every month to discuss the cases and help many doctors regarding that. Hospital board, headed by Dr. Sanjay Patil, was of great help to our members to solve challenges faced by hospitals during COVID. Hospital board helped hospitals for NABH accreditations. It helped hospital for registration, renewal of registrations. Friends, we had many problems regarding fire safety norms, nursing staff norms for this renewal. And time and again, hospital board chairman organized meetings to deal with these problems and approach the appropriate authorities for solutions. We expect hassle-free online hospital registration and renewal process. Our action committee was prompt enough to help our members in case of mob attacks on hospitals due to intolerant relatives and antisocial elements. We observed National Protest Day on 18 June 2021, declared by headquarters to protest against violence against doctors and healthcare workers. We have a zero tolerance policy regarding attack on doctors. Our MP Girishji Bapat visited our branch on the day we protested, and he assured us to bring this issue in Parliament. Friends, in our association, we have many sportsmen. Many of our members are good sportsmen, and we never lag in sports activities. Our sports chairman, Dr. Kedar Patil, organized various sports activities like table tennis, carom, badminton, and walking competitions. I'm proud to tell you that in IMA National Olympics at Nashik, our members, our branch has won 7 gold medals, 4 silver medals, and a bronze in different games. Our football team won the championship. Our members in the cultural activities are also on forefront. Our art circle chairman, Dr. Mohan Joshi sir, organized cultural programs like Devul Kase Pahave by Dr. G.B. Deglurkar and We also organized on a program on Journey to Antarctica by Dr. Madhubala Chintalkar. Both these programs were very inspiring. Our diary secretary, Dr. Raju Varyani, for our members, we at IMA come up with a financial diary every year. This year, Dr. Raju Varyani, the diary secretary, and his team came up with an excellent diary, which is a must on the table of each and every practitioner. And we will be distributing this diary to all the members as well as to all the branches of IMA in Maharashtra. This diary has got very good academic articles also. We are on forefront regarding social activities. Our members of hospital board started admitting COVID patients. They started COVID hospitals, which while working jointly with the PMC helped a lot to control the pandemic of COVID. Though we face lots of problems like in managing beds, procuring oxygen and requirement of the medicines, our members managed it to control this pandemic in this first situation too. Our members also helped government by starting private vaccination centers. At present, lots of members are facing problems regarding expiry of the vaccines. Our guest of honor has not yet come, but I would like to tell him that he should investigate into and help IMA regarding this expiry vaccines. We did almost 4 blood donation camps at different places for different blood banks in the time of blood scarcity. We did different awareness programs for society like breastfeeding awareness program, and awareness of milk banking was done by our ladies wing. Ex-MLA Dr. Medhatai Kulkarni was the chief guest, and about 400 women attended it, and she appreciated the social activity done by our women's wing. We also took awareness programs on COVID. Respected Mayor Muralidharji Mohar was the chief guest of a awareness program at IMA Pune, and it was attended on Facebook Live by a record number of people, that is about 8,000 people attended this program on Facebook Live. On Teachers' Day, we felicitated the deans of all the medical colleges in Pune city. We also started a COVID helpline of IMA Pune, which was inaugurated by Vijay Babuji Darda of Lokmat Group. He also appreciated the work that has been done by IMA Pune. We did a tuberculosis awareness rally on National Tuberculosis Day. We did blood pressure checkup camps for bank employees and found that many were unaware that they are hypertensive, and accordingly we guided them. CPR training activity is ongoing always in IMA Pune. We wish to do it in the next year too at many places. We also wish it to do at corporation level. Every year we distribute books to poor and needy medical students of BJ Medical College. This year, due to delay in the admissions, we were not able to do that, but in future we will definitely give these books to the needy students. In all these activities, friends, our members participate voluntarily and with great enthusiasm. Thank you for that. At association level, now I'm proud to tell you that we are the largest branch of IMA in Maharashtra, crossing the membership of 5,000 members. I should appreciate and thank Dr. Virendra Ostwal to take lots of efforts in the last hours to overcome that 5,000 bench and become the largest branch of IMA Pune. Our branch is not only the largest branch, but it is also the most vibrant branch all over India. I'm proud to tell you that. Our branch has won the Best Large Branch Award of IMA MS last year. our last year's president, Dr. Aarti Nimkar, was also awarded with Best Presidential Award at national level. Dr. Jayant Naurange sir got a special appreciation award for social security scheme. He looks after the social security scheme of the state, and the office is in our building, and we are doing excellent job in this social security. Thanks to Naurange sir. Due to the dedicated work of our branch, we could bag 6 office bearer posts and 5 CWC regular and 3 CWC alternate posts in IMAMS. We also could bag numerous posts at IMA headquarters. So I am proud that our seniors are leading at state level as well as the headquarter level. Friends, we also have medical students network. We help medical students in their problems regarding admissions, curriculum. Last year, there were lots of problems regarding admission, and as well as there were no physical lectures in the medical colleges. So there was lots of mental agony and disturbance in the medical students. So we at IMA organized a lecture on mental health given by Dr. Dhananjay Chavan for the students. Friends, we also have junior doctors network, and we regularly go and visit the resident doctors at Sassoon Medical College, and we try to understand their problems. During the COVID times also, they had problems for quarantine. We help them. We come up with our monthly magazine, IMA Plus. Friends, IMA Pune is the only branch that has a monthly magazine. All other branches come up with a magazine, say fortnight, every 3 months or 4 months. But IMA is the only branch which comes up with magazine every month, that is IMA Plus. We have very well maintained building, which was built due to grand donations from doctors like Dr. K. Sancheti sir and late Dr. Neetu Manke sir. We have been maintaining, and Dr. Kelkar sir. We are maintaining this building due to our building committee, which regularly meets in the building, and very small things are also repaired in time. With this, I would thank all my managing committee members, all my office bearers, especially my co-secretary, Dr. Alkashir Sagar madam, and my past president, all my past presidents, and especially our president, Dr. B.L. Deshmukh sir, for supporting me during my tenure as secretary of IMA Pune. And really, it was a learning experience for me. Thank you. Jai IMA, Jai Hind. Friends, now we have come to the award ceremony, prestigious award ceremony of IMA Pune. IMA Pune has a award committee, and every year we give 4 prestigious awards. The award committee has certain guidelines, criteria according to which they choose the awardees. And for this year, all the 4 awardees were chosen unanimously. The first award is IMA Pune Lifetime Achievement Award. This award is given to a senior academician doctor who has contributed a lot to IMA Pune's working as well as IMA State's working. This year, this award goes to Dr. Shyam Damle sir. I request Dr. Padma Iyer, madam, to introduce Dr. Shyam Damle. I request Dr. Shyam Damle sir and madam to come on stage. Sir, please. I request Damle madam to come on stage, please.
Congrats. Namaskar. Good morning, everybody. Dignitaries on the dais, Dr. Padma Vibhushan, Dr. K. Sanchiti sir, all the dignitaries of on the dais and off the dais. It's my honor and proud privilege to introduce Dr. Shyam Damle sir, a senior family physician and IMA Pune's a stalwart and one of the leaders who made IMA Pune its name and fame on the pedestal of IMA Maharashtra state and also national IMA, along with the other leaders like Dr. Bhutkar sir, Dr. Naurenge sir, Dr. Sarada sir, and many more who have really brought IMA a very, very vibrant branch, which you're all seeing, witnessing today. So first of all, Dr. Damle sir belongs to the 5th generation of medical practitioners, and his son, a pediatrician, he is the 6th generation of doctors in Damle family. So indeed, this is an unique achievement of the Damle family. Dr. Damle sir did his MBBS in 1971, and he was conferred with Fellow of CGP with silver medal in 1989. And he was the first scholar of AKN Sinha IMA Academy in 2000. He has got numerous achievements to his credit, and especially IMA MS. Dr. Damle sir had many award-winning papers in IMA National Conference in 1989, 1992 on survey of home visits done by family physicians and second non-disease respectively. Posts held by him till today at MS level, Honorary Secretary of College of General Practitioners, IMA MS for 5 years, and he initiated Pune as examination center for FCGP for 2 years. He was the Director of Studies, College of General Practitioners, IMA MS for 5 years. He worked as Honorary Secretary of IMA MS Social Security Scheme for 7 years and was involved right from its inception. Again now, in the year 2021-23, he has again been elected as Honorary Secretary, IMA MS, prestigious Social Security Scheme. He worked as Governing Council member of CGP in New Delhi. Dr. Damle sir has got many accolades in the local branch also. His achievements are President of IMA Pune 2002-2003. He initiated the concept of IMA Pune Financial Diary in 1989 and was secretary of the project for 3 consecutive years. He was involved in the process of starting GPCon, IMA Annual Conference in 1991, and which successfully ran for 25 years in the same name and still going on strong, but with a changed name as Multicon to change along with the changing times as a specialty conference. Incidentally, both the above projects are still one of the major revenue generators for IMA Pune till date. He worked as treasurer of IMA Pune New Building Project for 7 years. He was an IMA Pune Trust Board member and treasurer 2016-2021. I will end my introductory talk by saying that Dr. Damle sir is a man of very few words, but his actions speak volumes about his dedication, sincerity, and devoted hard work he has put in all these years in IMA. Kindly give him a big loud of applause to Dr. Damle sir, the recipient of IMA Pune Lifetime Achievement Award for 2022. Thank you.
Thank you. I request President Dr. B.L. Deshmukh sir to present IMA Pune Lifetime Achievement Award to Dr. Shyam Damle, sir. Damle madam to join. मी आता डॉक्टर श्याम दामले सरांना त्यांच्या भावना व्यक्त करण्यास विनंती करतो. दामले सर. असू दे सर, पगडी असू दे.
नमस्कार. सर्वप्रथम स्टेजवरचे डिग्निटरीज अँड ऑफ द स्टेज सर्वांना नमस्कार. IMA पुणे ब्रँचचे आणि ज्यांनी मला या सन्मानार्थ लायक समजलं अशा कमिटीचे मी धन्यवाद देतो. या प्रसंगी मी जर माझ्या वडिलांचं विस्मरण मला झालं तर तो माझा एक कृतज्ञपणा ठरेल. 1934 साली माझे डॉक्टर वडील 1934 साली पास झाले. 36 साली त्यांनी प्रॅक्टिस चालू केली आणि त्यांच्या मृत्यूच्या आदल्या दिवसापर्यंत म्हणजे 2001 सालपर्यंत ते अव्याहत प्रॅक्टिस करत होते. सिन्सिरिटी, रेग्युलॅरिटी अँड लव्ह फॉर मेडिसिन were his keywords, आणि he inculcated those keywords in our both of his son, that is me आणि माझा मोठा भाऊ. आता तेच तसंच माझा मुलगा ऋषिकेश हेही करतोय. या प्रसंगी मी डॉक्टर गोखले, आनंद गोखले यांचं देखील नाव विसरू शकत नाही, कारण मी जरी 76 साली IMA मेंबर झालो तरी मॅनेजिंग कमिटीत त्यांच्यामुळे 83 साली आलो. त्यावेळेला महाराष्ट्र ब्रांच आपल्याच बिल्डिंग मध्ये होती. आपलं ऑफिस छोटस खाली होतं, हॉल होता, एक छोटी मीटिंग हॉल होता आणि अतिशय छोटं असं ऑफिस होतं. त्यावेळेला डॉक्टर भोरगे जे खडकीला प्रॅक्टिस करायचे, डॉक्टर बोधे, वायजी बोधे जे 60-70च्या दशकात BJ मेडिकल मधनं पास झाले, त्यांना हे सर्जिकल युनिट मधले सर आठवत नक्की असतील. आणि डॉक्टर MG भिडे हे असे तिघ या दोन्ही ब्रँचची व्यवस्था चोख सांभाळायचे. ऑफिस बरंच वेगळे होते तरी फोर्स त्यांचा होता. कोइन्सिडेंटली त्या तिघांचं अल्फाबेटिकल इनिशियल वॉज B. तर पुण्याबाहेरचे लोक त्यांना बाजीराव म्हणायचे. डॉक्टर MG भिडे हे आतापर्यंत पुणे ब्रँचच्या हिस्ट्रीत पहिले असे आपले मेंबर आहेत की जे राष्ट्रीय लेवलला प्रेसिडेंट झाले, त्याच्यानंतर कोणी झालेलं नाही, त्याच्या आधी कोणी झालेलं नव्हतं. त्यांना पुण्याबाहेरील लोक किंवा महाराष्ट्राबाहेरील लोक त्यांना पेशवे म्हणायचे. काही मी तुमच्यातलाच आहे, मला तुमच्यासाठी तुम्हाला देण्यासाठी काही संदेश नाही किंवा मोठा बोधप्रद उपदेश पण मी करणार नाही. थोड्याशा आता जशा आठवणी सांगितल्या तशाच अजून 2-3 मिनिटं मी सांगणार आहे. सध्या ज्याला सीएमई म्हणतात त्याला पूर्वी जीबीएम म्हणायचे. जीबीएम म्हणजे जनरल बॉडी मीटिंग. आता ट्रस्ट मध्ये जीबीएम जेव्हा म्हणतात तेव्हा त्याला जोडून येणारा सगळा पॅराफर्नेलिया सगळा यायचा. म्हणजे जरी सीएमई असली तरी त्याची मिनिट्स ठेवायला लागायची, ती पुढच्या मीटिंग मध्ये पास करून घ्यायला लागायची. मग ते पास कोणी प्रपोज केलं, कोणी काय केलं ते सगळं लिहायला लागायचं. तर मुख्य कार्यक्रमाला असा खूप कमी वेळ मिळायचा. तो कार्यक्रम दुपारी व्हायचा, मंगळवारी किंवा बुधवारी, आणि त्याचं एक इन्व्हिटेशन एका पोस्टकार्डवर यायचं आणि मोठी त्याच्यात शेवटी लाईन असायची, हाय टी विल बी सर्व्ड ॲट 5:15. हाय टी म्हणजे चहा आणि बिस्किट एवढंच असायचं. हा एकंदर रटाळ कार्यक्रम पाहून 20-25 पेक्षा किंवा जास्तीत जास्त 30-35 पेक्षा कधी गणसंख्या हॉलमध्ये आली नाही. 82-83 साली डॉक्टर आनंद गोखले, डॉक्टर अशोक दीक्षित आणि त्यांच्या सहकाऱ्यांनी असं ठरवलं की आपल्या पूर्वी म्हणजे त्यांच्याही पूर्व लोकांनी एवढा मोठा हॉल, म्हणजे जुनी बिल्डिंग किती लोकांना पाहिले मला माहित नाही, चांगला मोठा हॉल होता, एवढा मोठा हॉल बांधलाय तर जास्तीत जास्त डॉक्टरांनी इथं आलं पाहिजे. म्हणून त्यांनी एक छोटीशी कू म्हणतात तसं केलं आणि डॉक्टर गोखले, डॉक्टर बेहरे, डॉक्टर म्हणजे सुभाष बेहरे, डॉक्टर रमेश डुमरे आणि असे 6 वेगवेगळे लोक निवडून आले आणि या जीबीएमच्या सभा संचालनाच्या पद्धतीत आमूलाग्र बदल घडवून आणला. सीएमई हेच नाव त्या जीबीएम ला देण्यात आलं आणि ती जी मिनिट्स वगैरे ठेवायचा जो प्रकार होता तो बंद झाला. डॉक्टर दीक्षित आणि डॉक्टर गोखले पदरमोड करून सीएमई ज्या रविवारी असेल तो वार बदलला, मध्ये सांगायचं राहिलं, तो वार बदलला आणि रविवारी सकाळी ती सीएमई व्हायला लागली. तर त्या आठवड्यात ते स्वतः पदरमोड करून फोन करायचे. हा अटेंडन्स 70-72 ते 100 पर्यंत तो पुढे जायला लागला. त्याच वेळेला आता ही जागा अपुरी पडतीये असं वाटायला लागलं आणि आपली नवीन मोठी जागा हवी हा एक बीज त्यावेळच्या मॅनेजिंग कमिटीच्या मनात जोर धरू लागला. त्यावेळी सगळे मेंबर्स अॅन्युअल मेंबर्स असायचे. लाईफ मेंबर्स फक्त आपल्या बुधराणी हॉस्पिटलचे डॉक्टर आर.बी. गुलाटी एवढे एकच लाईफ मेंबर त्यावेळेला होते. तर हे अॅन्युअल मेंबरशिप असल्यामुळे दरवर्षी फेब्रुवारीत सगळे पैसे जमवायला लागायचे आणि त्याचा हिशेब करून स्टेट आणि IMA सेंटरला पाठवायला लागायचं, म्हणजे ते त्यांचे वोटर्स लिस्ट तयार करायचे. पैशाची वानवा असायची हे सांगितलंच. 85-86 साली मी आणि डॉक्टर नवरंगे आमच्या नेहमीप्रमाणे कामाला आलो तर आमच्या बाहेरच्या बाईंनी सांगितलं आज जरा तुमच्यासाठी पाहुणे बसलेत. म्हटलं ठीक आहे, नेहमीच येतात हे पाहुणे. तर आत बसले होते असिस्टंट कलेक्टर. आम्ही त्यांच्याशी चहा वगैरे घेतला. ते म्हणले आम्ही एका महत्वाच्या कामाला आलोय, ही एक नोटीस असं म्हणून आम्हाला तुमची बिल्डिंग आम्ही जप्त करायला आलोय ह्याच्यासाठी आले. ते म्हटलं झालं काय? ते म्हणले तुम्ही बिल्डिंग बांधल्यापासून शेतसारा भरलेला नाही, नॉन ऍग्रिकल्चरल टॅक्स भरलेला नाही आणि त्याचा दंड पेनल्टी वगैरे धरून 20-22 हजार रुपये असा तो टॅक्स येत होता. म्हणलं असं त्यांना रिक्वेस्ट केली की आम्हाला 1 महिन्याचा अवधी द्या, आम्ही भरतो. ते म्हणले आज आहे काही तारीख होती तर पुढच्या याच तारखेला आम्ही येणार आणि इथे जप्तीची नोटीस दाखवणार. मी नवरंगे बाकीचे मॅनेजिंग कमिटी मेंबर त्याच्यानी थोडे पैसे जमवून 2 चेक मध्ये त्यांना ते पैसे देऊन टाकले. ही परिस्थिती बघून एकदा डॉक्टर आनंद गोखल्यांनी एका एक्स्ट्रॉर्डिनरी जनरल बॉडी मीटिंग मध्ये एक प्रेझेंटेशन दिलं की सध्याची जी 150 रुपये फी आहे ती खूपच अपुरी आहे, ती किमान 300 रुपये करून मिळावी. त्यांनी त्याच्यासाठी इतकं भारदस्त प्रेझेंटेशन केलं की श्रोते भारावून गेले. ते म्हणले 500 नाहीत, आपलं 300 नाहीत, 700 बरी पडेल. 700च योग्य आहे, 700 घ्यायला लागा. पण आम्ही पुढच्या मेंबरशिपचा वगैरे विचार करून त्यावेळेला 500 केली. आता मगाशी सांगितलं की ही अॅन्युअल फी असायची, ती फेब्रुवारीत जमा करायला लागायची. तर साधारणपणे त्याच वेळेला मॅनेजिंग कमिटीची निवडणूक व्हायची. त्यात ती निवडणूक टाळायची नाही असा एक डिक्टम होता. ती कशासाठी टाळायची नाही, तर कॅन्डिडेट्स आपापले वोटर्स घेऊन यायचे आणि मग त्यांची फी आम्ही त्या आमच्या एक उषा उत्तुरकर म्हणून बाई होत्या, त्या वसूल करायच्या. बाहेर ते कोण आलेत हे डॉक्टर, ते ससूनमध्ये मोठे डॉक्टर आहेत किंवा बाहेर त्यांची जोरदार प्रॅक्टिस आहे, त्यांना खूप मान आहे, याचा कुठलाही मुलाहिजा न बाळगता, अहो तुम्ही या इकडे, 500 रुपये राहिलेत, 500 हे ते द्रव्य देऊन पुढे जा. त्याच्यानंतर आम्ही सगळे लाईफ मेंबर केले. आता लाईफ मेंबर्स सगळे आहेत, अॅन्युअल मेंबर्स बोटावर मोडण्यासारखे असतील. तर त्यावेळेला दीक्षित, डुमरे, डॉक्टर गोखले आणि इतर यांनी जी योग्य दिशा दिली IMA ला, त्याच्यामुळे IMA ला चांगले दिवस आलेत असं मी ठामपणे म्हणू शकतो. मोठी जागा हवी असं स्वप्न बघायला भाग पाडलं त्यांनी आणि त्यासाठी कष्ट, त्याच्यासाठी केलेले देणग्या मिळवणे इत्यादी इत्यादी जाणं, या सगळ्याचा मी नुसता साक्षीदार नाही तर त्या वेळच्या ऑफिस बेररांचा साथीदार पण होतो. परत एकदा IMA पुणेचे आभार, समितीचे आभार, या मोठ्या लोकांच्या बरोबर माझा सन्मान केलात त्याबद्दल परत एकदा आभार. आणि आज नवीन टीम येते तर त्यांना पुढच्या वर्षासाठी शुभेच्छा. धन्यवाद.
थँक्यू सर. The next award is IMA Pune Community and Social Work Award. This award this year goes to Dr. Dilip Kadam sir for his extraordinary work, social work. He has helped the government a lot during this COVID situations. And he is a teacher to many of us. We know him. I request Dr. Rajan Sancheti sir to introduce Dr. Dilip Kadam. Dr. Dilip Kadam will be joining us online.
गुड आफ्टरनून. नमस्कार सर, जॉईन झालेले आहेत. It is a privilege and honor to introduce Dr. Dilip Kadam sir, well known as DB Kadam sir. Actually, I would say this is a great opportunity in front of our chief guest, Dr. K. Sancheti, Padma Vibhushan, introducing another stalwart, Dr. DB Kadam sir, well known in all of the consultant in government sector as well as private sector, doing is, I would say, a great work in this COVID. First, I would introduce sir. Sir passed out with MBBS from BJMC 1978, did his MD medicine in 1982, teacher since 16th March 1983, PG teacher since 32 years. In the morning, I heard from Dr. Suhas sir about him. All of whatever the problem, they used to consult Dr. DB sir. Sir, University, Baltimore, USA. TRG member for adult HIV medication at NACO. Total publications 48. Management of H1N1 flu epidemic in Pune. Prepared management protocol. Management of COVID-19 epidemic, all three waves. Chairman of COVID-19 task force for Pune division, all 5 districts. And all are aware the work done by him. It was, I would say, excellent, and we are really blessed to have him. So his faculty in national and international conference, attended COVID training programs, sent from a lot of, I would say, CMEs, and so also brief us personally, our IMA members, for international and national webinars. So I'd like all of you to give a big applause. Thank you, sir, for being an inspiration to us.
DB कदम सर जॉईन झालेले आहेत ऑनलाईन. तर थोडक्यात तुमच्या भावना व्यक्त करायची विनंती करतो मी ऑनलाईन. सर बोला. हा येस सर
ऐकायला येते ना. So to start with, first respected presentation, K. Sancheti sir and the dignitaries on dais. It's my honor to get this particular award, and I'm thankful to IMA Pune, Dr. B.L. Deshmukh, Sunil Ingre, Alka Shirasagar madam, and all other the members of IMA. I have frequent the acquaintance regarding and discussions for the management of COVID with Bondwe sir, Mantri sir, Naurange sir, Sanjay Patil, and Dilip sir. It was the great opportunity pandemics and can be a front runner for that particular thing. As far as swine flu is concerned, it started in Pune. Pune was the first city to have cases. So preparing protocol for the treatment management and disseminating it throughout the country was a great job which I could do. I could take the various training programs in Bangalore, Jaipur, Delhi, all over, and for government as well as for private sector. And then came this COVID, and the COVID also, the Pune model which we tried and they established in the swine flu. We tried to repeat the same, so we could manage a large number of patients in a very short time. And it was fortunate for me to work in Sassoon General Hospital continuously for 34 years. And that gave me the opportunity to serve the poor and the needy patients per se. Now in coming on about the fourth wave, if there is no further mutation after BA2, we don't expect any fourth wave, but with the infrastructure which has been prepared with the help of the administration and all of us, we are all geared up to take on to any wave, and any further pandemic can be successfully tackled with the experience which we have of these two pandemics. I'm again thankful to IMA for giving me this prestigious award, and I wish we should go ahead with any further medical emergency which comes in Pune and tackle all of us together. I wish a very good success for the new incoming IMA team for their role in that. Thank you very much.
I request Dr. B.L. Deshmukh sir to present this award to Dr. Dilip Deshmukh and Dilip Kadam sir. कॅमेरा झूम करून दाखवा.
Thank you, sir.
Thank you. Thank you, Kadam sir.
Thank you.
The next award is IMA Pune Young Achievers Award. This award goes to Dr. Lakshmikant N. pulmonologist. I request him to come on stage. Yes. I request our IPP, Dr. Aarti Nimkar Madam, to introduce Dr. Lakshmikant N.
Good afternoon, good noon, not afternoon. Dignitaries on the dais and of the dais and our chief guest, Dr. Sanchiti sir. I am here to introduce our recipient of the Young Achievers Award, Dr. Yange. Mrs. Yange is here. Can you come on the dais? Dr. Lakshmikant Yange is MBBS MUHS, MD in the internal medicine, DM in the pulmonary and critical care medicines from the Chandigarh. Now his current profile is consultant pulmonologist, pulmonary medicine and critical care in Dinanath Mangeshkar Hospital, Pune. His degree and his current profile shows that in Dinanath Mangeshkar Hospital in the COVID situation, how much he had work. And without taking care of his own life, many doctors are worked very hard, and among them, Dr. Yange is there. And in the future, in his future also, he wants to offer to the patient the state-of-the-art evidence-based care in the field of the pulmonology. Then he wants to bridge the gap in holistic care of the patients, especially thoracic diseases, in the collaboration with the thoracic surgeons and specialists. He doesn't want to work alone, but he wants to do the team work. It is a specialty, and to improve the treatment to the patient. And he research in the field of the interventional pulmonology and diffuse parenchymal lung diseases. And he wants to give the training to the future generation of the physicians. It is his greatness that he doesn't want to give his knowledge to the limited to him, but he wants to share his knowledge and train the future physicians. Then academic career, during his academic career, he is on the top of his mark list and had the gold medal in the international medicine. And he is having the comprehensive training in the internal medicine with the rotational through all the specialties like the hematology, rheumatology, nephrology, endocrinology, gastroenterology, hepatology, cardiology, and neurology, and pulmonary medicines. Successfully completed the courses in the research, methodology, and biostatistics in the 49th batch of the PG-IMER in 2010, and subspecialty, that is DM pulmonary and critical care medicine, in 2012 to 2015, and attended the various CMEs in PG-IMER Chandigarh from 2008 to 2010, and there are the subject related to the specialty, that is pulmonary diseases and its treatment, also the liver diseases, and perspective in the liver diseases, and World Heart Failure Society Congress. There are so many congresses he has attended, and he has done 18th month of the respiratory ICU exposure, predominantly catering to the patients with the multi-organ failure requiring mechanical ventilation and other advanced life supports. 10 months of the cold pulmonary OPD and IPD management of the diseases like COPD, asthma, ILD, sarcoidosis, pulmonary diseases, mediastinal diseases, and lung cancer. 2 months of the respiratory laboratory predominantly focus on the polysomnography of the and the treatment of the obstructive sleep apnea. 6 months of the interventional pulmonology with the hands of the experience of the diagnostics and therapeutic bronchoscopy, conventional TBNA, endobronchial ultrasound guided transbronchial needle aspiration, rigid bronchoscopy, tracheobronchial stenting, and medical थोरॅकोस्कोपी. हे असे बरेच कोर्सेस त्यांनी केलेत आणि त्याच्यात खूप चांगलं ट्रेनिंग घेतलंय, जी काही नावं आपल्याला काही वेळेला डोक्यावरनं जातात. आणि ही इज एक्सपर्ट इन दॅट. अँड he has attended multidisciplinary lung cancer management courses conducted jointly. And he also worked as a fellow in digestive diseases at Tata Medical Center, Calcutta, with the special focus on the endoscopic ultrasound guided FNA. To the complement for EBUS TBNA for the complete mediastinal staging in the patients with the resectable lung cancer. Having teaching experience, he is having the teaching experience of the 8 years, and he is having research work in the pulmonology and ICU training, and he is having he is a co-author and author of the many publications. And I welcome. त्याचं कसं आहे की मूर्ती लहान, काम महान, and it is Lakshmikant.
Now I request President Dr. B.L. Deshmukh to present him with Young Achievers Award of IMA Pune. मी लक्ष्मीकांतला रिक्वेस्ट करतो की अगदी थोडक्यात तू मनोगत व्यक्त करायचं.
First of all, thank you IMA Pune for showering so much of love on me. I have had opportunity to speak in lot of conferences. I can remember at least 5 or 6 in last 1.5 years. And I think that is how I got introduced to IMA and eventually resulting into this award. So my philosophy has been to do good and good will follow you. Good will happen to you. So that's all I can say. So I just continue to do good work and try to breach areas which are not touched by others. So that is something which I can always vouch for. I do not try to take a common path. I always take a path which is less traveled. Just to give you an example, if somebody said Harrison is the pathway to get PG entrance exam, I did not go to Harrison at all. I followed the other path. I started from anatomy, physiology, biochemistry, and then reached there. So if somebody said you have to mug up the MCQs, I did not read the MCQs. I went to the theory. So similarly, after MD medicine, I was searching for a specialty where I could do the difference. And people said that follow a common path, take cardiology, take neurology, take nephrology, you will settle early. I said, no, I want to go to something else, which will keep me connected more to broader medicine. So I went to pulmonary medicine and critical care, just thinking that critical care will keep me hitched to all the specialties. However, eventually in practice, I realized that practicing critical care is not going to serve the purpose what I want to serve. So I switched the gear again. My wife wanted to work at a hospital where she can do transplants. So I had to go to a hospital where I can do something different. So I went to gastroenterology. So I tried to do GI endoscopy fellowship so that I can do all the endoscopies at bone marrow transplant center or cancer hospitals, which again eventually did not materialize. We had to change gears and then we ended up in Pune. So when I was doing internship, actually I had decided I'm not going to come back to Pune, but then eventually I ended up back in Pune. So in 10 years, the things have changed so much. So coming to the present situation, what I do is I try to do pulmonary medicine and primarily pulmonary medicine, where I try to elevate the pulmonary medicine branch beyond the tuberculosis. So looking beyond tuberculosis in pulmonary medicine is what something which is on my horizon for next 5 to 7 years, and beyond that I might change it to something else. So with that, I thank you IMA for giving me this opportunity and giving me the responsibility to keep improving. Thank you.
Thank you, Lakshmikant. Now, Pune is fortunate to have a good pulmonologist uh, like Lakshmikant. Now, the next most important award is late Professor Dr. M.G. Shahade Memorial Award for Academic Excellence and Research. To tell us about this award, I request Dr. Aarti Shahade Madam. Raju Variani, sir.
Thank you, Dr. Sunil. Late Professor Dr. M.G. Shahade. This is the 4th year of this award. This award is instituted by late Dr. M.G. Shahade's son, Dr. Ambrish Shahade, and wife, Dr. Aarti Shahade, madam. So they have instituted this award for their father. The past recipients of this award are Dr. C.S. Yajnik, Dr. S.B. Kedkar, and Dr. Shivdev Bapat. I would like to tell you something more about late Professor Dr. M.G. Shahade. He was born in Chikodi in Belgaum district of Karnataka. He was from a very economically poor background. He completed his schooling in Chikodi, then he came to Maharashtra where he did inter-science in SP College, Pune. When he was doing inter-science at SP College, he was simultaneously working as a ticket boy at Minerva Theatre. Then he got admission in BJ Medical College, Ahmedabad. At that time, that medical college was the largest in Bombay province. He was the first gold medalist in the subject of surgery. After doing post-graduation in that same medical college, the state of Gujarat granted him a special scholarship to go to Vellore to do specialization in thoracic surgery. In 1961-62, their batch was the first batch to do specialization in thoracic surgery. Then he came back to Gujarat. He was the youngest HOD Department of Surgery, youngest civil surgeon, and youngest superintendent of government hospital, Surat and Jamnagar. He started thoracic department in Jamnagar and Surat medical colleges. He was author of the modified railroad technique, which is mentioned in Bailey and Love's textbook of surgery. That procedure is known as Shahade and Shah procedure. Dr. M.G. Shahade had passion for teaching. He used to love teaching. He was very, very favorite among his undergraduate and postgraduate students. Dr. M.G. Shade then came to Pune in 1972, where he started his practice. He was very popular among his patients because he never denied treatment to the poor and needy. We are very thankful to Dr. Ambrish Shade for instituting this award, which is an inspiration for the generations to come. Thank you.
This year, this award goes to Dr. Vaman Khadilkar. I request Dr. Arti Shahade Madam and Dr. Shahade Sir to escort him on stage. Yes. Now I request Dr. Jayant Naurange Sir to read the citation.
Respected dais, in particular Padma Vibhushan, Dr. Sancheti sir, Dr. Bhutkar sir, yes sir, incoming and outgoing presidents, and today's awardee, Dr. Vaman Khadilkar. It's my privilege to read out this particular citation, which is written and particularly drafted by our expert, Dr. Mandara Paranspe. He is expert in this. So he has been doing this for IMA for last 10 years. So we give him your biodata and he does the work. And many times I read his citation which I have prepared. So I will read it out. Respected Dr. Vaman Khadilkar sir, we are immensely pleased to confer the IMA Pune late Professor Dr. M.G. Shade Award for Excellence in Research and Academics 2022 upon you in appreciation of your mammoth contribution to pediatric endocrinology. After mastering the art and science of pediatric and adolescent endocrinology during your postgraduation in the UK, you brought this new specialty to the Oxford of the East. You have been serving pediatric endocrinology through a variety of roles, such as Senior Pediatric Endocrinologist at Jahangir Clinical Development Center, Professor of Pediatric Endocrinology and Guide for Pediatric Endocrine Fellowship at Hirabai Kavasji Jahangir Medical Research Institute, PhD teacher at Savitribai Phule Pune University, reviewer of several national and international journals, convener of Growth Charts Committee and co-convener of Vitamin D and Calcium Guidelines for Indian Academy of Pediatrics, and so on. In a research career spanning over a quarter century, you have completed a half century of research projects with special focus on childhood growth and growth disorders. You have established long-term research collaborations with reputed institutes, both Indian and overseas, like Tata Memorial Hospital, Mumbai, Mayo Clinic, USA, and Royal Manchester Children's Hospital, UK. Your current research work forms the proverbial backbone for a large study of bone age assessment in Indian children using 3 different methods of assessment, namely Grolick, Pyle, Gilson's Ratib, and Tanner Whitehouse. Besides being the editor-in-chief of the books on a variety of topics, you have written as many as 185 articles in index journals and won 28 prizes for your research presentations. From S.G. Desai Oration in 2006 to P.G. Sundaram Oration in 2019, you have been the most deserving recipient of several prestigious awards. You have taught pediatric endocrinology at 2 institutes, namely Bharati Vidyapit Medical College and HCJMRI for 2 decades each, and guided 20 PhD students over 1 decade at SPPU, that is Pune University. Actually, he has been our teacher in a whole lot of pediatrics because this specialty was brought to our shores by him. Sir, your passion for pediatric endocrinology is matched by your compassion for children with endocrine disorders. The department headed by you at Jahangir Hospital looks after the medical needs of around 500 diabetic children totally free of cost. Sir, befitting your name Vaman, your gentle, soft-spoken, mild-mannered, but extremely capable true self has conquered the entire spectrum of pediatric endocrinology through your three-step contribution of clinical care, education, and research. You have been ably assisted by your equally qualified better half, Anuradha Madam, who has also taken active participation in your research projects apart from doing her own independent work. Let this citation be a medium to convey to you, sir, our limitless appreciation of your spotless service to the care of ductless glands of countless children. Yours sincerely. Thank you.
Now I request President B.L. Deshmukh sir to present the award to Dr. Vaman Khadilkar. I request Aarti Shahade Madam and Ambrish Shahade sir to join the felicitation. Now I request Dr. Vaman Khadilkar sir to give his speech.
Good afternoon, everybody. Honorable Dr. Sancheti sir, Dr. B.S. Deshmukh sir, all the dignitaries on the dais and off the dais. First of all, I would really like to thank IMA, all the officials, the committee who decided to select me for this award, Dr. Naurange sir, Dr. Sarda sir, Dr. Shahade. As you just heard, this city is the Oxford of the East, and to receive an award in the academic excellence in itself is a tremendous honor for me. In fact, विद्येच्या माहेरघरी विद्येचा अवॉर्ड मिळणं हे फार मोठं भाग्य समजतो मी. I'm going to be very quick, so I'll just say a couple of things. When I was getting trained at Great Ormond Street Hospital in London, Professor Charles Brooke, who happened to be my boss, said, "Why are you going to India? We didn't waste the NHS money on you so that you could go to India. If you really want to do something, do molecular endocrinology, go to United States. You tell me where you want to go and I'll send you now." So I said, that's not what I want to do. I would like to go back to India. There's nothing like pediatric endocrinology, which is well established. And that's where my journey of return to India started. And in 1997, when Dr. Anuradha, my better half, and I returned, we had two goals in mind. Of course, to extend services to patients. That's the primary responsibility as a doctor. But more importantly, to look at the research side of things and the academic side of things. And when we arrived here, the entire pediatric endocrinology is based on growth of children. And we didn't have proper growth charts for Indian children. So one of my major contribution over the last couple of decades is to produce the first scientific growth charts for India, which the Indian Academy of Pediatrics accepted in 2015. And they are now the national growth charts which are used all over. And to my very pleasant surprise, when I went to Mount Sinai Hospital in New York, for Indian children, which they have a sizable number, they actually use the IIP growth charts, which is absolutely wonderful. Another contribution you just heard, we have done work on calcium and vitamin D metabolism in children. And the collaboration is with University of Manchester, and Professor Zulf Mughal, who received the award for that last year in America, actually had put up a slide which made me very proud. The first slide said, "Bone disorders in children, a tale of three cities." And that was Manchester, Cincinnati, and Pune. So it's an absolutely wonderful thing to see that on the slide. And the last contribution that we have done in terms of academics is we started the first pediatric endocrine fellowship training course in Maharashtra. It was the first one in Maharashtra and only second in India. And we till date have continued. I would like to say two lines for the younger generation, that you need to believe in yourself. No matter what people say to you, you definitely listen. Often the derogatory remarks take you much forward than backward. So it's important to listen to people, draw your own positive clues from it and go ahead. But more importantly, you have to believe in yourself. You have to be honest, hardworking, and equally important is leave your space of comfort. Unless you leave that and venture out to new avenues in life, you're not going to get anywhere. And as Jonas Salk, the American virologist, said, the reward of work well done is the opportunity to do more. And you have rewarded me with an award. So I'm going to do more and more now. So once again, this award is a great honor to me, and I'm extremely grateful to IMA for conferring this award. And I would once again say that I am again on the first step of the ladder to achieve something more and more in pediatric endocrinology. So with those words, I would once again like to thank all of you. Thank you very much.
Thank you, sir. Thank you for your inspirational words. Yes. Now I request our President B.L. Deshmukh sir to give the Presidential Appreciation Awards for last year.
Respected Chief Guest, Padma Vibhushan, Dr. K.S. Sancheti sir, dignitaries on the dais and off the dais. कालच गुढीपाडवा झाला. आज एक दुग्ध शर्करा योग आहे की डॉक्टर संचेती हॉलमध्ये डॉक्टर संचेती आपल्याला गेस्ट ऑफ ऑनर म्हणून लाभलेले आहेत. हा सगळा दुग्ध शर्करा योग आहे. Dear friends, I am coming to the end of my tenure 21-22 as a president of IMA Pune branch. This is my last communication as a president with you. It is almost end of COVID era. I hope this will come in reality. I thank Government of India, almost 175 crores vaccination done. I thank Pune Corporation, Cantonment Corporation, private hospitals for vaccinating Pune citizens. 2 vaccination doses and 1 booster dose. Now vaccination is going on for the children at the age of 12 to 18 years. My year started with the COVID restriction, but we conducted online CMAs and other activities. Now, since last week, we have started hybrid CMEs, conferences, meetings. Now wearing mask is also gone, but you can wear voluntarily. Hope world moves in well speed and enthusiasm. In spite of COVID vaccination, we arrange our yearly conference, Multicon, and medical legal conferences. MMC universal registration for the IMA members facilitated at IMA premises. Up till now, 200 members got benefited. IMA Pune branch has bagged so many awards. Dr. Sunil has narrated in very well. Sir, I am happy to share that our branch is largest branch in Maharashtra and number 4th branch in India. We have 5,000 members. IMA Foundation Day was celebrated on 31st May. I had donated IMA building mural to the IMA and mounted in President Chambers. In my presidency, some special visitor, Mr. Girish Bapat, Mr. Murlidhar Mohan, Mayor of Pune, Mrs. Kulkarni, Medatai Kulkarni, past MLA, and Bharati Pawar, Central Health Minister at Dr. Bondwe's house. IMA Pune has two strong points, HBI and medical legal sales. HBI मध्ये आपले 200 मेंबर हॉस्पिटल मेंबर्स आहेत आणि डॉक्टर संजय पाटील आणि पद्मायर समर्थपणे हे काम करत आहेत. दुसरं मेडिकल लिगल सेल अंडर द एबल गायडन्स ऑफ डॉक्टर नवरंगे सर and Subhash Bebe. We have helped and solved medical legal problems about 24 doctors up till now. तिसरं एक आमच्याकडे एक ऑटोमेटेड इलेक्ट्रॉनिक डिफिब्रिलेटर आहे. मला वाटतं आतापर्यंत कुठल्या ब्रांच मध्ये हे असं नसेल. My special thank to our trust board members. Special thank to Jayant Naurange sir. I thank all office members and my managing committee members for time to time support. My special thanks to Secretary Dr. Sunil Ingade and Dr. Alka Kshirsagar. President-elect Dr. Meenakshi Deshpande. I am one of the super senior to work at this year as a president of Pune, but I was ably taken care of all you. Whatever I had done best because of you all. If there is any lacunes, I am because of me and I am responsible for that. I wish you all happy and healthy and prosperous life year ahead. Now, the next president is Meenakshi Deshpande, as well a well-known gynecologist. He will took over from today onwards. I wish all the best to her and her team. I am sure she and her team raise the bar higher, no doubt about it. I thank all IMA staff, Aniket, Pooja, Neha, Kavita, Santosh, Shede, Dhavde, for smooth functioning of IMA day-to-day practice. At the end, I can say, ख्वाहिश ये बेशक नहीं थी कि तारीफ हर कोई करे, मगर कोशिश ये जरूर है कि कोई बुरा नहीं करे. Thank you, sir.
Thank you, sir. Thank you very much. Now I request Dr. Jayant Naurange sir to introduce our incoming president, Dr. Meenakshi Deshpande.
माननीय व्यासपीठ सर, फार वेळ घेणार नाही, अगदी थोडक्यात बोलता. सर, ते मला कल्पना आहे की सरांचं खूप बिझी शेड्यूल असतं आणि विल बी ब्रीफ अँड गिव्ह द इम्पॉर्टंट सॅलियंट फीचर्स ऑफ मीनाक्षीज बायोडेटा और इंट्रोडक्शन आय कॅन से अँड पर्सनल बायोडेटा ऑल्सो. तर आपल्या सगळ्यांना मीनाक्षीला इंट्रोड्यूस करताना मला खूप आनंद होतो आणि थोडक्यात सांगायचं म्हणजे शी वॉज बॉर्न इन पुणे अँड हर एज्युकेशन ऑकर्ड इन to the great extent in Pune, though her father was an electrical engineer in the central government service, so it was a transferable job. आणि त्यामुळे इनिशियल तिचा सगळा जो शिक्षणाचा भाग झालाय तो केंद्रीय विद्यालयामध्ये झालेला आहे. त्यानंतर त्यांचा एक मॅटर्नल अंकल मिस्टर पांडुरंगी, who was a brilliant student and a brilliant research worker in Ferguson College, developed brain tumor. And that is why ultimately he died after a thorough fight for about 4 to 5 years. So the grandparents asked the parents of Meenakshi to send her to Pune so that they will look after her and bring her up. And this is how the destiny has its own role to make a person to what level she is today. So after seeing the struggle of that maternal uncle, she took her passion further to become a doctor and to alleviate the pain of the people who are suffering. So मला असं वाटतं असं एक fascinating असं example आहे. So she has been brought up by the maternal grandparents. She was educated in later on with Karnataka High School, Pune, and then of course BJ Medical. She has done undergraduation and post-graduation both from BJ Medical College. A very astute student, आणि तो जो वारसा आहे ना तो काही प्रमाणामध्ये from her grandparents. Mr. Pandurangi, a great scholar and literary scholar from Karnataka, is her kaka azoba, and rest of the things I already mentioned about this. Basically, she is a workaholic and would do only her work, academics, and her practice, and won't be mixing much. So to some extent, you can't call it really introvert, but tendency was towards introvert. And it's only after Dr. Biniwale, and who is incidentally becoming the president of POGS this year, and Meenakshi is also becoming president of IMA Pune this year, and Dr. Bharti Dore Patil, Dr. Anand Shinde, and Dr. Shirish Patwardhan. Then she started mixing with the POGS activities, and then she had certain posts held in POGS. Later on, she joined IMA Pune the managing committee way back in 2015. So really speaking, from a person who is self-satisfied or engrossed with the self-work, going into the social work and that of the various academics bodies is her journey in last 15 years. आपल्याला जर असं बघायचं असेल की ज्या व्यक्तीला इतर सगळ्यांबद्दल आदर वाटतो ते एक व्यक्तिमत्व म्हणजे मीनाक्षी आहे. माता, पिता, श्वशुर आणि सासूबाई आणि आपली मुलं आणि त्यांचे संसार हे आदर्श गृहिणीचं लक्षणं धरली जातात. आणि मला सांगायला इथे खूप अभिमान वाटतो. हे बायोडाटात आलेलं नाहीये, हे मी माझ्या पर्सनल माहितीवरून मी सांगतोय की शी हॅज लुक्ड आफ्टर द बेड रिडन father in law and mother in law for more than 12 years, where she had done a terrible sacrifice of her all academic career as well as practice career. हे मला वाटतं खूप जाणून घेण्यासारखं आहे की that shows how much care she is giving to the society at large, from family to the society. त्यांना दोन she is happily married to my colleague whom I knew for several years before I came in to know about Meenakshi, and that is Dr. Anand Deshpande, who has been past IIP president, and as well as he is in the executive body of the national IIP, and a great academician, and was a teacher in BJ Medical, and now he is also practicing in his own small setup as well as Dinanath Mangeshkar Hospital. She has the first son who is taking the video, I suppose, who is sitting in the first row, Chinmay, who is MD psychiatry and recently started practice. His wife is Apurva. तुम्ही सगळ्यांनी तिला पाहिलंय की जे ईशा स्थवन म्हणता ना, she is a gynecologist. And another son is Chirag, who is serving after post-graduation as an engineer in USA. तर ही त्यांची सगळी फॅमिली, त्यांची आई पण इथे आलेली आहे, वहिनी भाऊ पण आलेले आहेत, त्या सगळ्यांचं आपण इथे स्वागत करतोय. And coming to the teaching experience, 3 years of teaching experience in obstetric gynec society as an obstetrician and gynecologist, as a registrar, senior registrar and chief resident from January 1989 to 1991. And she has had her own thesis under Manning score for assessment of fetal well-being by ultrasonography under Dr. Vishwas Yevle. She is a postgraduate teacher to MBBS students doing postgraduation in obstetric gynec since 2004 till now, and a postgraduate teacher in DGO at Sanjeevani Hospital, Uttamnagar. As an organizational experience, I already mentioned that she started taking part in the organizational activities rather late because she had to sacrifice her career because of the domestic issues. And she has been working in POGs and Pune Obstetric Gynec Society since 1995, as a treasurer, joint secretary, clinical secretary, and in IMA Pune since 2015. आणि आपल्याकडे प्रेसिडेंट होताना तो पक्क्या मुशीतनं वरती आलेला प्रेसिडेंट असतो. म्हणजे पहिल्यांदा ज्युनियर मोस्ट सेक्रेटरी, त्याच्यानंतर सेकंड लेवल ज्युनियर सेक्रेटरी, कम ज्युनियर ट्रेजरर, देन सिनियर सेक्रेटरी, मग ट्रेजरर, मग व्हाईस प्रेसिडेंट, मग प्रेसिडेंट. तेव्हा तो 9 वर्ष पक्का भाजून झालेली ती वीट असते. तेव्हा त्याच्याबद्दल मी जास्त सांगायला नको, आणि याच्यातनं खूप एक्सपिरियन्स तिला मिळालेला आहे. शी हॅज बीन अ व्हेरी गुड ऑर्गनायझिंग सेक्रेटरी फॉर IMA MS Maharashtra State Jericon in 2018 and Pune Multicon in 2017, treasurer of IMA MS Mastercon in 2019, and organizing co-chairman of Multicon in 2 consecutive years of 2020 and 2021, has several publications to her credit. I won't go in those details for the shortage of time. She has received some important awards. It is IMA headquarters Dr. Kanak Goyal Award for exemplary work in women's health and family planning and safe motherhood, IMA MS President's Appreciation Award, and IMA Pune's President's Appreciation Award, and Doctors Day Award from Rotary Club Shanwarawada, and Apulki Samstha Award for Social Services. She has special liking for obstetric ICU cases and has managed practically all sorts of emergencies for obstetric and gynec emergencies. And she has special liking for infertility and endoscopy procedures, gynec oncology, menopause and women well-being, and women cancer prevention, and that particularly through colposcopy, since she got trained in 2011. Right now, she is working with Ramakrishna Math OPD and has conducted several camps for the poor and the needy. So she is a socially committed lady doctor. And I would end my introductory speech by saying the few famous statements by the topmost people like Brighton Young, that contrary to the male-dominated world, women provide and facilitate are the powers, grace, wisdom, justice, creativity, hope, selflessness, show the confidence and courage. And that's how she has come up to this stage. And this is a very difficult responsibility to be a president of IMA Pune. And I'm sure she will go a long way. I think another famous quote I will take here, that you educate a man, you educate a man, single man, you educate a woman, and you educate a generation. With this, we request Dr. Meenakshi Deshpande to accept this presidentship, and I hand over the mic back to the secretary, Dr. Sunil Ingle.
Yes, now I request President Dr. B.L. Deshmukh sir to hand over the medallion and felicitate incoming President Dr. Meenakshi Deshpande and her spouse. Dr. Deshpande sir, please come on stage. Now I request President Meenakshi Deshpande Madam to felicitate IPP Dr. B.L. Deshmukh. Madam, yeah, now. Deshmukh madam, please. Yeah. Now I request President Meenakshi Deshpande madam to give her acceptance speech.
Respected Chief Guest Padma Vibhushan Dr. K. Sancheti sir, Executive Trustee Dr. Sanjay Patil, Chairman Trust Board Dr. Avinash Bhutkar sir, Dr. Jayan Naurange sir, IPP Dr. Deshmukh sir, all respected guests, seniors of the dais, on the dais. I'm really overwhelmed. I have got no words to speak. And let me thank you all for the tremendous faith which you have bestowed on me to take over as the president of this prestigious, vibrant, and active IMA Pune. I am extremely humbled to climb this step of ladder because I know I'm standing on the shoulders of the giant workers of IMA who have already taken IMA to such a level that it is really a glorious Indian Medical Association Pune. I promise I will try to put in my best efforts to see this crowning glory shine further. I have a dedicated team of office bearers, which I will introduce to you shortly after this. And slowly it has has become my passion. During this journey, I realized that coming together, because we are coming together from all branches of medicine, it is not only a gynecological society or a pediatric society or physicians, we are multi-consultants. And all consultants coming together is a beginning of progress. Keeping together is the real progress, and working together is the success of progress. Over these years, I realized that Dr. Sanjay Patil, Dr. Padma Iyer, Dr. Aarti Nimkar, Dr. Raju Varyani, Dr. Rajan Sancheti became my pillars of support. Senior gems of person like Dr. Shahade sir, Dr. Marathe sir, Nene sir, Mohan Joshi sir, Dr. Damle sir, Dr. B.L. Deshmukh, immediate past president, Dr. Hilary Rodrigues, Dr. Vaijayanti Patwardhan, Shrikant Kelkarji, all became my lighthouses, my Dhruva Tare, who showed me the right way. All my efficient and committed friends became friends in need, like Dr. Madhuri Lokapur, Prashant Chaudhary, Ashutosh Jappe, Dr. Chajed, Nandakishore Mantri, Dr. Karne. Their contributions are priceless. Secretaries like Dr. Sunil Lingre, Alka Kshirsagar, Gitanjali Sharma, Kedar Patil, and the newly joined Dr. Virendra Otswal, and the whole youth brigade became my eternal volcanoes of enthusiasm and talent, along with Dr. Sachin Lakde, Dr. Sachin Sangamnerkar, and Anil Dudbhate. Unke kya kehne, because there are all the budding talents of IMA Pune. So respected sirs, I am really fortunate to work in Indian Medical Association Pune branch, which is now one of the largest and the vibrant top 5 branches in the country and the largest in Maharashtra state. It has more than 5,000 active members, multi-consultants, and many 80% of them are above MBBS and postgraduates. The territorial jurisdiction is Pune Municipal Corporation. All of us, sir, are coming here voluntarily and have come together for common passion, that is to increase our unity, brotherhood, give good academic programs, to reach out to our own fraternity in times of their need. Albert Einstein has, just like Albert Einstein has quoted, that the only source of knowledge is experience. And IMA Pune is the best example of that. Because it is so true of IMA Pune that we have been through many nice as well as harsh experience, bitter experiences, which have taught us so many more things than what was taught in our curriculum. It is only IMA who fights and works for commonly based problems like medical legal issues, hospital-based issues, violence, licenses and rules, registrations, MMC issues, and along with it gives frequent high-quality good academic programs with MMC points. Presently, we are now passing through a difficult stage of post-COVID scenarios of recoveries of practice. We are coming back to our original practices, but there is severe rise in the maintenance costs. There is severe rise in the daily working of practice. So looking at the road ahead, it looks very turbulent to me and like a roller coaster ride for a private practitioners. We as doctors, especially of small and medium hospitals and clinics, are now rising from our ashes and yet burning in the fires of corona pandemic. More than 2,000 doctors have lost their lives during the pandemic, and many more have faced the brunt of close down of clinics. But there are many more working to their full strength day and night for the well-being of society and human race. Right from our medical students junior network to junior doctors network, all are under severe stress and are made to work under duress. The latest case, as you must have all known about, the Dr. Archana Sharma. So respected sirs, we as doctors would like to work in the safe, calm and secure environment and good working conditions. Then only we can give our best to the patients. But many times we are unable to do so. We are disturbed, we are apprehensive, we are ever worried over untoward and unwanted experiences by patients' relatives and for unexpected incidents which can occur during handling our patients. And Dr. Sanjay Patil and Dr. Naurange sir would surely vouch for that the newer authorities are coming with newer rules, and the implementation of that for our clinics and general practice is very much hazardous. As latest is the heart-wrenching story of Dr. Archana Sharma, gynecologist from Rajasthan, who saved many lives during her tenure, but when she couldn't save one from a natural complication, an FIR of 302 IPC was slapped on her. And such a great humiliation for just to save a life with no criminal intent. And we doctors are ever working to just to save human lives. So we would like to work in tandem with all the authorities and in tandem in association with all our colleagues. So this is my vision for this year. To protect your healers. That is my theme for this year. And I plan to have some out of box thinking ideas to implement this theme. We have got a new set of people coming into IMA Pune, and I would request all of you to implement and carry out new ideas, to carry out our new mindset and new result. That is the logo. Innovate, inspire, impact, and influence. That is the logo which can go and take us forward into our improvement of IMA working and clinics working. As one of the newer ways was to organize and formulate a fully online course of diabetes mellitus, which was planned meticulously by Dr. Shahade madam. And it has not only oversubscribed, but the registrations are nearly full. They're yet going on, but we have got a full registration mode for this. Also, as a starter for the theme of Protect the Healers, I'm planning to distribute the Maharashtra Medicare Act to all the clinics. And I would like Dr. Sancheti sir to release this. Can you have a set of... This is a Maharashtra Medicare Act in which also got a charter of patients' responsibilities as to how they should be behaving and how they should be carrying out their responsibilities when they come to a clinic or when to approach a consultant. And plus a Maharashtra Medicare Act in which every clinic should have it, so that the people attending or waiting in the waiting room will read that and know that there are stringent laws available for those who have those who can do harm to the clinicians and the personnel working in the clinics. Second plan is to have a CPR training for all the staff, because we have got an AED, that is an automatic electronic defibrillator, donated by one of my class friends, Mrs. Kamla, and we would surely felicitate her for that when she comes to Pune. This will have a CPR training not only to the layman, but also to all the building committee members, and also to those people who are in management of large crowds, because they are the ones who will go and do the CPR in case of accidental unconsciousness of any person. The third aim of in my tenure will be an improvement to work for common goals like improving the medical legal knowledge and improvement in the knowledge of the hospital laws of any practitioner, because ignorance of law is not an excuse. So we have to say that we are a whole family of 5,000 members, and I want each of us to improve their knowledge, stay fit, and grow younger day by day. You have to enjoy life and its activity. Do not get overworked. Do not get stressed. Do not be burdened. When the goings get tough, the tough should get going. And we should become tough and get ourselves armed with all the knowledge and the know-hows. And that is the cover of my IMA Plus magazine, which will come shortly reach out to you every month. Not only by post, it will also reach out to you by WhatsApp and by emails. So stay fit, stay healthy, stay young, and stay active. And last but not the least, this will be my message for all the family of 5,000 of IMA Pune members. And last but not the least, I would profusely thank from the bottom of my heart my husband, Dr. Anand Deshpande, a pediatrician by profession, who has been a constant support for me. My angel mother, Dr. Mrs. Nanda Kanekal, without whose efforts I would not be a doctor today. And my brother, Mr. Chaitanya Kanekal, who has continued faith in my thinking and my activities. My elder son, Dr. Chinmay Deshpande, who is a psychiatrist, and whose wife is Apurva, who are a source of encouragement and critical appraisal of me. And my younger son, Mr. Chirag, who is constantly in awe of me and praises my multitasking nature. So, Anugrahita Asmyaham, I am truly blessed. I'm truly blessed with all the support of the family members as well as the seniors from IMA and from the POGS. So, I would also request all the Corona warriors to share their inner thoughts with us anytime in need, but suicide is not the answer. And that is my final message to you all. So I would now request Dr. Chief Guest, Dr. Sancheti sir, to release the Medicare pamphlet. Thank you, sir. Thank you one and all. Thank you all.
थँक्यू डॉक्टर मीनाक्षी. आम्ही सर्व ऑफिस बेरर्स तुझ्या पाठीशी आहोत 1 वर्षासाठी. सो 1 वर्षासाठी. So don't worry, at least this year we will be all, every year the team changes. Isn't it? Yes, thank you. I will request now our Chairman Trust Board, Dr. Avinash Bhutkar sir, to introduce our chief guest, Dr. K.H. Sancheti sir.
Today's chief guest, Dr. K. Sancheti sir, other dignitaries on the dais and in the audience. सरांना आज खूपच लेट झालाय आणि त्यामुळे ते रेस्टलेस झालेत. म्हणजे सरांचं एरवीचं स्माईल त्यांच्या चेहऱ्यावरचं गायब झालेलं मगासपासून बघतोय. आणि म्हणजे आता त्यांना प्रॅक्टिसला लागून सन 65 पासून आतापर्यंत म्हणजे 57 वर्ष झाली. हे 2 मिनिटात कसं सांगायचं मला कोणी समजावलं. पण मी तरी त्यातले सेलियंट पॉइंट सांगतो की जे म्हणजे ज्याला आपण म्हणतो ना एखाद्या अभंग तयार करावा तसं. ही comes from a very poor family. म्हणजे he was born in a very poor family and he had to pay for his education through his own work. इथून या माणसाचा जो प्रवास सुरू झाला त्यांनी नंतर डिग्रीज काय काय मिळवल्या. MBBS, FCPS, MS ऑर्थो, FRCS एडिनबर्ग, FACS USA, PhD and also DLIT एवढ्या पदव्या मिळवल्या. He started his own hospital and in 1965 he started working for a social cause of betterment of polio affected children. आणि त्यांनी डायग्नोस्टिक आणि ऑपरेटिव्ह कॅम्प्स फ्री ऑफ चार्ज करून thousands of rural needy children were benefited. As many as 437 such free camps have been held and more than 1 lakh disabled children have been treated. 12,050 surgeries carried out to correct deformities and 20,200 calipers were provided to needy children free of cost. म्हणजे हे एवढं वर्क. नंतर he started his Sancheti Institute of Orthopedics and Rehabilitation in Pune in the year 1972, which is now a 200-bedded orthopedic and trauma hospital and is ranked as one of the best 3 hospitals in India. त्यांनी तिथेच संचेती अकॅडमी चालू केली आहे. त्याच्यामध्ये MS ऑर्थो, D ऑर्थो, ग्रॅज्युएट अँड पोस्ट ग्रॅज्युएट कोर्स इन फिजिओथेरपी, पोस्ट ग्रॅज्युएट डिप्लोमा इन हॉस्पिटल मॅनेजमेंट याचं टीचिंग सगळं दिलं जातं. आफ्टर पोलिओ he has now shifted, or since 1990 he shifted his focus to old age patients suffering from arthritis, and he developed the first indigenous total knee replacement prosthesis, Indus knee, at an affordable cost. And Dr. K. Sancheti is the only one amongst 30,000 orthopedic surgeons in India with the unique distinction of designing indigenous prosthesis for knee and hip replacement surgeries. He has trained over more than 300 orthopedic surgeons during the last 50 years, and he is an outstanding role of model for punctuality, discipline, and patient care, as all of us have witnessed. He has conducted workshops, live surgical demonstrations, not only in India, but also in Sudan, Nigeria, Kenya, Oman, and many other neighboring countries. He has been not only recognized by doctors or our fraternity, but Government of India, they have honored him with Padma Shri in the year 1991, Padma Bhushan in the year 2003, and then Padma Vibhushan in the year 2012. Some other awards which are to his credit are, I'm going to narrate only few. Fellowship of Royal College of Surgeons, Edinburgh, United Kingdom in the year 2004. Lifetime Achievement Award by International Medical Integration Council in the year 2004 at the hands of Honorable Shri Mohammad Fazil, the Governor of Maharashtra. International Award for Medical Excellence in the year 2005 by Harvard Medical International School, USA. Dr. B.N. Sinha Meritorious Award in the year 2015 by Indian Orthopedic Association. Dr. B.C. Roy Award, the most prestigious award in the field of medicine, at the hands of Sri Pranab Mukherjee, Honorable President of India in the year 2017. Presented Bharat Gaurav Award for Distinguished Services to the Nation and Outstanding Individuals Achievement at the United Nations Headquarters, New York, on 9 June 2017. Awarded Punya Bhushan Award at the hands of Sri Nitin Gadkari ji, Central Minister, on 27th August 2017, and awarded Nobel Puraskar by the Nobel Foundation India at the hands of former President of India, Srimati Pradeepa Patil, on 17 December 2021. This is a very, very, very concise introduction to Dr. Sancheti sir. And as far as IMA goes, we know that this particular hall is because of his donation that we could construct and erect this particular building. We all know that we could construct this building out of the contributions or donations received from our own members, and he was one of the biggest donors. Thank you, sir.
Thank you, sir. I request our chief guest, Dr. K. Sancheti sir, to say a few words. Means, sir, it will be very much needed for us.
Outgoing President Balasaheb Deshmukh and incoming President Meenakshi Deshpande, my all friends, dignitaries here, there. In fact, I have brought my lecture typed and written, but I don't want to use it because it will take more time. I want to finish in short time. IMA in Pune, so 94-year-old organization, can last, and not only last, can grow and grow, is only and only because of the doctors who have dedicated for this cause, taking care of their practice and spare time instead of spending here and there, utilizing here how to grow, how to go educate people and whatnot and whatnot. Any association has got certain responsibilities to protect their members, educate their members, and grow in the way that the members are benefited by this organization. This particular organization, biggest 5,000 members, biggest in Maharashtra, and one of the 3 biggest in India, is really remarkable. I salute all the members here, senior members, who has brought this institute to this level. Our incoming President Meenakshi Deshpande, you have read the advice to the doctors, and I concur 100% with them, and I don't repeat, but we have to always follow whatever she said, and then we'll be successful. Nowadays, doctors have to face so many other problems which are not really concerned with the medicine. Therefore, they must know what is medical legal aspect, law, little part of the law, and also they should know accounts, because we doctors are very poor in accounts. I can give you one small example. One of my friend received one notice from Income Tax Department a couple of years before, and he was so much afraid. For 3 days, he didn't open the letter. And when he opened the letter, it was written there that your excess payment of tax is returned herewith. So that is the situation with all doctors. So please be sit with your chartered accountant, know basic We don't want to become the nice. Sit with your lawyer, know basics of this, and especially for doctors, what precautions they should take, how they should talk, what things they should be have labeled, etc. That was only the things I can say. I thank you, Dr. Deshmukh and others, for giving me this opportunity to be the chief guest, and thank you very much for listening to me.
Thank you very much, sir, for your valuable guidance. Now I request. So now I request Dr. Gitanjali Sharma to give vote of thanks. Sir, I'm right. Sir, yes, sir. Sir, just a minute. Sir. सर थँक्स
फक्त थँक्स देते सर सगळ्या टीम तर्फे नाही संचेती सरांना फक्त थँक्स म्हणते
थँक्यू
Still, all of us will be waiting here. Sir wants to go. So, Sanchiti sir. No, I will only do. Now I will request our president, Dr. Meenakshi Deshpande, to introduce her new team. One, like this.
Yeah, so we continue with our program because Sancheti sir had to go. So we just took the last part in the center. So few things are remaining, like I will introduce my new team now. We got the batches. Yes. So I'll start with President-elect Dr. Raju Varyani, the ever jovial, ever smiling personality. He will be our President-elect now. Photo gap. Our Vice President will be Dr. Rajan Sancheti. Is he there in the auditorium?
I think he's not.
Okay. Treasurer will be Dr. Sunil Ingre. Okay. The secretaries will be Dr. Alka Kshirsagar, will be the first secretary. A big clap for her, because now she will be holding the responsibility. Responsible post, second responsible post is Dr. Gitanjali Sharma. Second secretary. Dr. Kedar Patil will be the joint secretary. And our new addition is Dr. Virendra Otswal, orthopedic surgeon, who has gone down, I think, in the auditorium. Okay. Dr. Deshmukh sir is our immediate past president. Yeah. Oath will be managing. Okay, so many members are yet absent over here. So the oath will be taken in the managing committee. And I would thank all the dignitaries in the audience who have come. I would like to thank Dr. Parag Biniwale, President POGS, who's attended the program. Dr. Bahar Kulkarni, who has come all the way from Sanjeevan Hospital. Then Dr. Gulavani sir and madam were there, but I don't think they're there now. But they had also attended the inauguration ceremony. So I thank them all. And also I thank all those seated in the audience for attending the inauguration ceremony. Thank you all. Dr. Rajan Sancheti, Vice President, who will be in charge of the diary now, the diary project of this year. Anybody else? Oh.
Yes, sir. ठीक है.
Dr. Ostwal, please come on. So now I have to do a pleasant task of vote of thanks. Oh, sorry. So a new team has arrived, and if you have noticed, president and both secretaries are women. So this year IMA will have a strong women power, of course, with the strong support from all our brothers. All the past presidents. And if you have noticed, we all are wearing blue saris. गगनात निळ्या घ्यावी भरारी उत्तुंग निळ्या सागरासम कार्य असावे अथंग. तर या सगळ्या ह्याच्यातून इतकी सुंदर कल्पना आली की निळ्या रंगाच्या साड्या नेसू आणि विविध छटांच्या या साड्या आहेत. थँक्स द्यायचे तर खूप जणांचे द्यावे लागतील. मेन तर संचेती सरांचे आहेत. एक पितृतुल्य व्यक्तिमत्व आज लाभलं आम्हाला आशीर्वाद द्यायला. तर त्यांच्या आशीर्वादाने आणि सगळ्यात सिनियर लोकांच्या आशीर्वादाने ही टीम एक न्यू विजन घेऊन एक न्यू ऍक्शन ठरवून एक न्यू इम्पॅक्ट नक्कीच एस्टॅब्लिश करेल याचा मला विश्वास आहे. आणि डॉक्टर मीनाक्षी देशपांडेंच्या अगदी स्ट्रॉंग अशा प्रेसिडेंट लीडरशिप खाली the whole team will work the best. And I thank everyone who came today to give their blessings and their best wishes for the new team. I wish to also thank all the awardees, mainly Dr. Shyam Damle sir. त्यांचं नेहमीच सगळ्यात मार्गदर्शन असतं. आज सर तुम्ही विथ मॅडम आलात, धन्यवाद. Also Dr. Dilip Kadam sir, who could not attend but attend online. IMA Pune is very grateful to Dr. Kadam sir and also the Young Achiever awardee, Dr. Lakshmikant Yenge and his wife. Special mention is for Dr. Shahade Award. Dr. Vaman Khadilkar sir came specially. Thank you, sir. And special mention of Dr. Ambarish sir and Dr. Aarti madam for the award, and they came personally. The citation was made by Dr. Mandar Paranspe. As every year, IMA Pune team wishes to thank Dr. Mandar Paranspe. Today's Ganesh Vandana was specially sang by Dr. Apurva. We request her to come on the dais. Dr. Apurva Deshpande. हा एक छान योग आहे की सासू सुना दोघी गायनेकोलॉजिस्ट आणि सासूच्या हस्ते सुनेचा सन्मान आणि सासूच्या छान दिवशी सुनेने ईशस्तवनाने सुरुवात करणं. सांगते Special thanks to Vittal Shamshet Mirajkar. For mementos, I wish to thank Dr. Vithal Shamshet and Mirajkar and citations Rohan Arts. थँक्सच्या बरोबरच डॉक्टर मीनाक्षी मॅडमनी त्यांच्या स्पीचमध्ये जो उल्लेख केला, नुकतीच एक दुःखद घटना घडली राजस्थान दौसा येथे. वन गायनेकोलॉजिस्ट डॉक्टर मिसेस शर्मा येस Sharma committed suicide, and IMA Pune has condemns the action of police. Unnecessary त्यांच्यावर 302 लावलं गेलं. याच्यासाठी प्रोटेस्ट म्हणून काल इथे मोठी मीटिंग झाली. त्याला बऱ्याच असोसिएशनचे पदाधिकारी, POGS, रेडिओलॉजी वगैरे हजर होते. त्याचबरोबर IMA चे सगळे पदाधिकारी हजर होते आणि आम्ही याविरुद्ध आपण ऍक्शन घेतली पाहिजे असं हे पास केलेलं आहे आणि त्या दृष्टीने आपण ऍक्शन घेणार आहोत. आज डॉक्टर मिसेस शर्मा यांना एक श्रद्धांजली म्हणा असं म्हणून वर केळकर हॉलमध्ये आपण एक कॅन्डल मार्च आता यानंतर लगेच आयोजित केलाय. अँड आय रिक्वेस्ट ऑल ऑफ यू टू प्लीज कम टू द केळकर हॉल अँड पे आर होमेज. आणि असा पुन्हा कधीही कुठल्याही डॉक्टरच्या बाबतीत घडू नये असा संकल्प आपण सोडायचा आहे. तर आय रिक्वेस्ट एव्हरीबडी टू अटेंड दॅट. नाव आय रिक्वेस्ट एव्हरीवन टू राईज फॉर नॅशनल अँथम. एक छोटेस काम आहे. डॉक्टर नवरंगे सरांना मी रिक्वेस्ट करते एक वर्ल्ड बुक ऑफ रेकॉर्ड्सचा अवॉर्ड डॉक्टर संचेतींना त्यांनी प्रदान करा.
थोडक्यात ब्रीफ मध्ये सांगतो, हे अवॉर्ड जे आहे ते मॅक्झिमम हेल्थ कॅम्प्स चे कंडक्ट केले. सर वॉज अ पार्ट ऑफ दॅट लास्ट इयर अँड इट्स अ ग्रेट ऑनर टुडे ऑन दिस डे ही इज रिसिव्हिंग द सेम. इट इज अ मेडल as well as certificate both together. And request more IMA doctors to come with us and have a World Book of Records. आणि सरांचं कॉन्ट्रीब्युशन खूप मोठं आहे. So I congratulate him for the same and thank you all IMA doctors.
National. जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल वंग. विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग. तव शुभ नामे जागे तव शुभ आशीष मागे. गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे जय. सर्वांनी वर केळकर हॉलमध्ये या.
गोळा करा सगळे आणि नंतर आम्हाला द्या क्लिनिक मध्ये लावायला.
काय करायचं?
For online listeners, please note that we'll be here within 20 to 25 minutes. After the lunch, we'll take a very short lunch break and we'll be there. So please be there by 2:30 at least. We'll start by 2:30.
IMA आहे हे उदय सरांचं आणि हे थामस सरांचं उदय वळके सरांचं हे IMA आणि हे जे सेशन
अच्छा त्या तारखेचं फोल्डर बनवायचं आणि तिथे कॉपी करायचं 9 तारखेला आहे संध्याकाळी त्या विजय फोन कर
अरे आता मी हॅलो पीयूष, कॅन वी स्टार्ट?
Yes, ma'am, you can.
Yes. Good afternoon, all. Now we are going to start our afternoon session, and it's a topic of endocrinology. And we have eminent speakers like Dr. Uday Phadke, Dr. Sajal Kamath, Dr. Sheetal Mahajani, and Dr. Mannan Doshi. To chair this session, I'll be calling our cardiologist, Dr. Suhas Hardas sir from Sahyadri Hospitals on the dais to moderate this session. Dr. Suhas Hardas, in the morning, everyone has been introduced to him. He's a renowned senior cardiologist in the city of Pune. His outstanding skills in complex angioplasties, device implants, and various forms of cardiac therapies. He's a gold medalist at various levels, and he heads the Department of Cardiology at Sahyadri Group of Hospitals. He's a national and international faculty. So the second chairperson is our own IMA managing committee member, Dr. Ravindra Chajed. He's a physician, and he's got a Harsh Hospital on Bibewadi Kondwa Road. And he's very much known for his all academics and all his practice. And he's working in Ruby Hall Clinic at Vanaudi in ICU department. So, and he has another also many social work also he's doing. So I'll request Dr. Ravindra Chajed sir to come on the dais. I'll hand over to Dr. Suhas Sardas sir.
Good afternoon, ladies and gentlemen. I think to speakers, don't get dejected that we have a very less audience here because there are a lot of people who have logged in, and I think we have an audience close to 300 or 400 today. Because that's a very, very big incentive for a speaker on the dais to give the best. But I think even if I allowed Dr. Uday Phadke to speak at a spinal level, in the middle of the night, he can wake up and give a wonderful lecture. His deliberations have been fantastic. I have myself been an ardent follower of his speeches and talks. And you can imagine that I've been his room partner, though I'm speaking good about him. So this is really genuine. He is the director of endocrinology and diabetology at Sahyadri Group of Hospitals. And he has an entire force working with him. And he is going to take Sahyadri Group to the forefronts in terms of what he can offer in management of metabolic disorders, diabetology, endocrinology, etc. He has been a faculty at national, international levels. He has multiple publications nationally, internationally. And I think he loves to teach, and you will now soon realize that he is a great speaker. He is going to be talking about hormonal dysfunction in PCOD and its proper line of management. Over to you, Uday. Thank you.
Thank you, Suhas, for those kind words, and real pleasure to be back in the IMA hall after such a long hiatus. Congratulations to the new managing committee, which has taken over the functioning of the IMA from today. And thank you for this invitation to be part of this program. In a short time today, I'm at least going to touch upon few of the aspects of a biggish syndrome called polycystic ovarian disease or polycystic ovarian syndrome, and give you a brief perspective of what we do in this. It's impossible to touch very details of all of these aspects, but I'll try and cover quickly whatever I can. Polycystic ovarian syndrome is extremely rampant. It's a part of the new age metabolic syndrome that we are seeing across the world, with increasing weights, changing lifestyles, differences in menstrual patterns, and altogether, what it really means finally is it's just a combination of some kind of hyperandrogenism, whether it is biochemical or clinical, and some kind of ovulatory dysfunction. What it means, therefore, is, in a nutshell, people have irregular periods or no periods, or very long gaps between periods, and they have some form of hyperandrogenism. It could be hair loss, it could be acne, it could be alopecia, it could be hirsutism. So ultimately, the diagnosis of polycystic ovarian syndrome is entirely clinical. And when you have these two things coming together, hyperandrogenism and ovulatory dysfunction, and having ruled out certain common disorders, like for example, acromegaly, Cushing's, hypothyroidism, hyperprolactinemia, which look like that, and of course, congenital adrenal hyperplasia, what you're left really is polycystic ovarian syndrome. So it's markedly a clinical diagnosis. And of course, it's not a single disease, and there are many components to it. Apart from the ovulatory dysfunction and the hirsutism, there is a significant metabolic component to it, which includes, of course, type 2 diabetes, dyslipidemia, NASH, obstructive sleep apnea, enhanced risk of cardiovascular disease, and so on. So the diagnosis is entirely clinical. It does not require a specific test. We see huge amounts of money being spent on tests done to diagnose PCOS. We don't really need one. As I said, the diagnosis is clinical. But essentially, there are three things that we need to know. Any two of the following in the absence of other diseases. So either ovulatory dysfunction, clinical or biochemical hyperandrogenism, or ultrasound criteria, which means more than 12 follicles, roughly between 2 to 9 millimeters, ovarian volume more of 10. But essentially, if you look at it, statistically, 90% of women who have irregular periods and hirsutism actually have PCOS, unless they have one of these, which you need to actually exclude. So the tests done really are to exclude these diagnoses rather than prove in a diagnosis of polycystic ovarian syndrome. There are certain pointers in examination when we look at this patient. They're obese more often than not, although lean PCOs are known. They have significant degree of acanthosis nigricans, which is a marker of insulin resistance. They have hirsutism, or they may have male pattern hair loss in women. So typically frontal hair loss, that is very common. Sometimes in extreme cases, you may have increased muscle mass and clitomegaly. So these women look pretty hefty and well built. And sometimes there is Cushingoid features, stripe, buffalo hump, and all of these may not necessarily be due to Cushing's, but hyperandrogenism and hyperinsulinism both can cause these kinds of features. And of course, look at acromegaly features. I'll just show you some. So this is a typical example of a hyperandrogenic milieu. Lots of acne and a typical frontal recession of the hairline. Very typical with polycystic ovarian syndrome. A very marked pattern of hirsutism and acanthosis nigricans. Of course, these are uncommon. I mean, you often do not have such severe hirsutism, but we do come across these patients very often and never miss these. This is a case of acromegaly who is referred as PCOS, but you can see her facial features, very prominent eyes, prognathism, arachnodactyly, large fingers, build is heavy. Don't miss out on these. And you can see here that this child again was sent because this child was developing a lot of hair on the face. Look at the puffiness. And this is a case of exogenous Cushing's treated by quacks for so-called childhood asthma. And this is what he has come with. And this is an adult Cushing's, which is endogenous cortisol production. The earlier one, of course, was due to exogenous steroids. Now, when we come to testing in polycystic ovarian syndrome, as I said, there are no real tests to prove the diagnosis of polycystic ovarian syndrome. There are tests to be done to rule out actually that we are dealing with anything else. So one thing that we need to know is how bad is the androgen status. Tests to rule out other diseases presenting as PCOS, like hypothyroidism, hyperprolactinemia, Cushing's, adrenal tumor, CAH, and acromegaly. And the last set of tests is tests relevant to the associated metabolic syndrome. If you're looking at the androgen status, the best test still is testosterone. I often see huge numbers of tests being done. Testosterone, free testosterone index, SHBG, delta 4 androstenedione, androstenedione, androstenediol, DHEAS, DHEA, and the list goes on. Patients have spent more than 20,000 rupees by the time they have come to us. for something which could have been done about 400 or 500 rupees, and that's a total testosterone. Believe me that this is still the most relevant test if you want to look at androgen status. Also understand that available assays are open to error. The best test is what is called LCMS, but it's not very commonly available. It's expensive. But by and large, also remember that even in patients who are significantly hirsute, you may not find elevated testosterone. That is something which is to be clearly understood. But this is one of the best tests. The real value of testing androgen is to rule out tumors. So if the values are high, you suspect tumors rather than polycystic ovarian syndrome. So that's something which is very important. Free testosterone, don't ask for free testosterone. It's a difficult test to perform. The assays are not very well standardized. And again, this free testosterone is also dependent on the amount of the sex hormone binding globulin, which again is dependent large number of factors. Best not to do a free testosterone. Only thing is testosterone, forget free testo. This is something which is very commonly and blindly done, and that is DHEAS. Remember that DHEAS is a precursor of testosterone, and it is formed predominantly in the adrenals. Understand that DHEAS in the body is ultimately converted to testosterone. So if you're measuring testosterone, you don't need to measure DHEAS separately unless and until you're thinking of certain kinds of congenital adrenal hyperplasia or adrenal tumors. But that's a specialty thing. In general, we do not need DHEAS. And the funniest part is that people also advise DHEA, which is spontaneously converted to DHEAS. It's pointless doing these investigations unless you're dealing with something very specific. This is one test which can be done. It's rather expensive, costs almost $3,000. Androstenedione, which is the immediate precursor to testosterone. But again, I'm telling you, even if you do a testosterone, that's good enough. This is something which is interesting, and that is dihydrotestosterone. This is the final end product in the pilosebaceous tissues. So testosterone goes to the pilosebaceous tissues and gets converted to what is called 5-alpha reductase into dihydrotestosterone, which is a final product. And in number of women, you will find who are hirsute or who have acne, their testosterone is normal, but DHT can be elevated because the final conversion at the periphery is exaggerated. But you don't need to do this. If you do this, you will find it in many people, but you really don't need to do this again and again. The only test for androgen is testosterone. Test for oligomenorrhea. And rather than, I would say, test for oligomenorrhea, I would do the FSH and LH to mainly rule out that this patient is going into premature ovarian failure. I'm not really bothered whether the FSH is 5 and the LH is 16. It doesn't tell you a diagnosis of PCOS. It's immaterial. Unless you're dealing with infertility, you want to use some kind of downgrading protocols and those kind of things. But otherwise, this is immaterial. AMH, often high in PCOS, but no cutoff value given, so can't be used in diagnosis. Prolactin, extremely important test, but extremely misused. Borderline elevations of up to 50 nanograms per ml are very common with just the stress of venipuncture, different at different times of the day, can go up even after a bath because of a physical stimulation of the breast, can go high because of variety of drugs. And of course, PCOS itself has slightly higher prolactin. Do not treat this. I see a huge number of overtreated patients with cabergoline. Remember that although the doses used are not high, cabergoline has some valvulopathy action. So remember that it should not be used randomly. TSH must be part of the evaluation because hypothyroidism also causes that. The only other test outside this is to rule out congenital adrenal hyperplasia, and a baseline 17-hydroxyprogesterone is good enough because the commonest enzyme defect is 21-hydroxylase deficiency. For other kinds, you will have to talk to an endocrinologist because there are different types of enzyme defects leading to different types of precursor elevations. As I said, in ovarian and adrenal tumors, it's mostly the testosterone, which is very high. And of course, you need a CT or MR for that. In Cushing's, when you're suspecting Cushing's, as I showed you, the child or that lady, the first test to do is a baseline cortisol. The baseline cortisol, if it is low, it tells you that the patient is being given steroids exogenously. So any person who looks Cushing's and has a low cortisol means that person is receiving exogenous steroids. If that cortisol is not low, then you do a dexamethasone suppression by giving dexamethasone at night, and the next day's value should be less than 1.8 micrograms per deciliter. If it is not, you're dealing with Cushing's. Again, to just show you, this child's cortisol done in the morning, normal value being, let's say, if it is around 10, 15, this was 0.1, abused with steroids. And this lady's cortisol was 25, and after giving dexamethasone, it did not come down. So this is typical exogenous Cushing's. For acromegaly, we do growth hormone and IGF-1, but I'm not going to go into that now. This is the typical acromegaly, which I showed you. And this, never forget. So tests for metabolic syndrome. And I think in current age, the most important implication of PCOS diagnosis when it is seen, especially in young girls, is to caution them about future risk of the entire full-blown metabolic syndrome. So blood glucose, HbA1c, lipid profile, and of course liver test, because NASH is extremely common nowadays. Serum insulin testing is also very rampant, and I have my reservations about that. I don't know what exactly you achieve by doing a serum insulin outside some research protocols, but essentially the hyperinsulinemia markers are staring at you. A person who is obese, centrally obese, acanthosis nigricans, low HDL, high triglycerides, has insulin resistance syndrome. You don't require this serum insulin. It's all humbug. It's been popularized, and I don't see why, but that's a separate topic. When we are approaching treatment, we are basically looking at reducing androgen excess. We are looking at normalizing periods, and we are looking at reducing the future risk of metabolic syndrome. To reduce androgen excess, one of the most important things is to suppress the FSH and LH, which are kind of abnormal in a pulsatile fashion. And one of the best ways to do that is to use oral contraceptive pills. GnRH agonists and antagonists, I'll leave for another day. It's a little too much in detail, but basically remember that one of the first line drugs in PCOS is actually oral contraceptive agents. And we have to have a lot of conversation with the mothers, because typically somebody has already told them that these things are bad and they cause uterine cancer and breast cancer and all kinds of nonsense. So there has to be a lot of discussion on the use of OCPs, especially in young girls. Then there are androgen synthesis inhibitors like spironolactone and finasteride, which we use very commonly. And then, of course, you have also some selective androgen receptor degraders, which are used in topical use like dimethyl curcumin. There are not too many products available there. In those with CAH, we use glucocorticoids, but that's very rarely, very sparingly. And one such drug which is used very commonly with PCOS is metformin. It has a multitude of actions. It does to some extent reduce insulin resistance, but it has a number of other factors as well. It improves insulin signaling. It reduces to some extent the hypertrichosis in the ovary, and to some extent does reduce the androgen production and also stimulates ovulation. So on a general basis, metformin is useful, but again, needs to be used in caution because a lot of women do get metformin intolerance as well. All the modern pills contain now small dose estrogen. The progesterone has to be wisely chosen. And there are again different types of progesterone. I can't go into them, but some of them are drospirenone and cyprotron acetate. They are basically anti-androgenic progesterones. So they are used not only to provide the progesterone, but also to get a anti-androgenic effect. And therefore, they work very well in reducing the hirsutism part of it. Spironolactone, very well used drug, except it can't be used alone because it often causes significant menstrual irregularity. But essentially, spironolactone and finasteride are two very commonly used drugs which we can combine with the oral contraceptive pills. Something which has come up to light now is that previously we used to believe that it used to be only menstrual irregularity and hirsutism. But we now also have what are called single component diseases like just acne or just alopecia or just hirsutism with normal periods. And often these are also part of polycystic ovarian syndromes. And the treatment essentially is the same: oral contraceptive pills plus minus anti-androgens or just two anti-androgens together. So to conclude and summarize, the overall approach is lifestyle modification for all, because unless you do that, the metabolic syndrome will never revert. OCP is to begin with, especially if irregular menses and severe hirsutism. Add anti-androgens later, plus of course cosmetic therapy as required. Metformin, some influence on ovulation, some influence on insulin resistance, and essentially use long term. I have seen many prescriptions being told to the patient that you cannot take OC pills for more than 3 months. Take it for 3 months, stop, give a gap and come back. No, this is a long-term thing. You may stop or you need to stop 2 months prior to conception. So I'll end here. Thank you very much for this invitation again. And if there are any time for questions.
There would be some time.
Certainly.
Hello. Yeah, we could probably take a couple of questions. I will have one question because I'm supposed to ask you a question. I'm moderating this session. whereas if I'm a cardiologist, you have a question, then I'll go by your question first. Okay, my question was, if PCOS and metabolic syndrome, they coexist in many situations, what is the precursor and what is the effect? Anda pehle ya murgi pehle? What is the?
So PCOS is part of the metabolic syndrome now. Initially, metabolic syndrome was diabetes, hypertension, dyslipidemia. But now PCOS, because there is a common soil hypothesis, and the common soil hypothesis is insulin resistance, at least one of them, okay, not all, but insulin resistance, hyperinsulinemia. And we have to understand that this hyperinsulinemia acts on all tissues which are responsive to insulin, and not all of them are resistant to insulin action. Otherwise, you will not get the syndrome at all. Because if everything is resistant, how will the effect come? But ovaries are less resistant. So when insulin acts on the ovary, they produces androgen. That kind of a thing.
So the precursor is metabolic syndrome,
yes,
leading to PCOS.
PCOS is now part of the metabolic syndrome. The precursor is insulin resistance.
Okay.
So defect in insulin action and therefore hyperinsulinemia is one of the common pathogenetic mechanisms.
Okay. Ma'am, you had a question.
PCOS. First thing, being a gynecologist, we come across PCOS day in and day out. I mean, it is not a rare occurrence nowadays to see a PCOS patient. 80% of the patients are PCOS nowadays. So I would just like to ask Dr. Uday Phadke, how many days lifestyle modification karna hai bhai?
Lifelong.
Lifestyle.
Lifelong.
That is the main question which the girls and the women keep on asking us. Kitne din karna hai? So it is, that is the main answer, that it has to be done forever. And that many people don't understand because they feel that it is only till their conception or till they conceive, or it's only for 6 months that they have to do this lifestyle modification. So
one very sad fact is we see a lot of children with obesity. And when we start counseling them, their whole thing is that wo sab theek hai, hormone ka kuch nahi hai na. फिर ठीक है, ये बाकी सब देख लेंगे. So it is so sad that they don't understand that this is all related to their diet, exercise, food, They're just interested in, is there some illness? Are you going to give some medicine? So it's a sad.
Thank you, sir. You have given a wonderful presentation on PCOS. As a physician, there's always a question whether the PCOS to be treated by gynecologist or the physician or the endocrinologist. Who should take it over and when we should take it over?
Physician, I don't think should be treating PCOS. Sorry to say that, but you can certainly pick it up. Okay, because ultimately it's a medical disease. It's not really a gynecological disease. You have to realize that. But the problem is that these kinds of things are not taught at MD level nowadays. That is a sad part of things. But yes, a physician as the starting point can certainly talk to them about this thing. Gynecologists will need to treat several aspects of it, including fertility. And they are often the first responders to, because women would generally go to a gynecologist if the menstrual cycle of a child becomes irregular. So they need to be clearly aware. And I think treatment is shared by endocrinologists and gynecologists. Endocrinologist part comes in typically because, there may be other disorders masquerading as PCOS, or sometimes there may be a choice of drugs that you need to use, or patients are not improving, or there's something else. But I think predominantly gynecologists and endocrinologists at different times. But good question that you asked, because physicians need to be aware of what PCOS is. It's actually a medical illness. It has nothing to do with gynecology as such. Although it's a disorder of the ovary, but the disorder starts somewhere else. It starts in the hypothalamus, which is our domain. Thank you.
One question from me. How to convince those PCOS patients' mothers, because they are very young. So how to convince them that your daughter has got this problem and what precaution has to be taken and the treatment. They feel that if something is wrong, you have to give treatment. So all the time in PCOS, we don't need treatment. I'm also a gynecologist. So it's a lifestyle changes plus any supportive treatment. But how to convince those mothers?
Madam, conviction comes from, I don't need to tell you, you're an experienced person.
I know,
but
still,
my personal feeling is that if you sit with the patient, explain in simple terms what this disease is about, and I draw it and explain to them what is happening, most of the people will understand. There are a few who will not. We let them go. We let them go. We cannot make everyone right in this world. So we try and convince them on the basis of science and by easy terminologies as to what the problem is, rather than get them into. So many people come and say, Doc, I have got PCOS. I say, I don't understand what you mean. I am a simple guy. Please explain to me what your problems are first. Then we will see what you have. Then they are kind of, okay, we can't talk like this here at least. So it all depends. It's an art and a skill, you know, that how to convince people.
Convince means the mothers
Convince
don't
or make them
understand.
understand. So it takes time, but I think ultimately they do.
There is one question in the chat box. Do you advise glycomet in PCOD routinely? That is again
So
the
as I
question.
said, I think I took up this question. So a lot of people would use metformin because of a variety of benefits. I wouldn't say that we use it in each and every patient. It is particularly useful when you're not using oral contraceptive pills and want ovulation. It does help. People who are significantly obese, have some degree of glucose intolerance, metformin works well, but I wouldn't say I'm going to use it in each and every patient. And somebody has asked, what is the treatment of PCOD-induced alopecia? So as I said, the treatment is basically oral contraceptive pills and anti-androgens. And we also refer them to dermatologists for topical therapies, which might help.
Thank you, sir. Now I request our president, Dr. Meenakshi Deshpande, to come on the dais to felicitate Dr. Uday Phadke, sir. Over to you, sir.
Good afternoon, everyone. Thank you, sir. Thank you for the introduction. And thank you for inviting me for the talk. So I'm going to talk about subclinical hypothyroidism, which is extremely common these days. We get a lot of patients who come to us, मैंने routine test किए और उसमें TSH ज़्यादा निकला. So whether to treat such patients, not to treat such patients is a very gray area. And there are a lot of guidelines, but there's no clear-cut consensus on whom to treat, whom not to treat. So I will try and simplify and try to tell you what patients need to be treated, which patients need not be treated. So first, what is subclinical hypothyroidism? So subclinical hypothyroidism means an elevated TSH with a normal free thyroxine hormone level. So in this case, we need to remember that the TSH should be repeated after 3 months, that is after 12 weeks, and the TSH needs to be persistently high on 2 occasions. That is more than 4.5 milli-international unit per liter, along with the normal free T4 levels, and with few or no signs or symptoms of hypothyroidism. How do you differentiate between subclinical and overt primary hypothyroidism? So first you get a patient with raised TSH of more than 4.5 milli-international unit with or without symptoms like fatigue, cold intolerance, lethargy, constipation, dry skin, brittle hair, etc. You check the free T4. If it is low, then it is, constitutes for primary hypothyroidism. But if it is normal, you repeat the TSH after 12 weeks. And if the TSH is still high, then it is termed as subclinical hypothyroidism. So normal TSH level ranges from 0.4 to 4 milli-international unit per liter. What is the incidence of subclinical hypothyroidism? It ranges somewhere between 3 to 15%. And higher incidence is associated with increasing age, female gender, and suboptimal iodine status. So epidemiology of subclinical hypothyroidism in India, it ranges from as low as 6.4% in some studies to as high as 26% in certain studies. This is a very common question asked, what is the risk of progression to overt hypothyroidism? So the risk is somewhere 2 to 6% per year. And it is more common among women than among men, among people with higher TSH levels, those with higher TPO antibody levels, and those with low normal free T4 levels. So these have more chances of progression to overt hypothyroidism. Here are certain, these are the causes, some thyroidal causes like autoimmune thyroiditis, thyroid lobectomy, post-radioiodine therapy, post-external radiotherapy. We have some transient causes like autoimmune thyroiditis, which reverses, subacute or other forms of thyroiditis, recovery from non-thyroidal illness, discontinuation of chronic levothyroxine therapy. We also have certain non-thyroidal causes like physiological increase, obesity. In obesity, you have, it is linked to the high leptin levels, which increases the serum TSH. Recovery from non-thyroidal illness, untreated Addison's disease, and assay interferences. So this development of subclinical hypothyroidism depends on TSH level. It is graded. There are certain gradings available. So slightly elevated TSH is somewhere between 5 to 10, and this is called as grade 1 subclinical hypothyroidism. Moderately elevated TSH is 10 to 15, termed as grade 2, and more than 15 is termed as grade 3. So this is a very common question asked: whom to treat, whom not to treat, whether to treat or not to treat. Let us have a look. So which are the factors that influence treatment? One is the age. So whether you are below 70 or above 70. Generally, it is said that above 70, there is no need for treating subclinical hypothyroidism, whereas below 70 years, the risk of cardiac disease with subclinical hypothyroidism is high, and hence treatment is indicated. Also, it depends on the TSH level. So whether the TSH level is more than 10 or less than 10. So if the TSH level is more than 10, treatment is indicated. And if the TSH level is less than 10, then it depends on factors like your TPO antibody levels, presence of goiter or presence of symptoms, or any other cardiac risk factors. So here are some treatment recommendations. So about 10, like I mentioned, you treat. When the TSH level is more than between 7 to 9.9, under the age of 65, patients need to be treated because there is found that there is an increased risk of cardiovascular mortality in these patients at a level of 7 to 9.9. If the patients are above 65 or 65 to 70, then you may consider treatment in such patients only if there are convincing symptoms or signs of hypothyroidism. 4 to 6.9, again, it is dicey. Younger patients with goiter, strong family history, strongly positive TPO antibodies, and those, of course, who are pregnant or undergoing treatment for infertility require treatment even at this level. But those people above 65 years with a TSH from 4 to 6.9, this is normal because as age increases, the normalcy of TSH increases. So between 4 to 6.9 is normal for the age above 65, and hence you do not need to treat patients with this TSH level above 65. And at the age above 80, it is said, it is indicated that you do not treat patients of subclinical hypothyroidism. So if the treatment is started because of symptoms of hypothyroidism, it should be discontinued if there are no alleviation of symptoms. After 3 to 6 months, give a trial for 3 to 6 months. And if there is no alleviation of symptoms, then it has to be discontinued. Probably the symptoms may not be because of subclinical hypothyroidism. And if the treatment is not started, then every 6 to 12 months, the TSH should be measured. And if it is increasing or if the TSH goes about 10, then you can consider starting treatment. Which are the patients that are most likely to benefit from treating? That is age less than 70, as I mentioned, because they are at risk of increased cardiovascular mortality. Pregnant women, definitely you need to treat. Infertile women, symptomatic goiter, high anti-TPO positivity, and those at high risk of cardiovascular disease can benefit from treatment of subclinical hypothyroidism. Significant risks of treatment are also there. There is worsening of tachycardia, atrial fibrillation, heart failure, angina. Worsening of fracture risk is noted in some studies. Worsening of untreated psychological conditions and severe anemia has also been noted in certain studies. So what is the goal of a treatment is to restore normal TSH levels, and the treatment of choice is oral levothyroxine therapy. So again, this is another common thing. When you should not switch between brands when you advise treatment to the patient, because there is different bioavailability between different brands. And if switch is made, then the TSH should be checked again after 4 to 8 weeks, and then you modify the treatment accordingly. But ideally, you do not switch between the brands. So depending on the degree of elevation of TSH, you initiate in subclinical hypothyroidism, you initiate the treatment at a dose of 25 to 75 microgram. And lower starting doses of 25 is used especially in those patients with stable angina, in patients who have clearly increased risk of cardiovascular disease. In such patients, you initiate at a lower dose of 25 and gradually can increase. After the start of therapy or increase in the dose, the serum TSH level should be checked after 4 to 8 weeks, and the clinical response should be based on further TSH levels. Another important thing is subclinical hypothyroidism in older individuals. So treatment with levothyroxine should be considered for individual aged 65 or older with subclinical hypothyroidism when TSH concentration is persistently 7 milli-international units or higher, and should not initiate the treatment if the TSH levels are less than 7, because this is normal for a person aged 65 above. What about in children? So subclinical, there are certain studies conducted which show that subclinical hypothyroidism is associated with deranged cardiac function. So studies have shown that there is increased risk of hypertension in children with subclinical hypothyroidism, deranged endothelial function, increased epicardial fat thickness has also been noted. Changes in lipid profile like increased LDL, reduced HDL has been noted with subclinical hypothyroidism in children. However, studies on insulin resistance, cognitive function, and growth and bone density have not shown any significant changes in subclinical hypothyroidism. What are the recommendations of treatment with levothyroxine in children? So those children with subclinical hypothyroidism with TSH levels more than 10, irrespective of its etiology, have to be treated. Those children with a level between 4.5 to 10 who have a goiter, who have signs or symptoms of hypothyroidism, who have increased risk of progression to hypothyroidism like Hashimoto's thyroiditis, or syndromic children like Down's or Turner's syndrome, and genetic etiology or presence of a thyroid nodule need to be treated. So this is a concise chart showing who needs to be treated, at what level you need to be treated. So first you get a patient with elevated TSH. You repeat the TSH after 2 to 3 months along with the anti-TPO antibody. If there is normalization of the TSH, that is the end of it. If there is a persistent TSH elevation suggestive of subclinical hypothyroidism, then and if the TSH is less than 10, then you categorize it from TSH between 4.5 to 7. And they generally do not need treatment. Those between 7 and 10, again, may not require treatment unless if the if the patient is less than 70 years, has a cardiac risk factors, and has strongly positive anti-TPO antibody. In such patient, you have to again repeat TFTs after 4 months. Those patients with TSH more than 10, those who are more than 70 years of age, you do not treat. Those who are less than 70 years, treatment is recommended, and especially if presence of symptoms or TPO antibody positive or cardiac risk factors, because there is an increased risk of cardiovascular disease in patients younger than 70 years. So TSH more than 10, patients younger than 70, you treat. TSH less than 10 and patients more than 70, you do not treat. What about in pregnancy? So there are certain recommendations in pregnancy for treatment of subclinical hypothyroidism. So the therapy is recommended for TPO antibody positive women with TSH more than 4 or between 4 to 10. TPO, any patient above the TSH who has a TSH above 10 needs to be treated. Treatment can be considered for those patients who have a TPO antibody positive status and has a TSH level between 2.5 to 4. And those between 4 to 10 with no antibody positive can be again considered for treatment. So above 10, again, you treat irrespective. 4 to 10 with TPO antibody positive, you treat definitely. 4 to 10 without antibody positive, it is not recommended, but treatment can be considered. Those with a TSH less than 4 antibody negative, you do not need to treat. ATA 2017 guidelines in pregnancy say that subclinically hypothyroid women who are undergoing IVF or ICSI should be treated with levothyroxine. And the goal of treatment in such patients is you maintain a TSH of less than 2.5. A few cases to discuss. So we have a patient who is a 42-year-old married woman working in an office, has a 7-year-old daughter. 4 months ago, her TSH was 6.3. And this was done because of some non-specific symptoms like fatigue, weight gain, and hair loss. Recent laboratory tests are TSH is 6.8 with a normal free T4, and TPO is mildly positive, that is 40 international unit per ml. Her past medical history is not significant. Her menstruation is normal and she has no plan for any further pregnancy. She takes no medication. Her BMI is 27 and a firm 25-gram thyroid gland is palpable. So she comes to us to ask whether the patient needs to be treated or not. What would you advise? Anyone? So she has a TSH of 6.8, less than 7. She's not planning any pregnancy, no fertility related issues. And less than 7, I think you can skip treatment. You can wait, monitor her TSH after 6 months, and then decide. If it is constantly increasing, then you can. We had seen in the guidelines less than 7. You can wait and repeat a TSH after 6 months and then decide. So these are the guidelines. What AAC, AT, and ES Endocrine Society recommends is patients with TSH of between 4.5 to 10 should be considered for treatment based on the clinical judgment. So it depends on the clinical judgment of the physician with proper consideration of patient's clinical features. AT and ACE also recommend that those patients with TSH more than 10, treatment should be given. ETA recommends to consider trial of treatment in patients less than 65 years with elevated TSH less than 10 if there are symptoms of hypothyroidism. And NICE guidelines suggest considering a trial of treatment with levothyroxine if TSH is between 4 to 10 in patients aged less than 65 years. This is another case. A 87-year-old female lives with her daughter and son-in-law. Her family brings her in because she is becoming more forgetful. MMSE exam shows a score of 25 and blood test shows a TSH of 7.8, free T4 of 6.6. What is the best way to characterize her lab test? Is it subclinical hypothyroidism, overt hypothyroidism, normal for her age, or a lab error? Yes, it is normal for her age. What is the reasonable next step in treating her? Start a low dose of thyroxine or increase slowly if improving. Do not start treatment. Do nothing and reassure her family. Yeah, fine. Also, in this case, why I mentioned this case is a lot of people cognitive. There are studies which show that cognitive functions are associated with subclinical. But most recent studies have shown that there is no cognitive dysfunction associated with subclinical hypothyroidism, even in elderly. So a 27-year-old nulliparous woman married for 3 years was referred to our endocrinology clinic with primary infertility and regular cycles. Lab evaluation revealed an altered TFT with an elevated TSH of 8.24. Workup for male infertility was non-contributory. These were the other investigations. She had no symptoms suggestive of hypothyroidism, no family history. Diffuse and firm goiter was present. Other things were normal. Her free T4 was 1 nanogram per DL. Anti-TPO antibody levels were greater than 500. What would you do? Yes, this patient needs to be treated. She has infertility. She's undergoing treatment for infertility, and any subclinical hypothyroid patient undergoing treatment for infertility needs to be treated. 29-year-old women married for 5 years and planning to conceive, TSH 6, TPO negative, no symptoms of hypothyroidism, whether to treat or not to treat. Treat because she's planning to conceive and subclinical hypothyroidism. 29-year-old primary gravida, 9 weeks pregnancy, TSH 3.8, TPO negative, free T4 normal. Treat or not to treat? Not to treat. Because anything 2.5 to 4 TPO antibody negative, you don't need to treat. 26-year-old primary gravida, 10 weeks pregnancy, TSH 12, free T4 reduced, TPO positive. You treat. 33-year-old again pregnant, TSH 3, free T4 normal, TPO positive, history of 2 miscarriages. Treat. So to conclude, Up to 46% of patients with subclinical hypothyroidism have TSH less than 7 and they normalize within 2 years. In patients with subclinical hypothyroidism, TSH more than 10 is associated with an increased risk of hypothyroid symptoms and cardiovascular events. A transient increase in TSH should be ruled out before the diagnosis of subclinical hypothyroidism is made. Treatment is generally recommended for persons 70 years of age or younger who have a TSH of at least 10, although long-term benefits have not been shown. Among patients who have TSH less than 10 or who are older than 70 years, treatment decisions are based on anti-TPO, either symptoms or anti-TPO antibody levels or cardiac risk factors. One repeat measurement of TSH and free T4 is indicated together with the antibody after 2 to 3 months of initial raise in TSH. Thank you.
Thank you, Dr. Sajal. You have taken up this topic like subclinical hypothyroidism. Listening to it appears that it is, though most of people think that subclinical hypothyroidism is very simple, but after seeing the vast number of cases, it is real challenging and difficult to make understand whether it is subclinical, required treatment or not required treatment. At the same time, I would like to understand what is the difference between subclinical hypothyroidism and mild hypothyroidism. Do they mimic same or they are different?
So subclinical hypothyroidism is patients generally do not have symptoms. I have not really heard of the term mild hypothyroidism. It's just, I think, subclinical hypothyroidism only. I don't know if.
Okay. And if consider we start the treatment to anti-TPO positive patient with TSH of 12, and then after starting treatment, say after 3-4 months, we find that TSH has come down. So then still we require to continue the treatment or go with the symptoms of the patient and then consider?
No, so I think at a TSH of 12 with anti-TPO positive, there is less likely that after stopping the treatment, the patient may, the TSH will again rise. So I think we need to continue treatment in such patients.
So then they require treatment lifelong?
Yes, sir, they do.
Any questions from audience, please? We can take 1 or 2 questions for now.
Living donor kidney or liver transplant, and they are found to have TSH values of 5.5 or 6. Then what would you suggest? Would you treat them or you leave them?
Ma'am, I don't think, like again, we do a TPO positive. If then I think we can treat the patient, but no symptoms,
Because
nothing.
the additional stress of surgery.
Yes.
That's why we are planning to treat.
Ma'am, this is post-surgery or pre-surgery. I don't know. No. Sir says
So
no.
generally we don't
okay,
get
sir.
time to wait for 3 months because they have been worked up for transplant, which is due. So most of the times we treat it.
The point is the surgery. See, there are two aspects.
TPO.
Other concern for living donation is the liver regeneration. So if you know there is no evidence on that, you are always worried about that part, especially for the donor.
Thank you, Dr. Kamath, madam. Now I request our president, Dr. Meenakshi Deshpande, to come on the dais to felicitate Dr. Kamath, madam.
Now our next speaker is Dr. Sheetal Mahajani. Dr. Sheetal Mahajani is well known and experienced.
Kaka.
Dr. Sheetal Mahajani is well-known and experienced consultant liver transplant physician, hepatologist and gastroenterologist at Sahyadri Hospital, Pune. She is also a director of hepatology and transplant unit and GI endoscopy at Sahyadri. Along with leading all these departments, she is founder and director of an initiative called Liver Care, which is a gastroenterology, hepatology and GI endoscopy clinics in Pune. Throughout her academics, she did well and stood gold medalist in BJ Medical and Sassoon Hospital. She has completed her DM and DNB as a gold medalist from Sion Hospital, Mumbai. She has completed her postdoctoral fellowship in gastroenterology from LTMC Sion, Mumbai, and fellowship in liver transplant medicine from King's College, London, UK. Over to you, Dr. Sheetal.
Thank you very much for those kind words. At the outset, I would like to thank IMA for giving me this opportunity to come forward and give this lecture after a good gap of 2.5 years, thanks to COVID. Thank you, Suhas, for doing a wonderful job of organizing this program. Now, without wasting time, I would like to talk about clinical relevance of endocrine function of liver. At the outset, when I was given this topic, I was literally fascinated because this is altogether a new area, which I also learned while preparing slides. Now, we always make certain observations as a hepatologist or a clinicians while treating liver patients. We know that right from our MBBS days that whenever somebody has a chronic liver disease, they have a lot of skin changes, a lot of changes pertaining to different hormones in the body. And they have things like gynecomastia, hypogonadism, so on and so forth. And our knowledge about liver endocrine function was only that much. Now, today's day and age, this particular topic is expanding. There's a lot of research going on. And now we know that there are conventional functions, endocrine functions, what the liver does. And there are certain novel factors which are coming up. These are mainly all proteins and amino acid derivatives, and they practically have effects on every single cell of the body. And there is something which is called as organ crosstalk. So liver talks to every other organ in the body via media of these amino acids and proteins. And isn't that very fascinating? So sometimes when people say that metabolic syndrome is very common and almost 30-40% of general population has fatty liver, I sometimes wonder whether a fatty liver is the culprit for metabolic syndrome. Because if you go through this lecture and some of the recent research papers, then we know that there are a lot of products which the liver produces and which has effects on every single organ, call it skeletal muscles or adipose tissue or pancreas. So maybe that in years to come, the science will tell us something different altogether. Going back to this talk, giving little background, we know that liver is the biggest chemical factory of our body, and it performs major metabolic functions of our body, including carbohydrate, fat, and protein metabolism. The functions are over 500, and many of the functions are known, and some of the functions are still not known. And this endocrine function is one such area. Now, pertaining to the endocrine functions, it mediates critical metabolic pathways via roles in different hormone production, hepatokine production, hormone metabolism, synthesis of binding proteins, detoxification, processing and redistribution of metabolic fuels. Then it also participates in multiple signaling pathways with other endocrine organs like hypothalamus, pituitary, pancreas, gut, thyroid, adrenal, and bones, which are considered as the conventional endocrine organs of our body. It produces hormones which in turn modulate metabolic and synthetic functions. And liver diseases lead to variety of endocrine manifestations like hypogonadism, osteoporosis, effects on glucose metabolism, growth hormone, etc. So this particular area is actually what interests us, and whether understanding it in a better manner, we will make any difference to our patients as far as the treatment is concerned is the challenge. Now, dividing these functions into two broad categories, the classic endocrine functions and the novel endocrine functions. In the classic ones, there are certain hormones which are produced by liver, which is known over last so many years, namely 25-hydroxy vitamin D or IGF, insulin-like growth factor 1, or angiotensinogen as a part of RA system. Then hormone metabolism, yes, it does metabolize majority of the hormones like thyroid, glucagon-like peptides, steroid hormones, all kinds of steroid hormones, then sex hormone metabolism, glucocorticoid, mineralocorticoid, etc. Now, just giving one, one additional pointer here is sometimes in patients of chronic liver disease, we see that their electrolytes just don't respond to whatever treatment we do. And that is the one area when we start thinking about whether they are actually developing mineralocorticoid deficiency because of their chronicity of their liver disease. And such thinking is needed, because then adding certain steroids will help these patients stabilizing in a better manner. Binding proteins, yes, cortisol binding protein, thyroid binding protein, vitamin D binding protein, and sex hormone binding proteins are produced. These are all globulins and produced in the liver. Then novel endocrine function, which is another fascinating area, is feedback regulation of pancreatic alpha cells and glucagon. So actually liver stimulates these alpha cells to produce glucagon. So here is my theory why not the diabetes, which is coming as a precursor. Dr. Hardas was asking Dr. Fadke, what is the egg and what is whether the egg comes first or the chicken comes first. So in case of liver and the metabolic syndrome, this question comes to my mind always, because we see people with age of 20, 25, 30 years with fatty liver. They are not diabetics at that time. They don't have any lipid issues. They are mildly obese, so as to say terms, but they have started getting fatty liver. Now, if we go on and monitor these patients in their lifetime, then maybe in 10, 15 years time, we will get answers to all our questions, what came first and what came later. Other functions which are novel functions of liver as far as the endocrine area is concerned is production of mRNAs. So liver will produce proteins and amino acids. At the same time, there will be messenger RNAs produced in the hepatocytes, and these messenger RNAs will go out of the hepatocytes as exozymes, and these will act on distant areas of the body, including skeletal muscles, adipose tissues, skin, so on and so forth. So this is actually the crosstalk which is happening through mRNAs, which are produced in the hepatocytes. Extracellular vesicles, these are the exosomes which I was talking about. Now, this is just to summarize the classic endocrine functions and the novel endocrine functions of liver. Mind you, the clinical applications are not completely known of all of these. And this is one big area for research and further future applications. Now, certain hormones which are definitely produced in liver, I mentioned few. The first three I already mentioned. Then thyroid hormone is metabolized in the liver. So activation through T4 to T3 happens in the liver in majority of its percentage. And there are certain other hormones also which get metabolized, and they do have effects on the other metabolic cascades which the liver takes part in. So coming to the novel functions, these are nothing but the hepatokines as they are called. These are the amino acids and protein factors which are secreted by the liver. I am not going to go through each one of them. It is quite tongue twisting, number one, and it is fruitless to remember all these substances. But one must remember clearly that there are certain products in the form of amino acids and proteins which are secreted by the hepatocytes and which have implications on various metabolic functions of the liver and the body. So these are the long list of hepatokines which are secreted by liver and which acts on adipose tissues, skeletal muscles and pancreas. So basically it also acts on the glucose sensing of pancreas and the insulin secretions as well as the glucagon secretion. And similarly, there are effects on the skeletal muscles. It can cause lipolysis, fatty acid oxidation, inflammation and insulin-like action. And on the adipose tissue also there is significant inflammation which is caused lipolysis and fatty acid oxidation. If you all are aware, then these days there is a lot of importance given to the inflammation as a culprit of obesity. So some people, some groups of researchers think that actually adipocyte inflammation is one of the reasons why people becoming obese and so on and so forth. So maybe somewhere it is all connected, which we have not yet understood in so much of clarity. Now, this is the common ground for all these metabolic syndromes, and that is insulin resistance. Again, in my mind, I have not clearly understood whether the insulin resistance comes first or whether the liver starts secreting all these factors and creates insulin resistance, or everything happens simultaneously. Only time will tell us. As of now, what the evidence is, insulin resistance is considered as the central common pathway for most of the metabolic syndrome factors which constitute the metabolic syndrome. Then this is again the role of all these endocrine functions of liver in various metabolic factors. Now suppose what happens when there is fatty liver. So there is generally a lot of uptake by the hepatocytes of free fatty acids. So free fatty acids are produced in excess in the body. Maybe it is dietary, maybe it is because of sedentary lifestyle, or maybe it is multifactorial, or maybe there is some genetic predisposition, or maybe there is dyslipidemia. But the point is the hepatocytes have a lot of fatty acids to work on, and in the normal pathway, these fatty acids will be converted as a part of the lipid metabolism in the liver into VLDL, some fraction into LDL, and a very small fraction will be released as non-esterified fatty acids. But if you have too much of substrate, then obviously this lipid metabolism goes for a toss, and there is too much of free esterified, non-esterified fatty acids which are generated, and these are the ones which get converted into triglycerides and start getting deposited into hepatocytes, forming the fatty liver, so as to say. Now on the other side, these fatty acids get converted into acetyl CoA, and they finally get converted into acetylamine. It also can get converted into ketone bodies, and then that is another stress or inflammatory stress on the body, and it also is one of the reasons why there is insulin resistance can develop. There is oxidative stress and there is insulin secretion. On the third, the third one is the main pathway which we already talked about, and if there is too much of chylomicrons in the diet, then it will be taken up, it will be converted into cholesterol, and then bile acid production also will be in excess. That will again stimulate the enterohepatic pathway, and it will stimulate the intestines to absorb more and more. So it's kind of a vicious cycle, the beginning of which we don't know, but we definitely know the end point these days, that there is a big metabolic syndrome which is very difficult to treat, right from getting overweight to developing diabetes to hypertension to PCOS and so many skin changes and so many problems secondary to all these metabolic issues one lands up in. Role of mRNAs, I already mentioned that mRNAs are produced by liver. These mRNAs, they act on various tissues, and this is the crosstalk what is actually talked about. And the exosomes, what I was talking about, these are nothing but the vesicles which carry the mRNAs, and this is a pictorial diagram which shows actually how the exosomes are formed and how they carry mRNA to distant tissues. Now, this is one interesting area that there is pancreatic alpha cell liver axis or liver pancreas crosstalk. In this, what happens is liver produces certain amino acids which stimulate the alpha cells of pancreas. In pancreas, we all know that there are two types of cells, alpha and beta. Beta are the ones which are responsible for secreting insulin, and these alpha cells, they produce glucagon. And this glucagon hyperplasia is also noted in certain patients with liver disease, and that is how the glucose homeostasis is completely changed in these patients. So this is one important hypothesis which is now gaining a lot of importance. Endocrine dysregulation in liver disease. Now, these were the novel endocrine functions what I touched upon. It is little complicated. I know there is a lot of molecular biology involved there, but then I had this was my talk, so I had to enumerate what all it can affect. Now, second important, which we understand it little better, is the endocrine dysregulation, which is seen in liver diseases, and this may be of clinical implications and importance. So liver mediates effects of numerous hormonal pathways directly and indirectly. And therefore, in liver diseases, you see so many disruptions of various hormonal pathways. Now, one by one, we will take it up. Endocrine dysregulation in liver disease. One can get hypogonadism, one can get osteoporosis, one can get IGF, that is insulin growth factor 1 deficiency, vitamin D deficiency. Then one can have alterations in lipids and glucose metabolism, and there is relative adrenal deficiency. Now, this is one controversial area, and why so? We will touch upon it a little while later. So effects of liver dysfunction on steroid hormones. We know that estrogen androgen imbalances caused in patients with liver disease. There is high estradiol and low testosterone in males in these patients, and even in females, the estradiol concentration is pretty high in patients with liver disease. Conversion of androgens to estrogens, majority of it, it takes place in the periphery in liver cirrhosis. So this conversion takes place all the time, and there is suppression of hypothalamic pituitary axis, adrenal axis, due to increased estrogens. And as a result, the sex hormone binding globulin shows initial rise followed by decline in patients who are compensated and subsequently decompensated cirrhotics respectively. So basically then in patients who have chronic liver disease, they have gonadal dysfunction. So it is the practical corollary is it is difficult for these patients to conceive. The females don't conceive if they have chronic liver disease or cirrhosis, and the male counterpart will not produce enough sperm count so as to have successful childbearing. Effect on cortisol. There is low cortisol and cortisol binding globulins in cirrhotics. Adrenal insufficiency also partly as a part of critical illness, corticosteroid insufficiency. So it is both ways. There is reduced cortisol, there is binding globulin which is less, and as a part of the general sick critical illness steroid deficiency, they can have adrenal insufficiency. Hepatoadrenal response in advanced cirrhosis is poor cortisol secretion in response to stress. So these patients, it is very difficult to find out whether they are cortisol deficient. And when in doubt, it is almost always a dictum that it is better to give them a small dose of steroids, or the critical illness dose of steroids, provided you have ruled out infection in these patients. Because mind you, cirrhosis also brings your immunity down, and these are the patients who are all the time harboring infections, either in their gut or in the urinary tract or in their ascites. So it is a very narrow path what the clinician has to walk on. On one side there is cortisol deficiency. So many times in the liver ICU we have these arguments. These patients, they land up with hypotension. Now hypotension is also because there is vascular tone, and vascular tone is less. There is splanchnic as well as systemic vasodilatation. There is cortisol deficiency as a part of their chronic critical illness. And thirdly, they can be infected. So in such a scenario, when to choose and how to give a steroid to these patients is always a double-edged sword, and one has to make a proper decision based on the clinical scenario. Then effect on RAA system, upregulation of renin, angiotensin and aldosterone systemic pathway is seen in these patients. And why it is seen? Because there is low blood pressure as a part of splanchnic and systemic vasodilatation, and that in turn gives rise to renal hypotension, and as a result there is always upregulation. Now to some extent this upregulation will hold true, but beyond the limit there won't be upregulation, and these patients, they have very bad hypotensions which are not responsive to even 2 or 3 inotropes, and everything comes together: their infection, then their chronicity of their illness, their end stage of their illness, and disruption of all these pathways. So it is always important to understand the pathophysiology behind all these common things what we observe on a day in and day-to-day basis. Then type 2 diabetes and cirrhotics. Now there is a molecule known as dipeptidyl dipeptidase of type 4, and there is glucagon-like peptide. Now these two they have important roles to play in proving the link between type 2 diabetes and chronic liver disease. In type 2 diabetes, more than twofold risk of liver disease is there, described in type 2 diabetes patients. Why it is so? Because if there is increased blood glucose, this induces DPP4 expression in liver cells, and that further degrades GLP-1, that is glucagon-like peptide 1, and it impairs glucose tolerance. And then there is a pathway in which there is insulin resistance, lipogenesis, and hepatic injury can occur in the hepatocytes. As a result, there is increased DPP4 activity noted in cirrhotic nodules in people who have NAFLD, people who have hepatitis C related cirrhosis. So this is one of the reasons why type 2 diabetes patients, they do have cirrhosis in a very large percentage. Thyroid hormone, there is variable expression. In some studies, we know that there is low T3 in these patients, or there is total thyroid hormone which is low, and possible elevations in TSH. It may be due to a low thyroid binding globulin, and it represents non-thyroid illness syndrome. Previously, it was known as euthyroid 6 syndrome. I think Dr. Fadke and Sejal will help us understand this more. And then lastly, IGF-1 deficiency in cirrhosis has been associated with an altered metabolic profile, including diabetes, deregulated lipid profile, and cardiovascular disease. It leads to insulin insensitivity in liver, skeletal muscle, adipose tissue, and corresponding hyperinsulinemia. Now, in NAFLD, low levels of IGF are noted, and they correlate with mild, moderate, and severe steatosis. Meaning thereby, if there is mild steatosis, then the levels are in proportion to that of IGF-1. And as the disease, the steatosis progresses, the levels are in opposite proportion. Bone health and vitamin D, this is very important area. All cirrhotics have weak bones, and most of them, they have propensity to have fractures. So all our cirrhotics, we tell them that you wear proper footwear, you take proper support, especially when they are really weak, they have lost all their muscle, they are in their catabolic phase, when their feet are swollen and their abdomen is bloated up with ascites. Now that is the time when we give them additional talk to take care of themselves and to prevent falls, because once they fall, then that is a downhill completely for them. They don't come out of those orthopedic surgeries, and first of all, anesthesia is a big problem. They don't reach transplant, and then their life expectancy and life is miserable, life expectancy is at stake. So let's understand why the bone health is so bad in chronic liver disease patients. Chronic liver disease of any cause can lead to osteomalacia, osteopenia, osteoporosis, and up to 40% develop osteoporotic fractures, as I mentioned. Hepatic osteodystrophy causes are not well known, but some of the factors are blamed are hypogonadism and IGF-1 deficiency. Due to less hepatic production, and also fibronectin is one factor which is blamed. And as these factors are deficient, cytokine production of IGF receptor activator and upregulation of IL-6 pathway happens, and that stimulates osteoclasts, and that is how the bone resorption starts. Now, vitamin D deficiency is one of the major causes also, which add to the poor bone health of these patients, and that could be multifold. It could be dietary, it could be less exposure to sunlight, or it could be because of advanced hepatic dysfunction or cholestasis may add to the risk. And history of steroid use, like some patients, especially autoimmune liver disease, if they are on steroids for a longer duration, then they because of their excess steroid use also, they have additional risk for weak bones. And liver diseases like Wilson's and hemochromatosis, because of deposition of copper and iron respectively, their bones are directly weak because of this excess deposition of copper and iron. So this is again going back to the novel functions. I'm not going into the details. We have gone through the classical functions of endocrine functions of liver and their clinical implications. And clinical implications, honestly, of all these hepatokines and their effects are yet not known. But I'm sure in times to come, we will have more and more light thrown on these other functions, endocrine functions of liver. Just to remind you, come what may is the injury to the hepatocyte, the liver goes through these four phases, come what may, whatever is the cause of the injury. So there is first deposition of fat into the hepatocytes, that is called as non-alcoholic fatty liver. Then if there is chronicity or liver disease which gets induced, then it is called non-alcoholic fatty liver disease. Then if there is too much of inflammation, which is another pathway, then that is non-alcoholic steatohepatitis. And mind you, for clinicians, this is the phase when enzymes will be high. So SGPT, SGOT high, and grade 1 fatty liver, and clinicians and radiologists telling the patients that सगळ्यांनाच fatty liver असते, ह्याच्याकडे काही लक्ष देऊ नका, ह्याचं काही करायचं नाहीये. That's not the case, because small rise in SGOT PT can be autoimmune liver disease, it can be hepatitis B or C, which is undiagnosed, or it could be beginning of a big metabolic syndrome, which will bring the general health of that individual down by virtue of adding morbidity, comorbidity, and reducing the life. So please, please, please do not ignore that little fat in the liver, and do not ignore those transaminitis whenever one comes across. I think all general practitioners and all general physicians and all clinicians for that matter can pick up this early fatty liver, and they can pick up this transaminitis and prevent somebody from going through the pains and misery of cirrhosis. We know that there is science of liver transplant, but then that comes at some cost, monetary cost, physical cost, and the dangling sword on your head, whether you are going to get organ or not. And we see the misery, what the people go through when they are waiting for transplant, and there's so much of mortality on transplant waiting list. So to avoid all that, I think all of us together can definitely take one take home message, that little fat in the liver or transaminitis is not something which we like, and we will look at it, we will counsel the patients, and that is how we will prevent the further detrimental effects of all these on the liver. So to conclude, liver has numerous endocrine functions, direct hormonal effects or hepatokine production, hormone production, synthesis of binding proteins, processing and redistribution of metabolic fuels. Liver plays key negative feedback regulatory role in pancreatic alpha cell mass, glucagon secretion and circulating amino acid levels. Then there are certain substances like beta-trophin and other hepatokines such as fetuin and FGF21 play important endocrine roles in modulating insulin sensitivity, lipid metabolism, and fatty body fat weight. And maybe this is the area which is actually important for understanding more about fatty liver and metabolic syndrome. A lot of research and rapidly evolving is needed, and this is a rapidly evolving field. Now, I always end my talk by pleading everybody wherever I go about organ donation. So please spread as doctors and clinicians, please spread the awareness of organ donation. It is really needed, and we are really at a very modest levels of organ donation. I thank you all for patient hearing, and if there are any questions, I'll be happy to answer. Thank you.
थँक्यू डॉक्टर शीतल. एक लिव्हर आणि त्या लिव्हरचं महत्व आज तुमचा लेक्चर ऐकल्याच्या नंतर लक्षात आलं. ॲज अ फिजिशियन वी ऑलवेज नो दॅट liver is an integral part of any hormonal management or any metabolic disease, but it is that important and you have to concentrate so much on liver is today we understood that, and definitely we need to learn more about how to protect the liver. आजचा तुमचा टेक होम मेसेज खरंच चांगला आहे का लिव्हरच्या बद्दल जास्ती काळजी करा. ॲज अ फिजिशियन, ॲज अ जनरल प्रॅक्टिशनर, ॲज अदर पॅथीज ऑल्सो नीड टू टेक मोर केअर फॉर द लिव्हर. And at the same time, simple investigation like LFT will give plenty of knowledge regarding how to handle it. याच्यात सोबत माझा एक प्रश्न होता मॅडम, का फक्त LFTs वरतीच आपण थांबायला पाहिजे का सोनोग्राफिकली जेव्हा त्याला फॅटी लिव्हर म्हणतात तर त्याच्यानंतर फायब्रो स्कॅन वगैरे सुद्धा ऍडवाइस केलं पाहिजे, आणि जर करायचं आहे तर किती फ्रिक्वेंटली करायचं?
पहिली गोष्ट आहे की if somebody has truncal obesity, somebody has little impaired glucose levels, or there is some sort of hypertriglyceridemia or cholesterol which is high, any one of that can come first. So I mean, as a clinician, one must see what the patient is coming with and then advise investigations. LFT is a must, there is no doubt. Ultrasound is also a must, and if you feel that there is transaminitis and there is fatty liver, then it is worthwhile seeing whether there is further progression in the form of fibrosis in the liver. So there are various gadgets which can tell you that. You can either use a fibroscan or you can use the ultrasound elastography, or if the patient is affording and really worried and want to know a correct way of understanding how much fat, then maybe MR elastography is the ideal investigation for these individuals. I wouldn't go that far and say that liver biopsy should be done. Liver biopsy should not be done for these individuals. And another very common thing, that if already one of these imaging techniques or modalities has shown that there is already cirrhosis, then going back to irreversibility of liver disease, then there is, what is the point in telling that patient you have 30% fat and you have 90% fibrosis? You know that there is cirrhosis. So I mean, such advice should not be given, because now I understand that fibroscan is available in many clinicians chambers also. So just to increase the numbers there, we will not advise fibroscans. Fibroscan also has a definite role, and it doesn't change management. See, ultimately the three important true things about all this is weight loss, exercise, and dietary awareness. Beyond that, there is nothing. So medicines and all that is okay for a limited group of people, but these three are the main things. So I think that this advice anybody and everybody can give.
Anybody from the audience to ask the question?
When we, a lady who's a pregnant lady with a chronic Budd-Chiari syndrome, what would be the status of folic acid? Of course, it is not related to the today's topic, but we had a case. So does it
there are-
really?
See, folic acid basically is a water soluble vitamin. So it should be given as and when it is needed. Now relating it with chronic Budd-Chiari, now chronic Budd-Chiari, what stage of disease, liver disease that patient has, it all depends upon that. The very fact she has conceived, then she doesn't have cirrhosis. I will tell you like that, ruling out certain things. So if there is no cirrhosis, then there shouldn't be any change in the metabolism of folic acid.
My concern was regarding the relative deficiencies to the fetus. Although folate supplements are given during pregnancy.
But then one will have to see first and foremost thing whether there is cirrhosis or not. Sometimes, chronic Budd-Chiari, if they have had it as a child and they have developed a lot of collaterals, then the liver is completely spared. There is no liver dysfunction. So there shouldn't be any problem with the liver metabolism as such. So it all depends upon the stage of Budd-Chiari. If they are full-blown liver cirrhosis, then they wouldn't conceive. If they have developed Budd-Chiari during pregnancy, then altogether it's a different area to treat and manage.
The fetus had anencephaly, and there was a history of two. In fact, it was an ultrasound diagnosis. Patient had jaundice for 5 years, undiagnosed Budd-Chiari, and we, I straight away had a look at IVC and liver, hepatic veins. So there was a history of two such, abortions in the past, and the fetus had anencephaly. So it was a question other
So
way around.
here there are a lot of other things also which are important. If she has already had history of miscarriages, then chromosomal study of the miscarriages or whatever amniocentesis, a lot of things could have thrown light on that. It is difficult to just comment that it was only because of folate deficiency, or I am not aware about that.
Thank you.
Okay. Thank you.
Thank you, Dr. Sheetal.
Thank you, Sheetal Madam. Now I request our President, Dr. Meenakshi Deshpande, to come on the dais to felicitate Dr. Sheetal Madam.
Our next speaker is Dr. Manan Doshi. Dr. Manan Doshi, who is well-known nephrologist in Pune. He is in nephrology department at Sahyadri Hospital. He has been known to diagnose multiple difficult nephrology cases and manage them particularly. He has done his MBBS and MD from MP Shah Medical College and DNB from Apollo Hospital, Chennai. Before joining Sahyadri Hospital, he was associate nephrologist at Apollo Hospital, Chennai. He has successfully conducted many theses and thesis topics, particularly hemodynamics and hydration status in patients with individualized dialysis, sodium versus uniform disalate sodium, as a part of his DNB curriculum. He has presented multiple cases on chronic mercury poisoning from traditional Indian medicine. I would say from quacks. Yeah. So over to you, Dr. Manan, for your talk on diagnosis and management.
Define it, how we diagnose it. He does not have any complaints, but on routine evaluation is found to have serum creatinine of 1.6. His urine examination shows +2 proteinuria. There is no microscopic hematuria, and on quantification, it shows a protein excretion of 1.2 grams a day. fundus examination shows diabetic retinopathy. He is on metformin 1 gram per day. He is on glyclazide 60 mg per day and amlodipine for BP control along with antiplatelets. Now, this is a very common scenario which all the physicians would see in their clinic day in, day out. So the questions that we ask to ourselves is, should we add SGLT2 inhibitors, which are the new kids on the block? Should we add ARBs, or is it too late? His creatinine is already gone up. Should we continue metformin? Should we increase the dose of metformin? If not, then how do we retard the progression of his CKD? So coming to definition of CKD, this we all know. It's defined as abnormality in kidney structure or function, which lasts for more than 3 months, with implication for health. And how do we diagnose kidney disorders is either by checking the structure or function. Function can be by checking the GFR or by albumin excretion. So if patient has albuminuria, which is more than 30 milligrams per 24 hours, if they have a urine sediment, that is microscopic hematuria, a tubular disorder presenting as multiple electrolyte abnormalities, or you do a kidney biopsy and found some interstitial kidney disorders, or you do an ultrasound, find either small kidneys or any genetic disorders like ADPKD with a large kidney, or a diabetic nephropathy with a large kidney, or there is a patient who has had a kidney disease in the past, has undergone transplant. These all come under the broad category of chronic kidney disease. And how we check it is by calculating or measuring glomerular filtration rate. So a GFR less than 60 would be categorized as chronic kidney disease. So GFR is glomerular filtration rate, and it can either be measured or it can be calculated. So it can be measured either by iodothalamus or DTPA scans, which is practically not possible to do in each and every patient. So there are multiple ways we can calculate GFR. The way it is calculated is either by collecting 24-hour urine and calculating the creatinine clearance in the urine by UV by T, or there are certain formulas which have been created after a prolonged study, and they are either MDRD or a EPI formula. So if we compare both the formulas, the best, if you ask me which is the one best formula with which we should calculate the creatinine clearance, it would be CKD EPI formula, because it is in studies it has shown to correlate more with the measured GFR at higher GFRs. At lower GFRs, MDRD as well as EPI correlate similarly, but at higher GFRs, EPI correlates more well with measured GFR compared to MDRD. So what is the role of doing cystatin C then? If we have creatinine, do we really need to check a cystatin C? So what KDIGO guideline says is that we measure cystatin C in adults with a GFR or a calculated GFR of 45 to 60, where there is no other marker of kidney damage seen. Like there is no proteinuria, the ultrasound looks pristine. Somebody comes to you with creatinine of 1.4, we don't see any other marker of kidney injury. And in such patients, we can calculate cystatin C and measure the GFR with cystatin C creatinine estimate GFR. And if that is less than 60, that person definitely has a CKD. If it is more than 60, then the diagnosis of CKD cannot be confirmed. Now, based on this, the kidney disease is categorized into 5 GFR categories and 3 albuminuria categories. And if it is more than 90, it is stage 1, 60 to 90 stage 2, 45 to 60 3A, 30 to 45 as 3B, 15 to 30 as 4, and less than 15 as end-stage renal disease. And albuminuria we would categorize into A1, A2, and A3, where A1 is less than 30, 30 to 300 is A2, and more than 300 is A3. And based on that, the risk is categorized as in the green band is low risk or minimal risk. In the yellow band, it is a slightly higher risk. Orange band is moderate risk, and red band is very high risk for further kidney and cardiovascular related complications. Now, with changes in lifestyle, non-communicable disease are on a high, and the etiology of ESRD is because of this non-communicable disease is also increasing. So compared to early 1980s or 1990s, where quite a number of cases were because of glomerulonephritis or cystic kidney disease, the incidence of kidney disease due to diabetic and hypertension is on the rise. And the same thing can be depicted even in this graph. So how do we treat all these patients? So what the guidelines recommend that all the patients with diabetic kidney disease should have smoking cessation, should have some dietary changes, need to exercise 150 minutes a week, and they should have a good glycemic control, good BP control, and good lipid management. Most of the patients would require SGLT2 inhibitors and RAS blockade, and some patients would require antiplatelet therapies. So we'll come to each of them one by one. So what are the lifestyle interventions that are recommended by KDIGO to treat such patients with diabetic kidney disease? So for all such patients, we recommend a protein intake of 0.8 grams of protein per kg per day. What happens if you take a higher protein intake? The metabolism of all such proteins is going to generate acidic amino acids. So the acidic load on the kidney is going to go up, and that is going to promote fibrosis in the kidney, and it's going to accelerate the chronic kidney disease. Hence, we need to restrict the protein intake. But it should not be restricted to, say, very low. Like some people just stop everything once they are diagnosed at CKD. That is not recommended. The other important thing is going to be restriction of salt intake. So the salt intake has to be less than 5 grams a day, or sodium intake of less than 2 grams per day. Higher the salt intake, higher is going to be your blood pressure, and higher is going to be complications related to that, including cardiovascular as well as renal outcomes. So these are the easy ways where how people are advised to cut down salt. That is, buy fresh foods, don't eat canned foods, don't eat high salt butters, margarine, or cut down the salt in your meat intake. Also use the salts which have less sodium content. Use fresh spices or herbs to add flavor rather than salt. These are the easy ways how we can cut down the salt intake. Now, besides this, obviously exercise is an important thing, and 150 minutes a week exercise is recommended for all patients with diabetic and diabetic kidney disease. Now, coming to pharmacotherapy, we can divide this into broad 4 categories. That is either proteinuria control, angiotensin 2 control, blood pressure control, and glycemic control. So the theory is reduction. Why do we concentrate so much on proteinuria? What's about this proteinuria? So theory is reduce the proteinuria and reduce the cardiovascular event. So how do we come to that? So this is based on a live trial which was published in Hypertension 2005, where 8,000 people about 55 to 80 years were treated with either atenolol and losartan. And what they found out was that lower the protein excretion, lower the proteinuria, better were the outcomes. So reduction in albuminuria during treatment translates to a reduction in cardiovascular events. Other theory, going on the same theory, there was another trial, that is renal trial. And it was, instead of intention to treat analysis, if we were to analyze the baseline proteinuria or reduction in proteinuria, what was found as we go on reducing the proteinuria, all cardiovascular outcomes were better. And so much so that reduction in proteinuria reduces the hazard ratio for cardiovascular events as well. So interestingly, suppression of albuminuria was the strongest predictor for long-term protection from cardiovascular events. So reduction in proteinuria is going to reduce your cardiovascular as well as renal complications. And hence it can be used as an intermediate endpoint, and interventions which reduce proteinuria are hence supposed to be good. So how do we do that? So what is recommended is we treat with angiotensin converting enzyme or an angiotensin receptor blocker, that is ACE inhibitor or ARB, in any patient with diabetes, hypertension, and albuminuria. And this, mind you, have to be titrated to a higher dose, highest tolerated dose. And for patients with diabetes and albuminuria whose BPs are normal, still for them the recommendation is to treat them with ACE inhibitors or ARBs. And this comes from the captopril trial, which was published in NEJM in 1993. And patients treated with captopril after say multiple years of follow-up had better outcomes compared to placebo. Renal trial, which was type 2 DM with nephropathy, where creatinine was already 1.9. They were randomized to receive either placebo or a losartan, and the primary outcome was either doubling of creatinine, ESRD, or death. And patient treated with losartan had a better outcome in all of those parameters. So how do we start? So we initiate ACE inhibitors, ARB, and we monitor the two problems with using ACE inhibitors and ARB is the potassium and creatinine. So what happens if patient comes to you with creatinine is 1.5, you start ACE inhibitors or ARB, you start them on telmisartan, say 20 BD, and patient comes back to you after 2 weeks, says my creatinine is 1.6, it's gone up. What should you do? Should I stop the ACE inhibitors, ARB? So that's not actually required. So what we need to do is monitor creatinine and potassium after 2 to 4 weeks. If patient has normokalemia, potassium is normal and creatinine increases less than 30%, you don't need to do anything. You just need to continue the same dose and in fact increase the dose to the maximum tolerated dose. If patient has hyperkalemia, you need to review concurrent drugs, whether he's on some other drugs which can increase the potassium. We can try conservative methods of decreasing the potassium levels, like adding diuretics, a bicarb, or a potassium binders. And if despite that they persist to remain hyperkalemic, then we need to reduce the dose of ACE inhibitors or ARB to the best tolerated dose as a last resort. If after starting ACE inhibitors or ARB, you have a 30% increase in creatinine, then you need to review for causes of AKI. You need to see if they have volume depletion. You need to see if they have renal artery stenosis. And if they have nothing, and you should then resort to reducing the dose of ACE inhibitor or ARB as a last resort. So this is okay, but can we use them in advanced CKD? If suppose somebody comes to you with creatinine of 2.3, 2.4, would you start them on ACE inhibitors or ARB? So yes, it has been studied, and there has been various studies. This is the one of benazepril trial, which was published in NEGM, where they categorize patient into two categories: 1.5 to 3 creatinine and more than 3 creatinine. And what they found out was that the benefit of using benazepril, that is the percentage of patients not reaching the primary endpoint, were higher in the benazepril group compared to the placebo group. And the difference was 1 year, like the same point was achieved by the benazepril group after 1 year compared to that of placebo. And the effect starts to kick in almost about, say, 3 to 4 months just after starting the treatment. But mind you, the problem is the patient need to be well informed, and they need to be made aware of the potassium, and they need to keep on checking their potassium, come back to us with regular reports, and we need to titrate the dose of ACE inhibitors and ARBs in advanced CKD. So similar trial which was published in Taiwan, and they used ARBs, ACE inhibitors in creatinine level more than 6, and the hazard ratios across all the categories were much lower in ACE inhibitor and ARB use. Similar trial which was used in US veterans, and more than 1 lakh of patients, and they came up with the same conclusion that ACE inhibitor ARB administration was associated with greater survival. So yes, ACE inhibitors ARBs can also be used in advanced CKD. So if ACE inhibitors or ARB are going benefit, can we combine the two? Give both ACE inhibitors, ARBs, why not? So yes, that has also been tried. And this is the VA nephron trial, which was published in NEGM, where patients were at maximum dose of losartan, 100 milligram per day. And then were further added lisinopril, which is a ACE inhibitor. And the endpoints were declining of more than 50% in the estimated GFR. So what they found out was that there was not much difference in the primary or a secondary endpoint. But when you look at the adverse effects like AKI or hyperkalemia, they were much higher in patients receiving the combination of the drug compared to either of the drug alone. Another trial was on target trial, and that also showed us the same thing. There was not much difference in the primary or the secondary endpoint, but combination treatment, renal impairment was higher, and the relative risk was also higher in combination treatment compared to individual treatment alone. So this is about angiotensin control and proteinuria. But what about glycemic controls in our diabetic patients? So can we use the usual thing HbA1c for checking the diabetic control in patients with CKD? Yes, you can use it. So it is validated till stage 3B. After that, stage 4 and stage 5, the reliability of HbA1c goes down. And hence, other things like self-monitoring of blood glucose or continuous glucose monitoring can be used in such patients to monitor sugar levels and control them in patients with diabetes. So what should be our target? So it depends. There is no fixed target in patients with diabetes. So suppose somebody who is young, who is in early CKD, stage 1, stage 2, who does not have any complications, who has no comorbidities, life expectancy is very long, hypoglycemic awareness is there. For such patients, we target a lower HbA1c compared to somebody who is elderly, who has multiple complications, who has many comorbidities, whose life expectancy isn't long. So for them, we would not target a very low HbA1c. Generally, somewhere around 7 would be our target in patients with diabetes. So how do we reach there? So physical activity, nutrition, and weight loss is part of every treatment in diabetes. Now, talking about two important drugs, that is metformin and SGLT2 inhibitors. So what do the guidelines say? The guidelines say metformin can be used until the GFR is of 45. Less than 45, we reduce the dose to half, and less than 30, we stop metformin. Similarly, for SGLT2 inhibitors, what it says is somebody who is already on SGLT2 inhibitors and comes to you with a GFR of less than 30, you don't touch it. Let it continue. There's no problem. Somebody who comes with a GFR of less than 30, you do not initiate SGLT2 inhibitors. Somebody who is on dialysis, you stop SGLT2 inhibitors. Because patients who are on dialysis anyways would not have much urine output, and the whole mechanism of action of SGLT2 inhibitors is going to be inhibition of sodium glucose link transport in the kidneys. Besides these two, the other drugs which can be used in CKD are GLP-1 receptor agonists, DPP-4 inhibitors, insulin, sulfonylureas, thiazolidinediones, and alpha-glucosidase inhibitors. Now, either of these drugs can be selected based on patient preferences, comorbidities, eGFR, and cost. So this is a very busy chart. So suppose a patient who wants to avoid hypoglycemia, then we would definitely not use sulfonylurea and insulin. We would use the other drugs. If somebody who wants to avoid insulin, we cannot use insulin and GLP-1 analogs, then we would have to use other spectrum of the drugs. If weight loss is the criteria, GLP-1 receptor, and this is, mind you, besides the SGLT2 and metformin. If somebody wants cheap medicines, so sulfonylurea, thiazolidinediones, and alpha-glucosidase inhibitors. For CKD, GFR less than 15, DPP-4 inhibitors, insulin, and thiazolidinediones. So this is how we can titrate the other medications for glycemic control based on patient preferences, stage of CKD, and definitely cost preferences as well. So what about metformin? So somebody who has GFR less than 30, definitely stop metformin and do not initiate. But somebody who has more than 60, do it as we do usually. So start at 500 or 850, up titrate it to maximum dose. And if you have GI tolerance, you can titrate the dose according to patient side effects. If it is 45 to 60, also you do the same thing. But less than 45, you start at the half dose. When somebody is on metformin, you have to monitor serum vitamin B12 levels, and you have to monitor the renal functions, because if renal functions are going to go down, you will have to change the dose according to the GFR of the patient. So this is all about what we have been doing for many years. This all has started since 1990, and we have been stuck since 2005, and there was nothing coming up until 2015. So these are the multiple trials. These are ACE inhibitors, ARBs that were being used to treat diabetic nephropathy, reduce proteinuria in patients with diabetes, and hence retard the progression of CKD. Since 2015, the new kids on the block are SGLT2 inhibitors, and this is based on 3 studies, that is CREDENCE, DAPA CKD, and there are a few more which are in the line, like CREDENCE is another trial which is based in CKD. We'll come to that in a while. So basically it all started with EMPA-REG trial in 2015, and it was followed by CANVAS and DECLARE TIMI. So EMPA-REG used empagliflozin, CANVAS used canagliflozin, and DECLARE used dapagliflozin, and they recruited patients more than GFR of 30. This basically predominantly were cardiovascular outcomes trial. They were not supposed to focus on the kidneys at all. After results of this trial, the later 2 kidney trials that were published were CREDENCE and DAPA CKD trial. where they recruited patients even with CKD stage 5 to see what is the outcome. And the patients with proteinuria were not much in the initial 3 cardiac trials, but the CKD trials included patients even with proteinuria. So these were the 3 trials: the EMPAREC trial, which is NEJM 2015, Canvas trial, which was 17, and DECLARE was 2019. The primary outcome was death from cardiovascular causes, non-fatal MI and non-fatal stroke, and major adverse cardiovascular event. So across the trials, all SGLT2 inhibitors were associated with better outcomes. So cardiovascular death or even the heart failure hospitalizations or major cardiovascular adverse events were much lower in patients taking SGLT2 inhibitors compared to placebo. But what was also found out was that they had renal benefits. So patients who were taking SGLT2 inhibitors had better composite renal outcomes compared to the placebo. And then it was found that we should probably study them even in non-diabetic proteinuric diseases, and hence renal trials were conducted in patients with and also without diabetes. Do they have better proteinuric outcomes in patients with without diabetes? And hence we had 3 trials, that is CREDENCE, DAPA-CKD, and EMPA-KIDNEY. EMPA-KIDNEY is yet to be published, but the other 2, CREDENCE and DAPA-CKD, is already published. Out of which CREDENCE had only diabetic patients, but DAPA-CKD also included patients without diabetes. So what CREDENCE had was 4,000 patients, and the eGFR average was 57. And mind you, all these patients were on maximum ACE inhibitors and ARB and were further randomized to receive either canagliflozin or placebo. And they were associated with reduced risk of kidney failure and major cardiovascular events. So what was found as patients treated with SGLT2 inhibitors had better HbA1c, had better blood pressures, had lower body weight, had lower albuminuria, and the renal outcomes, that is end-stage renal disease, doubling of creatinine, renal or cardiovascular death, was lower in patients treated with SGLT2 inhibitors compared to placebo. And similar findings were also noted in DAPA-CKD trial, which also included non-diabetic patients, and they were associated with better outcomes. So the hazards ratio was much lower with SGLT2 inhibitors compared to placebo. And they also included patients with eGFR more than 25. So 25 to 75 was the patients that were included in this study trial. So this is the summary, very busy slide. So I'll just highlight. So what the major concern with SGLT2 inhibitors is UTI, but what the trials have shown is that there is no difference in UTI. The major concern is genital mycotic infections and Fournier's gangrene, which is a very, very severe and a rare complication associated with SGLT2 inhibitors. Few trials did show increased risk of bone fractures, like in CANA and DAPA, and limb amputation, but they have not reached a statistical significance that can hamper the use in day-to-day practice. The only concern is this, the euglycemic DKA. So for somebody who is on SGLT2 inhibitors, goes for prolonged fasting, or is kept NBM for any surgery, there is a risk that they can go into ketosis. And hence there is a sick day rule, which I'll come to in a while. This is the same kidney trials that we spoke of. So based on this trial, the American Diabetes Association now includes SGLT2 across all categories to treat diabetes with and without CKD, with and without proteinuria. So what is the recommendation? So recommendation is, if GFR is more than 30, we have to treat such patients with SGLT2 inhibitors. If patients' glycemic targets are met, can lowering glycemic target be achieved with SGLT2 inhibitors? If yes, we add it. If not, then we have to stop few medications and then add SGLT2 inhibitors. Now, this is the sick day rule. It is reasonable to withhold the SGLT2 inhibitors during the times of prolonged fasting, like surgeries or critical illness when patient is admitted into ICU, they can't eat well, because if not, they would be at a higher risk of ketosis. If patient is at risk for hypovolemia, like somebody who is on diuretics or multiple diuretics, the risk for hypovolemia, hypotension has to be factored in before adding SGLT2 inhibitors. Also, like ACE inhibitors, ARB, a reversible decline in GFR is expected with SGLT2 inhibitors and is not an indication to discontinue the therapy. Once SGLT2 inhibitors is initiated, it is reasonable to continue even if GFR falls less than 30, unless they are planned for kidney transplantation. In patients after kidney transplantations, SGLT2 inhibitors are not adequately studied, and hence these recommendations do not apply to kidney transplant patients. So based on this, what are the indications to treat patients with SGLT2 inhibitors? Would be diabetes with albuminuria with renal disease, non-diabetic albuminuric renal disease like somebody who has IgA nephropathy or FSGS. TAPA-CKD also showed improved outcomes in such patients. Type 2 DM without albuminuria but high CV risk, patients with heart failure and reduced ejection fraction, and type 2 DM with hyperglycemia. So all such patients we can add SGLT2 inhibitors. Are there increase is there a risk of adverse effects associated with the SGLT2 inhibitors? Yes, then you have to weigh the risk and benefit. If no, then you assess the BP volume status and glycemic control. If there are chances of hypotension or hypovolemia, like a patient is on diuretics, we may need to reduce the dose or adjust the dose before we add in SGLT2 inhibitors. If patient is hypertensive and normo or euvolemic, you can start SGLT2 at the lowest approved dose. If glycemic target achieved or not. If yes, then if patient is on drugs which can cause hypoglycemia like sulfonylurea, meglitinides or insulin, we need to reduce the dose of such medications. If glycemic target is not achieved, then anyways you can add SGLT2 inhibitors without reducing the dose. So this is about SGLT2 inhibitors and controlling the sugars and controlling the proteinuria. What about lipids? Should such patients be on statin? So the guidelines related to statin use in CKD are very old. The KDIGO has published guideline in 2013, and what it essentially says is that any patient who is more than 50 years not on dialysis can be added statins, irrespective of GFR less than 30 or more, less than 60 or more than 60. If a patient is on dialysis, then statin may not be added unless there are any additional risk factors. So patient has a known coronary disease or prior ischemic stroke, then such patients would definitely need to be added statins. And the targets remain the same as the other patients. Now, for patients with CKD, what should be the BP targets? Now, this is based on the trials that are recently published, and this is the latest KDIGO guideline, which says that the BP target should be less than 120 systolic when tolerated, and this is using standardized office BP measurement. And all across the group, stage G1 to G4, A2 to A3, ACE inhibitor ARB would be the drug of choice to start in patients with CKD. What else do we need to add to reduce the progression of CKD? It is sodium bicarbonate. So there has been a systematic review and meta-analysis of effects of bicarbonate therapy on kidney outcome. And what it has been shown is that they delayed the CKD progression and progression to kidney failure. The effect on peripheral edema and blood pressure is a bit modest. It's not very high that will stop us from using bicarbonate in patients with CKD. Now coming to second case, this is a 42-year-old gentleman with type 2 diabetes for 10 years, presented to OPD for evaluation of azotemia, detected on routine blood check. There was no history of pedal edema or urinary symptoms, but there was occasional analgesic use for headache. High creatinine first in 2014, and was since then told to have CKD due to diabetic nephropathy, and was given sodium bicarbonate and phosphate binders. On checking the old records, he had 4 years back normal renal function, and creatinine was 5.2 now, proteinuria of +1, and BP was normal, and systemic examination was normal. A lab report showed a creatinine of 4.9, urea of 60, electrolytes were all okay. Proteinuria was traced, 24-hour urine protein was 780, and hemoglobin was all right, it was 14.7. So what next? Is it diabetic nephropathy? Should we just continue the supportive treatment and not do anything? So retinopathy in patients with diabetes is supportive, but it is not necessary for diagnosis. This holds true presence of retinopathy and nephropathy, especially in type 1, where 95 patients with type 1 diabetes with retinopathy are expected to have CKD due to diabetic nephropathy. But this does not hold true in type 2. 30% of type 2 diabetics with CKD may not have retinopathy or albuminuria. So it can still be a diagnosis. So when do we suspect that this disease is probably not diabetic nephropathy? So the rate of decline in GFR that is expected for somebody with diabetic kidney disease is about 5 to 7. When there is a rapid decline in GFR, or there is a rapid increase in proteinuria, or suddenly they start developing microscopic hematuria or refractory hypertension, or you add ACE inhibitor and there is suddenly decline in GFR, these are the patients where we have to think probably that it is not a diabetic nephropathy and we are dealing with something else. So when such patients were biopsied, 63% were still found to have diabetic nephropathy. But there are 18% where there was non-diabetic renal disease like acute interstitial nephritis or glomerulonephritis or just a ATN or a hypertension related kidney disease. And 19% had a mixed picture. So we did a renal biopsy and there was mild increase in mesangial cellularity. But what we found out was there was dense diffuse interstitial inflammation of lymphocytes and plasma cells. And they had storiform fibrosis. So then we thought of IgM in the immunofluorescence showed IgM. And then we thought probably it is IgG4 related disease, and IgG4 plasma cells were positive and IHC was also positive for IgG4. And it was diagnosed as IgG4 related disease and they were started on steroid. So what is the recommendation to refer to nephrology services for patients with diabetic nephropathy is if the GFR is less than 30 or a drop in GFR is more than 25%. The rate of decline in GFR is higher than 5 to 10 mils per minute per year. And there is significant proteinuria, or there are some secondary complications of CKD like hyperparathyroidism or high anion gap metabolic acidosis and hyperkalemia, which is not managed by conservative methods, or you come across a hereditary kidney disease. So to summarize, with increase in prevalence and incidence of chronic disorders like DM and hypertension, the incidence of CKD is gradually increasing. Regular checkups, early detection are key to early diagnosing and reversal or retarding the progression of CKD. Not all patients with long-standing diabetes have diabetic nephropathy. They can have other disease besides diabetic nephropathy. SGLT2, metformin, ARBs, and ACE inhibitors are mainstay of treatment for cardiovascular and renal manifestations of diabetes. Thank you.
Thank you, Manan. That was very exhaustive because I think the topic itself, when I read that you were going to be talking about this particular topic, I was a little taken aback because it is almost impossible to do justice to this exhaustive topic in a matter of 40-45 minutes. But nonetheless, you have done a wonderful job. I think we have an overall good overview of what medications, and these medications are backed by what trials and what are the fallacies of those trials and what are the pluses of these trials. So very well presented. Any particular question? I just have one query. In all these trials where you have done the ARB or AC, the RAS blockade.
Yeah.
The benefit of RAS blockade is purely related to its direct effect on microvascular effect or reduced renin or to blood pressure reduction. So the benefits were because of which of these?
So I think it's a combination of all the three, but predominantly it is reduction in proteinuria and microvascular injury that is translated into a better outcomes, both cardiovascular as well as renal wise in patients using ACE inhibitors and ARB.
Anything else? Anybody? Any questions? I have one suggestion. We have overshot by almost 45 minutes. If we keep listening to talks and sit in one chair, all of us are going to develop metabolic syndrome. We need to exercise our legs. So in which case, if we leave this topic for next time, do you think it would be better? Because this is a very, very important topic. Currently, a lot of Indians are plagued with this particular problem. We have a 30% prevalence of this particular entity. Or you want to do it in 5, 10, 15 minutes, something like that. Yeah, because in that case, let us have a rapid fire kind of a thing. I will ask quick 3 questions to you, 3 questions to you, and see if you can answer those in 1 or 2 minutes each. Is that possible? Why don't you come on the stage, please? Okay. Gitanjali, you go ahead, whatever you wanted to say. Meanwhile, I'll invite you, Sheetal, and Dr. Uday
Yeah, you
to come
please
on the
come.
stage.
All the
So at
panelists,
least
please
you
come.
occupy your seats by the time
Yeah.
the felicitations are done.
क्या बस ऐसे लगा? चार. Felicitation. हो होते चालेल. एक. यांचं felicitation होतं. Dr. Doshi, please come. I request. Till then, I request Dr. Meenakshi Deshpande, President IMA Pune, to felicitate Dr. Doshi. Yeah, yeah. I request Dr. Chajat sir to come over here. And I request Dr. Meenakshi madam to felicitate Dr. Chajat for chairing the session. It's okay. Dr. Okay. Yes, we can proceed with the panel discussion or whatever you said, rapid fire questions.
I think it will have to be a rapid fire kind of a thing, because I don't think we have a lot of patience and time to discuss this particular entity, which is very, very important, because you all know that it has a very high prevalence and high incidence. Every year, 1 crore individuals in our country are diagnosed with this particular problem. It is a harbinger. No, we'll give you a mic. We'll give you a mic. Can we have mic, please? Take mic then. It's a harbinger of a lot of problems. It's a harbinger of diabetes, hypertension, and subsequently that translates into more cardiovascular events, whether it is heart failure related to hypertension or it is ischemic heart disease. So my first question to you, Dr. Uday, is what is this metabolic syndrome and why do we call it a syndrome? And can you tell us in detail as to what are the components included in this particular syndrome?
So this whole idea came in because people started realizing that if you see a patient of diabetes, you're very likely to have dyslipidemia and hypertension. Or if you see a patient of hypertension, he is very likely to have the other two. And together, all of this finally results into cardiovascular disease. So that is why they felt that these different risk factors cannot be isolatedly discussed. You cannot just say, I have diabetes, I have dyslipidemia. They have to be looked as a triumvirate at least, and look at it as a common thing which increases finally the cardiovascular disease. Therefore, this term, and all of them are related to metabolic abnormalities.
So in
Therefore,
short,
the
what
term-
you're trying to say that it is a shared pathophysiology and it is not an individual disease entity.
Correct. So
And it indicates basically the underlying biological process.
Which leads to exaggerated cardiovascular disease finally. The main components with which we started was abnormality in glucose regulation, abnormality in lipids, typically low HDL, high triglycerides.
Any particular criteria of HDL that
So there are different criteria, but what we believe currently is less than 30 for males, less than 40. Some say it should be 40 and 50, but essentially some degree of low HDL and high triglycerides. Triglycerides being more than 200, and blood pressure. Of course,
So-
the standard blood pressure criteria as is currently used in JNC.
So this is an important thing that Dr. Uday has just mentioned, that in the diagnosis of metabolic syndrome, if you are looking at the lipid profile, earlier we used to look at components like total cholesterol and LDL cholesterol. But it is a high time that we start looking at triglyceride, because triglyceride itself, when interpreted along with HDL cholesterol, indicates a bad dyslipidemia, which is a component of metabolic syndrome. So please go on. What are the other parameters?
Then subsequently, yeah.
Is there something like isolated HDL, low HDL, and what that is some importance or?
So see, I mean, this metabolic syndrome is a coined term. It is not an established disease entity. The whole idea of bringing together metabolic syndrome was to alert people that if you have one component of the disease, please pay attention to the other as well. So if you have low HDL, you already have one component of it. And then if you have other components, say like sugars or blood pressure, and very importantly, central obesity, you are at a higher risk. And at least then, some of these factors are modifiable. For example, sugar is modifiable, lipids are modifiable, blood pressure can be clearly changed, and central obesity can be changed through exercise and diet. So the whole idea was that metabolic syndrome can be treated not just with medicines, but by intense lifestyle, improving cardiovascular disease.
So, sorry to interrupt you. What is at the crux of metabolic syndrome?
So the crux is
what causes metabolic syndrome?
So we cannot say that. But one of the chief metabolic abnormalities at the background is resistance to insulin action.
Okay.
Now, when we say resistance to insulin action, we don't just mean that the sugar is going high. Insulin has huge number of metabolic roles in the body. And all of them at different stages, the organs can be differently resistant to insulin, thereby causing endothelial defects, sugar abnormalities, even lipids. So the low HDL is because of insulin resistance. It's not because of something else. It's a marker of insulin resistance. So insulin resistance is believed to be one of the four things. And insulin resistance, even before it is clinically evident, is seen in muscle biopsies 10 years prior to the onset of metabolic syndrome.
So the four components that Dr. Uday has just mentioned: insulin resistance, visceral adiposity, and there is atherogenic dyslipidemia that just you mentioned, increased TG with a reduction in the HDL, and endothelial dysfunction, which is something which I wanted to add. And endothelial dysfunction can manifest in a variety of ways. And one of the commonest manifestations of endothelial dysfunction is development of pre-hypertension or hypertension. And therefore, one of the criteria for diagnosis of metabolic syndrome is a blood pressure, ambient continuous blood pressure more than 130 systolic or more than 85 diastolic.
And there is one more component which is now added to this diagnosis, and that is microalbuminuria. So microalbuminuria was once just taken as a marker of nephropathy, but it is actually a marker of endothelial dysfunction and capillary leakage. So anyone who has microalbuminuria is at a high risk of developing cardiovascular disease, and it's one of the strongest associates of the risk.
I think one must be aware, because a lot of us go on to develop metabolic syndrome without realizing that we are slowly drifting into the problem zone. So if any of you, family members is developing truncal obesity and has any of these features just described, please bring them to the medical attention as soon as possible. One question to you, Dr. Sheetal. What are the other associated disorders that go hand in hand with metabolic syndrome?
NASH or fatty liver disease is a main group of disorders which is quite commonly seen with metabolic syndrome. And as I mentioned in my talk, it may be the first sign of metabolic syndrome, that people at 20, 30 years, they may develop early fatty liver, grade 1 as to say it is called. And then thereon, then one after the other, the whole cascade of other components of metabolic syndrome starts appearing. So that's one major area.
Can presence of gallstones be another feature of metabolic syndrome, or associated?
Nothing to, not really, not related to metabolic syndrome as such. But then that indicates gallstones can be of two types. They can be pigment gallstones, or they can be cholesterol gallstones. So again, if somebody's food is very rich in cholesterol or fats, then obviously one will have cholesterol gallstones. And that we used to say in undergraduate days, that fat females of 40, fertile females of 40 are more prone for gallstones. And that was one of the reasons why maybe their diet was rich in cholesterol or fats. So that is a corollary, but that will not classify it to be a metabolic syndrome.
I'll come to that NASH in a minute, but I'll go back to the diet because you just uttered something about that. What kind of a diet can be a good harbinger or can be a stage former for development of metabolic syndrome? And what would you advise our people as to what one must avoid distinctly to be able to avoid getting metabolic syndrome?
This is a big question actually. To answer it in a shortest possible way, one thing I would like to say is like our biological rhythm is based on natural rhythm of sunrise and sunset. So our eating window should be with sunrise and should end towards sunset. You cannot get up and start saying that I want to have a midnight snack. Now there's a fashion of midnight snack. There's a fashion of desserts having late in the night. There's fashion of having dinners late. It's a family time, whatever is associated with that, but that is all wrong because body has no mechanism to metabolize that additional calories in the night. So that is the first discipline what each one of us should have. Our breakfast should be like a rich man, lunch like a common man, and dinner like a poor man. That has to go into our systems. You cannot have the pyramid reversed, that you are having dinner as the heaviest meal and breakfast as the lightest meal. Then all your metabolic needs are reversed and then the whole problem starts. Now, as we grow old, what changes? Many times we hear people saying that हे मला लहानपणी पचायचं आता काहीच पचत नाही, मी खूप 4 पुरणपोळ्या खायचो आणि अर्धी पोळी खाली तरी पोट भरतं. So all that happens because our basal metabolic rate changes with age. And as we grow old or we age towards advanced stage, then our BMRs are going to change. And we constantly have to be aware about that. You cannot keep on feeding yourself 2,500 calories for a sedentary lifestyle when you are 50 plus, when your BMR may be around 1,300 calories. So you yourself are gaining those extra calories on a day-to-day basis. You are not putting in activities. So that is going to sit on your trunk. Truncal obesity will come from those extra calories. So there are 3 important things in the diet. The diet has to be disciplined, the timings of the diet, the volume distribution of the diet in a day. Then thirdly, the components of the diet, carbohydrate, fat, and protein. So traditionally, 50% of your calories should come from carbohydrates, 30 from fat, and 20 from proteins. So that balance you cannot change. You cannot change the timings, and you cannot have shortcuts in your food. You cannot go to the supermarkets and get ready to eat food because those food items are prepared with increased shelf life. See, in your own house, chapati, if you prepare in the morning, next day it will stink in this season if it is left outside. So natural shelf life of that chapati is less than 24 hours. Now, ready to eat food, if it is packed in a particular package, it comes with the package instruction that the shelf life is 3 to 5 days. So they have done something to increase the shelf life. The season is the same, the atmospheric factors are the same, but the product is going to last long because there are trans fats in it. And those trans fats are bad for you. So those are the ones which are culprits of excess fat deposition into the liver. Adipose tissues inside the organs will increase if there are trans fats. And
sorry, go on.
just one last thing, all trans fats will be there in all the food items which are very attractively packed. So all these items which are ready to eat and they're packed in a nice manner in the supermarket should be avoided. You should stop going to that corner. And obviously all the fast foods, because that will have too much of fat in your diet.
One question to you. No.
Point.
Okay.
So I'm sorry about this, but if you just throw back our attention to the lunch we had, if you look at American conferences, the maximum lunch that you will get is a bowl of salad, 1 fruit, and maybe 1 sandwich. And I think it is time for us to start thinking of that. The food was fantastic, okay? I'm not denying it, but this is what we get used to.
No, but I was also surprised at the same time when I asked, where is Dr. Uday Phadke? Somebody said he's at lunch. One quick question to both of you, and I think you can also answer. What is this intermittent fasting and what is this keto diet? Does it really help to regress the metabolic syndrome?
Okay. So as far as intermittent fasting is going, because that's the flavor of the season, there is evidence about intermittent fasting. It is not new. It has been existing for a very large number of years. And the whole idea is that you eat with gaps in between and it helps. The only problem there is that you need to eat less as well. So I think some people believe that if I can eat what I like, if I eat twice a day, that's hunger. There are different kinds of intermittent fasts. So you can say I'll eat at 8 in the morning, 8 at night, or even more rigorously, I can eat 8 morning, 2 p.m. and nothing till 8 a.m. tomorrow. Then there is something called, which some of our ancestors used to do, 2 days of fasting. And fasting doesn't mean eating khichdi and all that kind of thing. Fasting means langar, nothing, zero. Only liquids and pani and tak. So that is also a form of fasting. Jains have another form of fasting where they eat alternate day. And I have seen my patients losing up to 15 kilos of weight in 1 month when they did this. So you are aware of this. So they just eat 24 hours, nothing for 24 hours, and then again for 24 hours. So it is again intermittent fasting. Whatever said and done, it still remains that if you use a low calorie diet, that is still the best way to lose weight. And as she said, pay attention to timings, no late meals, no processed food, no trans fat. As far as keto is concerned, the second part, keto diet means extreme glucose reduction in diet. So by reducing glucose in the diet, you allow your natural fats to break down as alternative fuels. And keto acid is a form which can be utilized by many body tissues except brain. You lose weight rapidly. A lot of people report extreme degree of distress, mental, that they are very uncomfortable when ketos are done because the brain is craving. Ketos are good to kickstart weight loss, not very good for long-term basis, difficult to follow in vegetarian diets, and overall not palatable.
And probably to some extent atherogenic also.
Yes, very much so.
So you may reduce metabolic syndrome, you may reduce weight.
Add something else.
So that is also to be understood very well. That
But there are some theories which say that ketones now are the super fuels, particularly for heart. So a heart muscle actually does better on ketones rather than glucose. So a person who is eating less will do better in terms of heart, especially when you're reducing glucose. So glucose is the new poison, more than fat.
correct, correct. One question to you, Dr. Sheetal. You mentioned in your talk about a lot of reports coming from ultrasound clinics, from radiology clinics, from hospitals, various places. There is some fatty infiltration of the liver. There is some fatty involvement of the liver, but somebody tells them, don't worry about it. You can ignore it. No?
They write the description and below they say ultrasound is normal.
Correct. So I would want you to highlight this with a specific reference to lean NASH.
Basically, as I said in my talk also, 30% of the
What is the
general
full form of
population,
NASH for all of us?
non-alcoholic steatohepatitis.
Okay.
So 30% of the general population, it will not be exaggeration if I say they have some amount of fat in their livers. Okay, so the percentage is that high. Now there is, as I said, that I strongly believe that is the culprit for the entire metabolic syndrome. In times to come, maybe we will find evidence also for that. That's not so important as much as the point is important that it is beginning of metabolic syndrome somewhere. So it cannot be ignored. Now, when we say that non-alcoholic fatty liver disease is because of non-alcoholic state, one has to remember that there are certain other factors which also induce deposition of fat in the liver. Alcohol is one. Secondly, certain drugs, especially methotrexate and some of the chemotherapeutic agents, are known to cause deposition of fat in the liver. Then there are certain other illnesses like Wilson's disease or hemochromatosis. There also you will get fat deposition in the liver. Some of the autoimmune liver diseases, you will get fat deposition in the liver. So it is important for a physician or a hepatologist to look into why there is deposition of fat. One cannot just take it that it is non-alcoholic fatty liver disease. And as I tell my patients that 30% of the general population has fatty liver. Now, the amount of alcohol people consume in our country is also phenomenally high. Youngsters, males, females, everybody, even women have started drinking alcohol pretty high amounts. So there is often more than one factor for that fatty liver. So all those factors have to be addressed. Just finding fat is not going to be enough. So all that is equally important. So just ignoring that fat in the liver is definitely not on. And whether it's a child or middle-aged person, a young adult or old, for everybody it is important. Because mind you, once the fat deposition starts in 7 to 8 years or 10 years or 15 years, as per how bad you are in fasting your metabolic issues, you will produce liver disease or the end organ problems because
Absolutely.
of the metabolic syndrome.
Yeah.
So it is in your hands
Yeah.
how to control.
You just mentioned about fatty liver, obesity, childhood. Anything to say about pediatric obesity or a childhood obesity?
Frightening levels.
Mhm.
In cities, particularly in North Chandigarh, 40% of children are obese, not just overweight, which means beyond a particular BMI. And all of them are sitting on the edge of developing adult type 2 diabetes.
And can you also make a comment about the changing lifestyle which is responsible? Can you make a comment about the racial component also being responsible?
See, the racial component is always there. So Indians, as a rule, have this tendency to put on central fat. By birth, also, you know that they are more adipose than their Western counterpart. That means the percentage of body fat is higher. And the lifestyle that is promoted is outrageous. So, I mean, you feel so sad for the parents when they say that they don't eat anything. And if you just sit and take a quick dietary recall, they're eating out 3 times a week. It's so disheartening to tell them that, you are just overfeeding your child. I still remember one quick incident where I'd seen a child who was obese. They came from a very medium or in fact low medium social class. And once they understood, they just quietly went away. 3 years later, this guy comes in again with his son and he asked me, do you recognize him? And this was a tall, fit, very heftily built guy. And he said, the moment you explained to me what the problem is, I sent him to my brother's farm somewhere in Solapur district. I took him out of school and made him do menial labor. And now look at him. So this is extreme. You can't do that. But the point is that you can do it. It is possible to do it. Many parents themselves are so indulgent that they party so often that they believe that their children also deserve the same.
Absolutely. And I think addiction to variety of gadgets,
Yes, absolutely.
non-adherence to the, exercise
Exercise.
is.
So,
Certain people who are they don't have truncal obesity, they are quite lean, their BMIs may be in the normal range, but still they will have fatty liver. And here the genetics play important role, that there are certain genes which are identified which are culprits for deposition of early fat into the internal organs. So but those are the unfortunate people who are blessed with bad genes. But if their lifestyle is good with all those bad genes, they will still prolong this illness, because this illness has a lot of factors which are correctable. And that's the, the brighter side of the whole problem. People have to just adhere to good lifestyles. That's all. And all is needed is good exercise, weight control, and diet. Looking at your diet.
Manan, do you want to say something about?
Yeah. So besides the proteinuria, blood pressure, diabetes, besides affecting the liver, obesity is also known to cause glomerular diseases. So obesity related glomerulonephritis is for real. So the adipokines, leptin, and all those things secreted from the adipose tissue has an effect on the glomerulus. And these all patients present with proteinuria and have rapid progression of CKD. So it is called ORG, obesity related glomerulonephritis. So that can also in future become part of the spectrum.
I think Dr. Chajed had a quick question. What about meal replacement therapy? Like Amway, Herbalife, etc.
Don't even go that way. It's rubbish. All of them. There is another So it's good that you brought that up. Many of them, instead of using glucose, you will see that there is no added sugar. They use fructose. And if you look at fructose metabolism in the body, there is no way to take fructose into the glycolytic pathway. Fructose is converted to fat. So even these high fruit diets, people say that for the next 7 days, I'll eat only fruits. It's ridiculous, because that's also one cause of fatigue, excess fructose. And this was studied very well in the US when fructose became a very popular sweetening agent. And it's not at all. So meal replacements are a no-no, except for short-term kick-starting something if you want, not on a long-term basis.
At the same time, how these calorie counters will be a big help to many of these parents and children if they keep
There are
Very
good apps. You can take photographs and it will give you a calorie count. So that's pretty good. But ultimately, Dr. Chajet, it is common sense. What, as she said, what looks good and what tastes good is clearly bad. So you can take that as a thumb rule. Simple is healthy. Anything rich and lovely and tasty is not so healthy.
And another thing.
So basically, tell us, how do you suspect? What are the tests that you do? And how do you come to a conclusion that somebody has metabolic syndrome and you need 1, 2, 3, 4, 5, 6 treatment?
So as I said,
all of you can participate in that.
The best ways are to look at sugar, lipids, more than 100, post-meal or post-glucose more than 140, HbA1c more than 5.7. Look at lipids, look at liver functions clearly, and look at truncal obesity. You measure the waist circumference.
Where do you measure the waist?
So the waist circumference is measured at the highest point of the superior iliac spine, anterior superior iliac spine.
There or in between the rib cage and...
No. So you can do that, but the best way is to measure it at the top of the ASIs. That's a standard method of measuring and following up the waist circumference. The Indian values say waist should be less than 90 in men, less than 18 women. The treatment is essentially lifestyle. But after lifestyle fails, you can use metformin. You can, of course, metformin is not the gold standard. You can use, if there is a very high risk of ASCVD, you can directly use SGLT2 or GLP-1 without using any of the other drugs. So glitazones are good. Glitazones are extremely good for fatty liver. But weight-wise, glitazones put on weight. But they are good. But they are good drugs and they should be used carefully. I would not recommend a general use of glitazones. They have a specific place. As far as treatment of lipids are concerned, we don't necessarily treat. Triglycerides are extremely sensitive to calorie loss. From 500, you can get down to 105 days, literally. It's that sensitive. HDL is the troublemaker. Different trials up to now have looked at HDL elevation by drugs and has not succeeded. In fact, some of the drugs which tended to raise HDL up to 80 and 90 resulted in very high mortality. So we don't use those drugs. The idea still remains regular exercise and frugal diet. Somebody had said that alcohol is good for HDL. It's not true. That the real protective HDL, which is HDL2, buoyant high density, does not increase with alcohol, although total HDL may. But all of this together, and then if you need, then of course drugs for any of these. But chiefly it is about changing central fat, increasing exercise so that muscles pick up more glucose from the blood and start becoming more active, and reduce insulin resistance in general.
Cases of fibrosis we were just discussing a while ago, one may use some of the drugs. So the drugs which have gained some sort of evidence is vitamin E is one of them. Then some of the pioglitazones and sarglitazone, these are certain drugs which are now coming up big way. But these are again the message is it is not for somebody who has SGPT and OT of 50 and doesn't have much of a problem, just little deposition of fat in the liver. And it is not substitute for change of lifestyle. Lifestyle remains the mainstay. But only for some people who are going towards cirrhosis, maybe you can curtail that progression to some extent.
So, Manan, I think you should address this gym people and their diets. Because these people often go to gyms. And there they don't consult a nutritionist. They consult a gym instructor who has a vague idea about diet. And those people come to him.
Yeah, so most of them start on protein supplementations, creatinine supplementations, and that is all known to cause elevation in creatinine. Because if you are going to consume a creatinine, it's going to cause metabolism. The acid load is going to go up on your kidneys, and eventually it will manifest as increase in creatinine values. So the message is that you don't need to take very high protein intake to get into better shape. You can do it just by regular aerobic exercises and some toning of the muscles. You do not need to supplement it with additional proteins.
I think
20% of the calories to be consumed from proteins. So it is hardly any, for a 50 kg, it may be around 40 grams. So remember that it's less than 1 gram per kg. And that's hardly anything.
These all bodybuilders go on a crazy diet. They'll have a lot of eggs in the morning, in the evening, and they'll to top it up, they'll take whey proteins, creatine supplementations, and the protein intake just goes way top.
absolutely. I think with that, we have come to the end of the discussion about metabolic syndrome. It is important. It is very commonly seen in India. And I think Indians are cursed with having this particular problem. I will probably now hand over the proceedings to you, Dr. Sharma, because we want to wind up and want to thank all of you, IMA and Sahyadri Hospital and all these people. Thank you very much.
Thanks a lot. Excellent discussion. She just mentioned, but even I wanted to say that those gym powders do cause endocrine disruption, I think, to some extent.
Endocrine disruptors which we don't even know about, honestly.
Yes, that's what.
All the lentils, I can answer that. All the lentils and all the dals have proteins, but they have plenty of carbohydrates with that. So don't go by the idea that they have fiber. If you take it with their chest and you sprout them, then only that fiber will remain. If you use split dals, then they're polished. So, whole grain will definitely have some sort of. They are good. And if they're sprouted, they are better because they will also preserve vitamins.
Thank you.
You have to calculate every legume will have different proportion of carbohydrate and fat and protein in it. So if you are saying that the green peas, for example, you are going to have half a kilo of green peas, they will give you more carbohydrates and less protein. Yes, but then you can't lose the balance. You can't lose the carbohydrate like chapati.
That's true. IMA Pune wishes to thank Sahyadri Hospitals for today's CME. It was an excellent CME and a nice interactive session. I would like to thank on behalf of IMA Pune all the faculty for their talks. Special thanks to delegates who joined online and who are present today. This platform was provided by DigiShield. So IMA Pune thanks DigiShield. IMA Pune wishes to thank Mirajkar for audio-visual arrangements. Special thanks to all past presidents of IMA and managing committee members who helped and gave their guidance for today's program. Though he mentioned that today's lunch that was not needed though, but it was very delicious. So IMA likes to thank Shreya Caterers for the lunch, but next time we'll keep this point in mind. And special thanks to office staff of IMA Pune. I request now all the panelists and everybody to come on the stage for a group photograph. Dr. Sheetal.